Okay. Also, good morning, everyone. Welcome you to the Vietnam National Congress of Cardiology, and it is the sessions about exercise and cardiovascular disease. And we'd like to introduce Professor Thomas Allison from Mayo Clinic, Rochester, and Dr. Yoti Zhu from National University Heart Center, Singapore. So Dr. Allison and Dr. Yo, thank you so much for joining us today.
Yes, a pleasure. Thank you.
Yes, so we know that sport cardiology is very important as many people start training and some of them living with cardiac pathologies. So we do hope that our sessions will bring some essential information, not only for cardiologists who have patients who wants to training, but also for some people who heart patient who really want to train regularly. So to start with, I would like to invite Professor Thomas Allison to present his lecture about exercise prescription for patients with cardiac pathologies. Thank you, Professor Allison. Can we start his video, please? Không có tiếng. Bắt đầu đi ạ.
Hello, I'm Dr. Tom Allison. His cardiac disease. He's status post-coarctation repair with no significant residual stenosis. He has a dilated stable aortic root and a dilated stable ascending aorta. And the root is 48 millimeters and the aorta is 41 millimeters at mid-level. You can see he has a bicuspid aortic valve with fusion of the right and left cusps. His echocardiogram shows a severely enlarged LV with preserved ejection fraction, confirms the fusion of the right and left cusps of the aortic valve, and there's moderate to severe aortic regurgitation. His exercise test results show a peak VO2 of 51.5 ml per kg per minute, which is actually 126% of predicted. Quite good, but maybe not good enough to run the Boston Marathon quite yet. He gets a normal heart rate response. His blood pressure is within the normal limits, although a little to the high side for a man this age at peak exercise. Negative for ischemia, no significant arrhythmias. You see his VO2, that's the green line here, it increases in a very normal fashion with exercise, but because of the aortic regurgitation, his oxygen pulse, which is the analog of stroke volume, does not increase throughout the test, but rather shows a plateau during heavier levels of exercise. Now, let's look at some general principles. So most any patient can safely perform light exercise, stretching, normal paced walking, light weight training, and many positive benefits are recognized even at low levels of exercise. The current guidelines, which are cited here, suggest that moving more and sitting less benefits nearly everyone. Guidelines exist for the management of many cardiac diseases. For example, here's the ACC, AHA heart failure guideline. And these guidelines may include statements about exercise training. Another source of information are the 2015 guidelines for sports participation. These can also serve as a basis to help guide exercise training. Now, these guidelines are based where available on clinical trials, case series, but frankly, mostly these are expert opinion as there are few clinical trials or large case series with athletes with different cardiac pathologies. So, restriction from competitive sports should also disqualify patients from high-intensity training, where allowing patients to participate in certain more restricted or modified sports should allow them to exercise in a similar fashion. Some cardiac pathologies qualify for cardiac rehabilitation. Now, eligibility to some degree corresponds to documented benefit to exercise. We can't say that the guidelines are keeping up with all of the current research and that everyone who would benefit from supervised exercise qualifies for reimbursement. And then, of course, there are some patients that really don't need a supervised exercise program. So even though they would benefit from it, they're not required to be in a supervised cardiac rehab program. And for example, coronary disease, yes, for cardiac rehab. HOCM currently is not a recommended indication for cardiac rehab. Key steps in the prescription of exercise for patients with cardiac pathologies. First of all, we need to assess the risk for sudden death. And that may be with exercise test, Holter monitor, other ways of looking at that. We should understand the potentially adverse hemodynamic effects of exercise. Will exercising potentially, particularly exercising at a high intensity, make this condition worse? And then thirdly, we determine the exercise capacity. Now, sometimes higher fitness may equal higher risk. People who are more fit in a peripheral sense can go out and push themselves harder, and they may then get into trouble from a cardiac sense. So this is a slide that I will come back to, the scope of exercise prescription. So first of all, you have unrestricted exercise. People can exercise as long as they want, as hard as they want. They can do high-intensity interval training. They can exercise every day if they want. They can add resistance training and competitive sports. And these programs will produce weight loss and risk factor control. You'll see significant improvements in peak VO2, increases in LV mass and RV size, and reductions in the resting heart rate. And again, not all of these changes may be desirable in all cases with cardiac pathology. Now, the modified program, we suggest exercising up to an hour at a somewhat lower intensity. High-intensity interval training can generally be performed, although there might be exceptions like patients with chronic atrial fibrillation. Frequency, at least 3 days per week, but probably best to take at least 1 day off a week. Resistance training should be modified. No high intensity, no Valsalva. Competitive sports would be low intensity, golf, bowling, but not running the Boston Marathon. Weight loss, risk factor control, some improvement in VO2, and some reduction of resting heart rate may be seen. In restricted program, we're talking about short periods of exercise at a lower intensity. You can't do high intensity interval training, but you could do low intensity interval training, meaning walk for a while, then rest, walk some more, then rest. Frequency, 1 to 3 times per day, since your intensity is low and your duration is low. Competitive sports, no. Resistance training, low intensity. This can produce weight loss and risk factor control without any exercise-induced cardiac remodeling. So let's go back to our case, the bicuspid aortic valve. Now, he would not be covered in a cardiac rehabilitation program unless he'd had recent valve surgery. There's a broad spectrum of disease, including the valve. Is it competent, insufficient, or stenotic? And the aorta. Is it normal, enlarged, and is there underlying connective tissue disease? Concerns for this patient might be accelerated enlargement of the aorta, LV enlargement if there's aortic insufficiency, and syncope or sudden death if there's significant aortic stenosis. Potential scenarios: normal valve function and normal sized aorta, less than 2 standard deviations. No restrictions on exercise or competitive sports. Yearly evaluation to detect new onset heart murmurs, and a one-time evaluation to exclude coarctation. With aortic stenosis, and here's a little guideline for aortic stenosis severity by Doppler echocardiography. No restrictions for mild AS, but again, the same yearly exam, Doppler echo, exercise test to evaluate possible progression. Moderate AS, we do not recommend high dynamic or static demanded competitive sports. So moderate AS, we would not recommend the Boston Marathon. High intensity training and heavy resistance training are also restricted. So this patient has the modified exercise program. Severe AS is the low intensity or restricted exercise program. What about AR? No restrictions for mild AR. Moderate AR, no restrictions if asymptomatic, and that should be confirmed with an exercise test. For severe AR, modified exercise training if asymptomatic, and restricted activity only if symptomatic severe AR. And again, I provide you with a little table here and reference for determining the severity of AR. Potential scenarios with the enlarged aorta. So if the diameter is less than 2 standard deviations, no restrictions. 2 to 3.5, we go into the modified program, and there should be low risk of bodily contact. With a diameter greater than 3.5, we're in the restricted activity program. Marfan's or other connective tissue disease, no exercise training, restricted activity only. Exercise prescriptions can also be developed for patients with other cardiac pathologies by a similar process. And I'm not going to go into each of these in this lecture, but you can walk through it, and maybe we'll have some future lectures on other forms of cardiac disease and specifically how to prescribe exercise for them. Let's review the key steps. Is the patient at risk for sudden death? Are there any potentially adverse hemodynamic effects of exercise? What's the exercise capacity? Where does the patient fit in? An unrestricted program, a modified program with perhaps some low-intensity competitive sports, or a restricted program with only light exercise and no competitive sports. Even the restricted program can have some significant benefits for the patient, although correcting the cardiac pathology surgically, if that's possible, is probably the better option, or an option that should be pursued at some point. So I have 4 take-home points for you. Number 1, virtually all patients can become more physically active. The mantra is move more and sit less. Number 2, high-intensity exercise training and even competitive sports are permissible in many asymptomatic patients with mild to moderate cardiac disease. Number 3, in asymptomatic patients with moderate to severe cardiac disease, we should shift to moderate intensity exercise training and eliminate all but the lightest competitive sports. And finally, in symptomatic patients with severe cardiac disease, there should not be exercise training or competitive sports, but these patients can perform restricted exercise. They can move more and sit less, and then hopefully they have a correctable lesion that can be sent off for repair, and they can move up to a higher level then of exercise training and even competitive sports. We might say it's a matter of which dog you walk. Do you have kind of an Alaskan Husky, a sled dog that you have to run along with? Maybe you've got a hunting dog that's willing to stay on the leash but likes to keep moving. And if you're in the restricted activity category, well, get a dog with short legs. Thank you very much.
Thank you very much, Professor Allison, for your great lecture. So I'm just a little bit curious. Is your patient going to run the Boston? Because if he really wants to run the Boston, he needs to qualify for it, and the qualifying time for Boston means that he has to run 26 miles in under 3 hours as his age. So is your patient can still qualify for Boston with his AS?
Well, he, can you hear me all right?
Yes,
Okay?
perfectly.
Yes, okay. Well, he hasn't qualified yet. The question was he allowed to train and attempt to qualify? So I can't, I can't get him in without qualifying, but we'll see how he does. I've had many patients manage to qualify and run the Boston Marathon. There are also some back doors I've found out. If you make a large charitable contributions or belong to certain medical societies and things, so there's ways to sneak in. But no, he has not qualified yet. The question is whether, we were evaluating, it's whether he could start that training and try to do so.
Yes, thank you so much. And so, Dr. Yu, what's your opinion about the lectures provided by Professor Allison?
Okay, so excellent talk. I enjoyed it very much, Dr. Allison. And I fully agree with you in your points, in your take-home points. So I think in a large part of who we see these days, patients with heart disease, they are actually more on the sedentary portion. So I think it is extremely important to stress the importance of reducing sedentary behavior. And this will actually take up the bulk of our patients and those that we see. And of course, for those who are athletic, as you correctly mentioned, there are different categories and different risk stratification that we should do. I think one point that I would like to bring up is the importance of shared decision making. So in your lecture, you mentioned that a lot of these recommendations are consensus based. So it's quite difficult to carry out randomized controlled trials, to look at outcomes and things like that. So shared decision making based on the patient and the doctor's understanding of potentially a natural history of his or her condition, plus the risks involved, and also involving the coach, the caregivers, the parents, etc. These are very, very important concepts to put through to any competitive athlete who wishes to compete in spite of potentially life-threatening heart condition. So I think that is the main point I would like to bring up.
Yeah, and let me just second that. Our famous Mike Ackerman at the Mayo Clinic, he's fond of saying that to disqualify takes minutes, to counsel and come to shared decision making and manage the risk takes hours. And so the physician, the clinician must be willing to commit the time and the effort to do this, and to say, oh, you have aortic stenosis, no exercise for you, is a very simple and easy thing to do. But the right thing to do is to educate, explain the risk, and I just had several cases of this week that, I had a patient today who had a distal left main and proximal LAD disease. He passed his stress test, no unstable arrhythmia, no ischemia, his ejection fraction 65%. But I told him, just because you can resume competition doesn't mean you have to. And you talk with your spouse, you talk with your family, you decide on the importance of these things, and we're clearing you to compete, but we're not forcing you to compete again. That's not only the shared decision with me, that's a shared decision with your family.
Yes, exactly. And if I may just add another point, so for these athletes who train competitively, they may have a certain intensity when they train, but when it comes to competition day, with the adrenaline rush, with the crowd support, assuming it is a mass spectator sport, and also you can't control things like weather, too hot or too cold. The demands on the cardiovascular system can be much higher than what they were used to during training. So I tend to get tell my patients to exercise or to even compete at the training pace, and not to try and sprint or go all out.
Yeah, it's interesting that Masters, as you remember, invented the two-step test. This was the first stress test where the patient walked up and down the steps for a few minutes and then had an electrocardiogram. And Masters was in the Navy, and when he performed the two-step test, he always performed them the morning after the sailor was on watch all night. So he would always test his patients in their absolute worst state, so that he would optimize bringing this out. And we can talk a little bit later about your point, but it's very interesting, and I don't know if you allow me to. Well, later we can share the screen, and maybe we'll review the RACER study, in which 10.9 million half marathon and marathon competitors over 10 years' time had a total of only 59 cardiac arrests. So despite what you say, and I agree with you, the conditions are different and all, we still have vanishingly few of these cardiac arrests in these events. And needles are always hard to find in haystacks.
Yes, great discussions. Before we move to the next lecture, may I ask your opinion about, because Dr. Yeo mentioned some of his patients participating in some marathons. So do you think that we need a routine cardiac screening for everyone participating in marathon or half marathon? Routine cardiac screening to see if he has any coronary heart disease, or at least you do the echo or the EKG, or maybe the stress test.
Well, go ahead. I'll let you go first.
No, sorry. I just was wanting to find out if the question was directed at you or me. I think Dr.
Okay.
Allison, you may please take the answer the question.
Yeah. Well, I think the most important thing is everyone should be educated as to the symptoms of heart disease. Now, to take 10.9 million runners over the course of 10 years, okay, and to do, if we do them every year, that's 101 million echoes, ECGs, stress tests, and there were 59 cardiac arrests. That I don't know if we have enough cardiologists to do that. So I would say certain individuals, obviously anyone who having symptoms with exercise, people with family history of sudden death, with family history of significant cardiac disease, with lots of risk factors should be screened. I'm not sure that every 25-year-old healthy man, or particularly woman with much lower sudden death risk, almost all these are men, that every young woman should go out and have an echo and a stress test and an ECG before she decides she's going to join the tennis club or, run a local 10K. So I think education is very important, and trying to funnel the right people in through screening. I know that's difficult to do, but this broad brush approach will utilize a lot of medical resources that, particularly in the current era, might be devoted toward taking care of COVID patients or screening them for cardiac disease. And so I'm hesitant to say everybody should be screened, and then you get into how often do you screen and what's the screening.
What do you think?
Yeah, I fully agree with Dr. Allison, because in this case, most marathons are very popular, with participation rates ranging from thousands to tens of thousands. And if everyone was to get routinely assessed, that would take a very heavy burden on any healthcare system. So I think most marathons nowadays have a simple screening questionnaire. Some use PARQ, for instance, to guide the participants as to whether or not they should consider further testing. So as long as one or more of the questions are abnormal, then it is an indication that perhaps the participant should get assessed before participating in the marathon. And I agree that it is important to educate the participants to be aware, because a marathon is not a small matter. It is a very, very challenging and physically demanding event. So as long as they understand that if they have any kind of chronic illness, if they have any kind of cardiovascular disease, it is their responsibility to actually get themselves checked out before participating.
Yeah, thank you so much. And now I I think I would like to invite Dr. Yu to present his lecture about physiological changes in adults with long-term sport training. Please, teacher.
Thank you very much, Lin. Can you see my screen?
Yeah, perfectly. Go ahead.
So a very good afternoon to everyone tuning in. A big thank you to the Vietnam National National Heart Association for the invitation to speak today. My name is Dr. Yeo Thi Ju, and I am from the National University Heart Centre, Singapore. Today I'll be speaking about physiological cardiac changes with long-term sports training. So, okay, in view of time, today's talk will mostly be an overview because I only have 15 minutes. So I will outline the various aspects of cardiac remodeling with long-term physical activity. I will touch on the impact of age, gender, ethnicity, and type of sport on cardiac changes. I will also go through both electrical and structural changes in athletes or active individuals following long-term activity. And finally, I will reinforce the importance of knowing physiological limits and explain a bit about the gray zone between physiological and pathological changes in cardiac remodeling. So with long-term sporting activity, the heart responds in a variety of different ways. So these include electrical changes that one can see on the ECG, and also structural and functional changes that can be identified with various imaging modalities like echocardiogram or magnetic resonance imaging. And also there are peripheral changes in the circulation with long-term activity. Now you may ask, why is this important? As you can see from the picture below, athletes come in all shapes and sizes. These athletes are all Olympic level athletes, and you can see that there is an extreme diversity when it comes to shape, size, ethnicity, etc. So to date, what do we know about the athlete's heart or the hearts of people who exercise often? We have the most data in adult Caucasian athletes, especially those who engage in endurance exercise. So you can see on the box below, they are usually having bradycardia, large voltage criteria for left ventricular hypertrophy, some T-wave inversions, etc. And over the last few years, we've had more and more data from Black athletes, and we know that there are some unique characteristics, especially when it comes to repolarization changes. We will go into that a bit later as well. Now, we do have lesser data on both female athletes as well as adolescent athletes. And most importantly, for our part of the world, we have very few data on Asian athletes. Now, the type of sport and intensity of training is extremely important in impacting cardiac remodeling. So this figure you see here is the Mitchell classification of sport, and it classifies sports based on two different components: the dynamic component or degree of endurance on the x-axis, and the static component or the degree of strength or resistance training on the y-axis. So the most intense sports are usually those with the highest endurance as well as the highest static components, such as cycling, the Tour de France, for example, triathlons, and some degree of rowing. And in contrast, the least intense sports are those in category 1A, which usually include things like golf and shooting. Now, take note that cricket has recently been reclassified into somewhere in the middle, box 2A, moderate static and moderate dynamic, because a lot of cricketers were upset that they were classified under 1A when there was tons of running and pretty intense sometimes when you watch cricket. So the European Society of Cardiology also has its own classification of sport. This is based on the impact of the sport on the circulatory system, for instance, the heart rate, blood pressure, cardiac output, etc. So the type of sport are classified into skill, power, mixed, and endurance. And you can see that within each category, there are also different intensities. So you can, if you if you do see patients or individuals who engage in a lot of sport, you should be quite familiar with the classifications of sport in order to determine whether the degree of cardiac remodeling matches the type of sport. Now let's move on to ECG changes. So for an endurance athlete or one who engages in endurance sports, you typically see the most changes, and many of them are shown here. So firstly, you can see that there is sinus bradycardia, 45 beats per minute, and also early repolarization changes. Typically, these two are due to the increased vagal tone from prolonged training. In addition, you will see voltage criteria for left ventricular hypertrophy, typically because of increased left ventricular wall thickness. And when the right ventricle size also starts to increase, it comes with the incomplete right bundle branch block. So this figure summarizes the factors that influence the electrical changes, as well as the reasons for these changes. Now, in this most important guideline, I would say in recent years with regards to sports cardiology is the international recommendations published in 2017. So you can see on the left side that there is a whole list of normal ECG findings. So these are expected changes in people who exercise or athletes who do regular and long-term sports training, and they should not require any further evaluation. Due to the interest of time, we will not go through any of the abnormal changes. So taking the table from this classification or the recommendations, these are the lists of changes that you should be familiar with in athletes or people who exercise frequently. So many of them have been shown in the ECG earlier, but in addition, you should also take note that you can expect things like sinus arrhythmia, ectopic atrial rhythm, junctional escape rhythm, first degree AV block, and Wenckebach phenomenon. In addition, certain specific changes, as mentioned earlier, in ethnicity, for example, in Black athletes, they typically have convex ST segment elevation, as well as T-wave inversions up to lead V4. There are also specifics for age. So in pediatric athletes or adolescent athletes below 16 years old, they do have T-wave inversions all the way up to lead V3. So we got to bear this in mind and not investigate unnecessarily. So now we come to some structural changes. This figure summarizes the cardiac remodeling with sports training that typically can be seen on echocardiography. So in an athlete, when you compare it to a non-athlete, you can expect that the LV wall thickness gets larger. The LV size in terms of volumes gets bigger. Increased magnitude of the tissue Doppler indices, increased left atrial size, increased the right ventricle fractional area change, as well as right ventricular volumes. The blue arrows denote a decrease in left ventricular ejection fraction that can sometimes be seen in those patients or individuals who do extreme endurance activity. Now, to explain this in a slightly simpler fashion, you can look at this figure. So again, the dynamic and static components are what you saw earlier with the Mitchell classification. For individuals who engage in more dynamic or endurance sport, you can typically expect both the right and the left ventricles to dilate and remodel. In contrast, the athletes who do more of the static or strength training will get more left ventricular wall thickness and concentric LVH. So why is all this knowledge important? This is because with increased physical activity and increased cardiac remodeling, it encroaches upon pathology. You know, the left ventricular size or left ventricular wall thickness may increase to a level that resembles pathology. And these are four main conditions that we need to bear in mind. So if the athlete's left ventricular wall thickness increases, we need to actually worry about hypertrophic cardiomyopathy. If the size and the volume of the left ventricle increases alongside decrease in ejection fraction, we have to try and rule out dilated cardiomyopathy. If these changes affect the right side of the heart, then we have to check for arrhythmogenic cardiomyopathy. And if there is increased trabeculations coupled with low EF, then we got to think about left ventricular non-compaction. So again, this diagram or figure that you can see is taken from the latest Journal of American Society of Echocardiography, recommendations for imaging in athletes. So the 4 conditions that you saw earlier are mentioned here. In addition, there are more differential diagnoses that are very important to keep in mind if you are someone who sees athletic individuals. So these include infiltrative heart disease in patients with very thick walls. For those with very big hearts, you've got to rule out the possibility of myocarditis or valvular heart disease. And something that can be pretty common in competitive sport is substance abuse and long-term ingestion of, for example, steroids or performance-enhancing medication or drugs. So these are some things that we should keep in mind. So what exactly are the limits that we are talking about? Now let's start with the left ventricle size. So this table shows various cohorts of athletes and their range of left ventricular sizes. So you can see that most of them are actually Caucasian. And in male athletes, typically the left ventricular size does not exceed 60 millimeters. And for female athletes, the left ventricular size does not exceed 55 millimeters. So therefore, if you see an athlete or an individual with left ventricular size exceeding 55 or 60, depending on their gender, and if coupled with a low left ventricular ejection fraction, then you should consider investigating further. How about the left ventricular wall thickness? A similar list of athletes. And again, you see that for the males, the left ventricular wall thickness doesn't usually exceed 13 millimeters. For the ladies, it does not exceed 11. And so if someone comes to you with left ventricular wall thickness of beyond 11 or 13, then you should consider investigating. Now, it is important not to take these numbers and limits at face value because there are always outliers. So you can use these other clues to differentiate between physiology and pathology. This flowchart is taken from the British Society of Echocardiography, but most of the other imaging societies have similar guidelines. So it uses other indices, for example, the mitral E velocity, tissue Doppler imaging, ejection fraction, etc., to help you to make a decision whether this athlete's cardiac remodeling is physiological or pathological. And often, exercise stimulus is recommended to see how the athlete or the individual responds to exercise. Obviously, when there is a very abnormal response to physical trainings, for example, a drop in blood pressure or a worsening left ventricular ejection fraction with very little contractile reserve, then you would think that there is some sort of pathology going on. Now let's quickly come on to the right ventricle. So the right ventricle, is something that remodels significantly in endurance athletes, to the point that if you take a cohort of competitive athletes, many of them would fulfill the criteria for arrhythmogenic cardiomyopathy. So this graph just outlines that a large proportion, both male and female, black and white athletes, have right ventricular remodeling that fit the criteria for arrhythmogenic cardiomyopathy. So what do we do about it? Instead of using absolute values, we try and use values indexed to body surface area. So 19 millimeters per meter squared for right ventricular outflow tract in the parasternal long axis view, or 21 millimeters per meter squared for the RVOT view in the short axis. So if athletes exceed these values, then it should warrant further investigation. Again, there are other indices that you can use to help make your decision between physiology and pathology. And in addition, for those where MRI is available, you can also use the MRI ventricular volumes as a rough gauge. So throughout the last decade, I would say, sports cardiology has improved in leaps and bounds in terms of research. However, one thing that is still lacking is our Asian data. So in athletes around our region, East Asia, there are very, very few studies. And the table that you see you see in front of you is taken from 2014. 6 years have since passed and we are in 2020 now. But I believe not much has changed with regards to echo data. Not only that, ECG data is also lacking. A lot of blanks seen in this table over here. So we should try and aim for our data sets in East Asians. So ever since I finished my training in London under Professor Sanjay Sharma at St. George's University, I came back to Singapore and started the Singapore Sports Cardiology Registry. Now, because of the COVID pandemic, recruitment has been suspended, but to date, we have over 250 athletes so far. And what you see here are some preliminary data that we have submitted for publication, and the manuscript is under review right now. But I think we need more collaboration between Asian countries so that we can have our own data set that may potentially contribute to ECG and imaging guidelines. So I hope today's lecture has helped everyone understand the role of cardiac remodeling in patients or individuals who exercise significantly. Often you should use multimodality imaging and exercise testing to investigate further if they exceed their limits. And finally, we should try and aim for our own Asian data set, because anyway, Asia is the biggest continent, and performance in the Olympics is pretty good, I would say. So we should have our own normative data. So finally, for those who are interested in sports cardiology, you can consider looking at the St. George's Sports Cardiology Master's course. With that, I end my talk. Thank you so much.
Thank you so much, Tiju, for your great lecture. So, Dr. Allison, would you please give some comment about Dr. Yu's talk?
Excellent lecture. Very nice summary. And you went over the important, you said you were giving us an overview, and you gave us a nice overview of what's normal and what's abnormal. The thing I want to focus most on is your call for Asian data, for South Asian data, or Southeast Asian data. Sorry, I think that's extremely important. And I might ask you a question. Do you even at this point have mortality data? I mean, do we know how many East Asian athletes die in sports competition every year? Do we have anything like the racer study, or have we with US or European data, have we tried to tease out the Asian Americans from the deaths?
Okay, so I can only comment on Singapore, where I'm from. So unfortunately, there isn't any specific registry for athletes. We do have a sudden death registry, and there is an Asia Pacific registry for out-of-hospital collapses and sudden deaths, but there isn't enough bandwidth to look into the demographics, whether these people are athletes or not. I think the most information that could be obtained from these data is what the location of their collapse, as well as type of activity within 24 hours. But this data is predominantly held by the emergency physicians. Yeah, so I think the problem is that we do not have these registries set up in place. So there is no we are unable to provide demographic data or prevalence rate or incidence rates of sudden death like the RACER study?
I would guess that they would be quite low. Would be my guess, but we'll have to wait and see data.
Yeah, typically when there is an event, it would be widely reported in the media because of its rarity.
Yes. Since you have time, Dr. Allison, would you please show us you have some data about cardiac arrest during training and competition in the States that you would like to show us? Can you show it now or not?
Yeah, I can share it with you here, and let's take a look at. I have a bunch of screens up, so have to log back in us in. Sorry. Okay, so these are data that we have both commented on the RACER trial. Okay, and so we have over 10 years of all marathon and half marathon races conducted in the US, 10.9 million runners, and only 59 cardiac arrests. Vanishingly small, almost all of them, as it turns out, men. And you can see the reversible causes are largely ischemic heart disease, and irreversible sudden death is largely hypertrophic cardiomyopathy. We mentioned some other things about temperature, thermal conditions. As it turns out, together, 3%, 7%, 10%, maybe 6 of these 10.6 of these cardiac arrests could be environmentally triggered. So largely survivors, resuscitated cardiac arrest is ischemic heart disease, and non-resuscitated cardiac arrest is hypertrophic cardiomyopathy.
Oh, that's great. That's good to know. So based on the data, the risk of cardiac arrest is pretty low, even during a marathon. So if I have a cardiac patient with previously stented in the coronary artery disease, you can call it chronic coronary syndrome. So should I recommend them to do some training like running or cycling? Is it safe for them? What do you think?
Do you want to answer that, or is that to me? I've been talking. So describe the patient for me again, okay?
Okay. The patient has acute MI and a stent is implanted already. And after that, patient is symptom-free and he wants to start training like running or cycling. So what should we recommend him?
Three phases. Number one, he goes to cardiac rehabilitation. Number two, when he finishes cardiac rehabilitation, he begins to train harder, but in a safe environment, in a gym where there are other people, on the treadmill in his home, close to his home, within cell phone coverage with a training partner. And then after he has completed that phase of training, then we perform a maximal stress test. We check his ejection fraction, and then we, at that point, decide if we're going to let him or her go on and compete in the event. So there's a 3-phase process: the cardiac rehab, enhanced training in more safe environments, and then finally release back to competition. I'm actually in some ways less worried about the patient who's in a race. I had a patient earlier this week who had triple cardiac arrest, three separate shocks after completing the Birkebeiner cross-country ski race. Now, there were thousands of people there, many physicians, there was an ambulance. Now, if that had happened while he was training, he'd be dead. And then he said, in the summer, I like to go kayaking. And he goes out into the wilderness of Minnesota, and he goes kayaking 20 or 30 miles out through these chains of lakes. There's no cell phone coverage. There's nothing out there. So I'm frankly more concerned about that than I am in a kayak race where there's lots of spectators and, you know, the things are being monitored. So I think personal safety is important. Again, just anecdotal, an interventional cardiologist who was on a 50-mile bike ride collapsed and got 15 minutes of CPR without brain damage. So his training partner was an anesthesiologist. So if he was training with anyone else, he either would have died or would have suffered anoxic brain damage. So it's not just being in the competition, it's the training and where you're training and whether you have any access to help if anything does go wrong.
Yes, I think it makes sense. What do you think, Dr. Yuo?
Yes, I fully agree. It is the process that the patient needs to be aware of. They cannot expect to go straight back into, for example, marathon running soon after myocardial infarction. So cardiac rehabilitation is one of the most important aspects that will help these patients. And if I may also share my screen, I did my cardiac rehab training at Toronto under University Health Network. So, okay, can you see my screen over here?
Yes, perfect. Go ahead.
So I was at Toronto Rehab Institute where Dr. Terry Kavanagh first built his program. And you see, as early as, I believe this is 1974, he actually studied 8 patients who all had myocardial infarction. And in those days, there were no stents. So there was only thrombolysis, or rather streptokinase and things like that. So in spite of these, the patients all finished running the Boston Marathon. And the only one who did not was because of musculoskeletal and non-cardiac reasons. And that just shows you that running a marathon after MI is definitely possible. And in fact, the group did one step further to train a heart transplant patient about 10 years later. So he actually made news worldwide. So even a heart transplant patient can run the Boston Marathon. So, I mean, the sky is the limit. But of course, the caveat is that you should have very structured, progressive training, or for which cardiac rehab is one of the main factors that you should consider.
May I throw a couple anecdotes in there? So I knew Terry Kavanagh well, and was in Toronto, and in fact, indirectly, Terry Kavanagh was responsible for my getting into sports and exercise cardiology, and that's a long story. And I've also trained people to, after heart transplant, to run marathons. But interestingly, for the young people in the group, we need a perspective on this. You know, in 1974, all infarcts were transmural. There was no rescue, there was no angioplasty. There were no statins. So all of these individuals had a transmural infarction, most of them anterior. They had residual ischemia. They were all on beta blockers. Aspirin really wasn't being used yet, and there were no statins. So today is a cakewalk to run a marathon after getting a stent or a bypass surgery compared to 1974. Now, there's also, we talked about shared decision making. there's also the commitment of the athlete. For example, I have a number of athletes said, you know, you can continue to train and compete if you're 100% compliant with your statin. You take the 12.5 milligrams of metoprolol, and that's as low as we're going to go. You take that and you come back every year and have a workup with us. So the patient has to make commitment too. We do this especially in the cases of patients with channelopathies who have had cardiac arrest. An AED at courtside, no energy drinks, complete compliance with beta blocker, annual evaluation. So the athlete has responsibilities also to the physician who is clearing that patient.
That is great. Okay. So since you have run out of time now, Professor Allison, would you please summarize a little bit about the knowledge about sport cardiology so that our colleagues can apply in clinical practice?
Summarize sports cardiology?
I mean the main point of that.
Okay, all right. Well, there's two parts of sports cardiology.
Yes.
Now, and we've had two views on it. The way we do sports cardiology, we don't have a lot of clients where we screen whole athletic teams. We basically see patients, individual patients who have had cardiac disease and want to continue sports. So these are clinical cases. There's a form of evaluation. There are guidelines in terms, and basically with ejection fraction, cardiac performance, arrhythmias, symptoms, and then there's a shared decision-making process. So you have to understand the specific cardiac pathology, whether it's like the case I presented, adult congenital heart disease, or the case you asked me about with coronary artery disease, or whether it's an underlying long QT syndrome, for example. You understand the dynamics, the risks of each case. You understand whether exercise could have adverse effects on prognosis. And then you evaluate the fitness level to make sure that that person has adequate fitness for the sport that they participate in. So it's a three-step process: risk, potential for adverse effect on the progression of the disease, and assessing the fitness level. Then, as we've discussed, there's shared decision-making. You make a commitment, the patient makes a commitment, the family makes a commitment to continued participation. I'll give another quick example. A woman, 44 years old, playing in an all-men's hockey league in Canada, had a spontaneous coronary artery dissection. Now, she has 3 children, and she's a professional. So her goal was, I've got to play hockey again. And of course, my goal was to slow her down and get her to reconsider whether this was really the best option for her. And in the end, by having her postpone her return to playing hockey, she decided not to return to play hockey, which I think in the case of SCAD, what was the correct decision for her.
Yes, that's
so. Is that a good enough summary for now?
Okay, so thank you so much, Dr. Thomas Allison and Dr. Yo Tiju. I do appreciate your time and to participate in our sessions, and I hope to see you again in our next sessions and to listen to a lecture and discuss with you. Thank you so much. Thanks a lot.
Thank you very much.
Thank you. So yes, thank you so much.
Thank you very much.
Bye for now.
Okay.
Thank
All
you.
right. Bye-bye. Good.
Bye-bye. See you. Bye. Okay, hello everyone. Welcome you to our sessions on aortic valve disease. So I would like to introduce the chairperson today, Dr. Michael Lee from Queen Elizabeth Hospital, Hong Kong, and Dr. Paul Cham from Heart and Vascular Center, Singapore. Dr. Cham used to be my supervisor when I was the fellow in Heart Center, Singapore. So, and we have Dr. Michael Sternberg from USA, but he's not here yet. But I think we can start now. Hello, Michael. Hello, Paul.
Yes.
Very nice to see you.
Great to see you, Lin.
Morning, Lin. Always nice to see you again.
Yes, good morning. Okay, so may we start now? Michael, can you start?
Yes. Okay. Let me first make a very brief introduction because aortic valve diseases have been on a very rapidly growing trend because of aging population. And TAVI procedure has been the sort of new gold standard for treatment of these elderly severe AS patients. So today we will have 3 talks. Paul, first of all, will start off with some of the local situation. So Paul will talk to us on should this TAVI procedure become routine for all Asian patients with aortic diseases, and then we can have further discussion. Paul, would you like to start your presentation? Thank you very much.
Okay, thank you, Michael. Let me share my screen. Can you all see my screen now?
Yeah.
Yes, we can.
So good morning, everybody, and thanks once again to the Vietnamese Heart Association for inviting me to speak. I think this must be the 4th or 5th time already. It's been a long time since, and it's always nice to see Lin, one of our fellows before in Singapore, and of course the main organizer Guang, who was also my good friend, and we were international fellows together. So today's talk is should TAVR, as we know it, become routine for all patients with aortic diseases. And I'm going to take you through mainly the randomized data to see where we are now. I think for this therapy to really expand further, we'll need class 1 data to compare to the surgical aortic valve replacement. So we know that is 40, 50 years of aortic valve replacement history that it's been a cure for aortic stenosis, a very fatal disease, but there is a good cure. And this has been performed very well by surgeons. So for TAVR to be able to replace this, it must really be proven that you can be equal to this or better than this in the long term. So, and what do the data so far tell us about TAVR? And let's go back to the inoperable patients. And you can see that this was the first trial using the balloon expandable. This is already the first generation valve. We are now on the third generation SAPIEN valve. And the first data came out about 10 years ago, looking at inoperable patients, randomizing to TAVR versus medical therapy. And you can see that for all-cause mortality and 1 year, it was highly significant in favor of TAVR. And we knew many years ago that this was sustained out to 5 years. The other way to look at it is that the median survival for a patient without undergoing best medical therapy, including valvuloplasty, was only 11 months. But if you had this patient undergo TAVR, then he would live almost three times as long at 30 months. So it is now proven for all patients who are not fit for surgery. So, but that's only a small group of patients, and we really need to know the other risk groups. And subsequently, the next studies that came out looked at patients at high surgical risk. And again, the balloon expandable valve was the first one to go, and this was published in 2011, looking at 700 patients, randomizing against conventional surgery. So we knew again that it was non-inferior at 1 year, and this was again sustained out to 3 years. For all patients undergoing TAVR versus surgical AVR, there was no difference in terms of all-cause mortality, and also no difference in terms of all-cause mortality or stroke. So there was also another parallel device that was coming out at the time, and a very different design, as you can see, self-expanding frame that doesn't need a balloon to expand, and using porcine pericardial leaflets. And they also conducted a trial in high-risk patients, randomizing against surgical aortic valve replacement, and the results came out in 2014. Again, we see the same good news for TAVR. In fact, in this trial, there was a slightly lower all-cause mortality at 1 year and also at 2 years. So in fact, it was slightly superior to surgical AVR in this high-risk group of patients using the self-expanding valve. And also all stroke also trended to be less. This was very surprising at the time, because the surgeons were criticizing us that, you're just, smashing the valves and all the debris is being liberated, but yet we saw less strokes as compared to surgical aortic valve replacement. So at this time in 2014, what we knew was that in inoperable patients with severe aortic stenosis, TAVR is superior to best medical therapy, and that includes balloon valvuloplasty. And in high-risk patients, TAVR was non-inferior with the early generation SAPIEN valve, or maybe superior with using the early generation core valve to surgical aortic valve replacement. And these were the publications that came out. You can see the many articles now in the New England Journal of Medicine regarding this field. I don't think any other therapy has had so many publications in the top medical journal as we see with TAVR. But really, we wanted to know, in the bigger population group of patients that we see, the intermediate and low risk patients with aortic stenosis, what were the results when we compared TAVR with surgery? And again, the balloon expandable was first to come out with some data, and this was published in 2016, randomizing intermediate risk patients to the balloon expandable valve versus open surgery. And the second generation valve, you can see here, the main difference was that the introducer sheath was smaller, and that therefore resulted in less vascular injury. And they randomized about 2,000 patients, so a significant number of patients, using both the transfemoral and the surgical approaches, and this includes transapical or the transaortic approach. And this was the results. As you can see, at 1 and 2 years, there was absolutely no difference between TAVR or surgical aortic valve replacement in terms of all-cause mortality or disabling stroke. And I guess these two parameters would be the most important to any patient who wants to undergo the procedure. Either you die or you get a major stroke. This was for the entire cohort, but interestingly in this study, if you look only at the patients who were suitable for the transfemoral procedure, then TAVR was actually just meeting the superior criteria as compared to surgical replacement. You can see a lower 1 and 2 years rate of all-cause mortality and disabling stroke for transfemoral TAVR versus surgical aortic valve replacement. So at this time in 2016, in intermediate risk patients, we could conclude that TAVI using the SAPIEN XT, which is the second generation SAPIEN valve, there was no difference between this technique against surgery in terms of all-cause mortality or disabling stroke. And in particular, in the transfemoral group only, which was about 76% of patients, TAVR actually reduced all-cause mortality or disabling stroke. And again, this was published in New England Journal of Medicine. So now the fourth or fifth paper in the journal regarding TAVR itself. But we have to be careful and don't get ahead of ourselves, because subsequently a paper just published very recently looking at this same cohort of patients now up to 5 years. And we do see that at 3 years, there seems to be the curve seems to overlap, and then subsequently TAVR seems to do a bit worse. And you can see in this study, there was slightly more deaths and disabling stroke from the 3-year mark onwards. And we postulate, now we cannot prove it, but it may be due to the fact that there were still more moderate or severe paravalvular leaks with the TAVR group, and perhaps more untreated coronary artery disease in the TAVR group. Most of the patients in the surgical group would have bypassed anyway. The surgeons usually bypass any artery which is more than 50% narrow, and that may have given them a survival advantage in terms of reducing myocardial infarction. I think importantly, in the transfemoral group, there was no difference, but the transthoracic or the transapical, which is surgical, sort of a surgical access TAVR, they did a lot worse, and therefore the curves diverge after 3 years. And I think this has very important implications in younger patients that we see, especially with intermediate or low risk patients, that we need to be mindful that the long-term data is still quite uncertain. The only thing that I can say is that the SAPIEN XT valve is no longer in use, and therefore we don't really know if the current SAPIEN 3 would have the same issues as what we see over here. Again, the self-expanding valve also were doing a trial in parallel in intermediate risk patients, and this was a SIR-TAVI trial. It was published in 2017, and they looked at 1,700 patients. And this was the third generation self-expandable device, which was recapturable, the Evolut R, and a very low profile sheet. And again, we see that at 1 and 2 years, there was no difference in all-cause mortality or disabling stroke in these patients using the self-expandable valve. And if you look at separately all-cause mortality itself, no difference, and maybe a trend towards a lower rate of disabling stroke for the TAVR group. Again, this is counterintuitive because we are scraping the arch and ballooning the valve, and yet we get a lower stroke than surgery. So again, this trial met its primary endpoint that showed that there was no difference between TAVR and surgery in terms of all-cause mortality or disabling stroke at 4 months, and there was significantly less 30-day stroke and acute kidney injury, AF, and transfusion with TAVR, but surgery had less residual paravalvular leak, and there was fewer pacemakers with conventional surgery. So, but I think this now brings us to the most important group, the low surgical risk patients, which are the biggest group of patients we see with severe aortic stenosis. And let's see what the data tells us. So now partner 3, again, the balloon expandable was just ahead. You can see them randomizing 1,000 patients. Now, the main difference is that they only included patients that were suitable for the transfemoral approach. They've taken transapical and transthoracic out. As you can see from the previous intermediate risk study, they did a lot worse. And in these patients, the mean age has come down to 73 years from about 79 to 80 years old in all the previous studies. And this was just published last year in March. And this is the latest iteration of the valve, the SAPIEN 3 valve, smaller profile sheet, and also with the external skirt, as you can see in the yellow arrow, which will reduce paravalvular leaks. And here we see the primary endpoint of death, stroke, or rehospitalization, highly significant in favor of TAVR at 1 year. So TAVR is superior to surgery at 1 year with this valve in terms of all-cause death, stroke, or the need for rehospitalization. And if you just look at all-cause mortality, it was trending in favor of TAVR, although it did not reach a significance level. But I just want to bring you to the 30-day result. You can see an extremely impressive 0.4% all-cause mortality for TAVR, which is really, really low. And the best surgeons, they will quote 1%, but TAVR has now gone half of that as compared to surgery. And if you look at all stroke, again, the finding that, it's been consistent throughout, a very low stroke rate with TAVR, lower than surgery. And in this trial, it was significantly lower in the low-risk patients. So your 30-day stroke rate is only 0.6%. So that's really, really low. And when you pull all death or disabling stroke, it was also lower as compared to surgery. So the conclusion is that in a population of severe symptomatic AS patients, TAVR using as compared to surgery resulted in the reduced primary endpoint of death, stroke, or rehospitalization at 1 year. And now we complete the loop from patients who could not undergo surgery to high-risk patients to intermediate-risk patients and now to low-risk patients. Seems like the whole risk spectrum of patients are suitable for TAVR. Again, the self-expanding valve was not far behind. They also published almost simultaneously this result last year, randomizing low-risk patients. Again, the average age 73 to 74 years and about 1,400 patients. And this was the slight improvement. They had the Evolut Pro, which is external skirt. Same device, recapturable, low profile, but we're now with the external skirt. And you can see the primary endpoint of all-cause mortality or disabling stroke at 2 years was the same, so it's non-inferior. However, bear in mind this trial they use a kind of a statistical method. The patients were only at 1 year, but they projected the event rate up to 2 years, and this was the result. But if you look at patients at 1 year, the all-cause mortality or disabling stroke was trending in favor of TAVR, but did not reach significance level. And same for the all-cause mortality. And disabling stroke at 1 year, again, we see the same signal we saw with the SAPIEN 3 result. It was in favor of TAVR. So a lower risk of disabling stroke with TAVR as compared to surgery in low-risk patients. And also the need for rehospitalization at 1 year was significantly lower. So again, the trial was consistent. TAVR was non-inferior to surgery for primary endpoint. At 30 days, less death or disabling stroke. Again, we see that surgery has fewer pacemakers and less residual AR, and this may be important when we consider some other factors. So again, another publication in New England Journal for this study. And very quickly, 3 months after the publication, FDA actually approved TAVR for low-risk patients, which means that basically the entire spectrum of patients are now suitable for TAVR. But I think we really have to be cautious because both trials show only short-term outcomes. 1, maybe 2 years. It's not even a 2-year outcome, it's a projected 2-year outcome. And we really don't know how this valve will last. The surgery, we know that most valves will last 10 years. We quote 10 years, but we right now have no proof that this TAVR valve will last 10 years. Valve thrombosis seems to be, it can be something that may worry us in future, and it appears more frequent than the surgical bioprosthesis, at least for the balloon expandable SAPIEN device. As we do younger patients, coronary access after TAVR can be difficult, especially with the Evolut valve because it's a taller frame and the leaflets are supraannular. And this may be important in younger patients who may require future coronary intervention. Paravalvular regurgitation, less of a problem, but I think it's still more than surgery. In the SAPIEN 3 study, in the partner 3, there was more mild paravalvular leak, although the moderate and severe rate of paravalvular leak was the same. But the Evolut study definitely had more moderate or severe paravalvular leak. And we do know that anything more than moderate paravalvular leak may impact on the long-term mortality. So the jury is still out on how this will turn out in long term. And again, there was also more conduction disturbance. Left bundle branch block was more common in both the balloon expandable and the self-expanding low-risk patients. And for the self-expandable valve, the Evolut there was also more pacemaker requirements as compared to surgery. And I don't think we can say that nothing will happen to this patient. The pacemaker is always added comorbidity. They may get infection of the leads. They may need to replace the pacemaker. So again, we don't know how these will turn out in, let's say, 10 years' time. Other indications that have been used, but has not a lot of data. We look at this bicuspid valve is a hot topic, but we actually did this 10 years ago. And there's been many registries that suggest that TAVR in bicuspid aortic valve is feasible and safe in selected patients. And of course, with the 3rd generation valves, the results have improved, but really there's no randomized data. And I think we really need to consider each patient on its own and carefully. And bear in mind that all these bicuspid valve patients are usually younger, and we don't know how these valves will behave in the long term. again, the long-term issue is a concern. And the last indication, the pure aortic valve regurgitation, experience is still limited. I think the problem is most patients with AR have also very dilated roots without much calcium to hold the valve down. And it can be done, and there's been several registries now published about this, but I think patients must be very carefully selected. So in 2020, which are the patients that we should consider with severe aortic stenosis for TAVR? I think all inoperable patients with a life expectancy of 1 year, high surgical risk patients, intermediate surgical risk patients, I think they are good. Low risk patients, I think if they are older, not too young, if they are, in the trial it was average of 73 years old, I think it's suitable. There is still no randomized data for severe bicuspid aortic stenosis. The long-term durability of the valve is unknown. And so the conclusion will be that TAVR is indeed suitable for many, many patients, but really not all patients with severe aortic stenosis, especially younger patients that we may see in Asia. And off-label use for pure AR is really anecdotal and limited. Thank you very much.
Well, thank you, Paul. That's a great overview of the current evidence. I think we might leave the question time until the end. We have 10 minutes for question time at the end. Is Dr. Fintonsberg here?
I did not see him.
Oh, okay. Did he record the presentation before?
Yes, already. So
okay. So maybe we go ahead with his recording. He's talking on what is the role of surgical AVR in the year 2020. Maybe we go ahead and listen to his recording. We cannot hear. I'm sorry, can you all hear? Because I cannot hear. Okay, maybe we try again.
About the role of surgical aortic valve replacement in the year 2020. We have a lot of material to cover pretty quickly in a limited time, so I want to jump in. I think it's pretty well established at this point that the natural history of unoperated aortic stenosis is dismal, with a very poor 2 and 3 survival when compared to those patients that are offered some type of therapy. And I think we need to then start considering more and more what really are the best options, especially in the context of sometimes limited resources. With some of the recent trials, I think it is pretty safe to say that patients that are very high risk or sometimes prohibitive risk may benefit predominantly from a catheter-based approach to their valve, although there is still some inconsistency in that data that is limited by center experience. But the growing debate is really what to do with the intermediate risk and the low risk patients as predicted by their STS risk score, multi-organ system function, and procedure-specific requirements, as well as their evaluated assessment of frailty. But fundamentally, it does beg the question of why would you not want a catheter-based procedure when you consider that open heart surgery is still associated with still pain, discomfort, and complications. And considering all of the marketing that is going involved, TAVR seems to be the way to go. However, I'm not exactly sure, as we will talk about today, that the data supports that this is the best thing for everybody. When we go back to the original SIR-TAVI trial, for which 1,746 patients were enrolled, when specifically looking at all-cause mortality or disabling stroke at 2 years, fundamentally the outcomes between the two procedures were somewhat the same. This served as the basis for some of the non-inferiority conversations that were driving people towards this procedure, thinking that because it was simpler, it was by definition better. And I think it was pretty well established that the quality of life and the recovery for surgery was much more challenging in the first couple of months than catheter-based therapies. However, once the patients got beyond 5 to 6 months and now even extending at 4 to 5 years, the quality of life and the overall performance of these patients is somewhat similar once you go beyond 1 year. And this served as the basis for advocating TAVI in those patients that you had an expected life survival outcome of less than 2 years, and that maybe getting them on their feet sooner was better. However, this does not necessarily apply across the board. In a meta-analysis of over 9,500 patients at 1 year, both intermediate, low, and high risk, one of the things that became clear was that despite all of the morbidity and mortality reviews, that at 1 year, the mortality and rate of stroke really showed no fundamental difference between the two procedures across the board. And furthermore, when you start looking at the mortality outcomes of these patients at 1 year, again, no fundamental difference, particularly in the intermediate risk group, suggesting that both procedures are reasonable. Specifically addressing the question of low-risk patients, this was a review of the randomized controlled data and the propensity score matching studies at the time, almost 3,500 patients looking specifically at the mortality at 2 years. And what they found was there was no fundamental difference between surgical and catheter-based therapies at 2 years with regards to the short-term outcomes and specifically death and stroke. Furthermore, when you start extending this beyond 2 years, the data suggests that there was actually a survival and freedom from major adverse events that tended to favor surgical aortic valve rather than catheter-based therapies. And it is this that we're starting to see where the data converges. And specifically looking at stroke, procedural related, most people, I don't want open heart surgery because they're afraid of stroke. Nevertheless, both procedures are associated with the same procedural related risks. Furthermore, when taking this to the intermediate risk population, a meta-analysis looking at over 4,000 patients and 14 studies had similar results. And that is at 3 years, the curve started to diverge more and more with a benefit both in terms of survival and freedom from major adverse cerebrovascular events favoring surgery when compared to catheter-based therapies. So in essence, the outcomes are similar at 2 years, but once we start getting beyond 2 years, the benefits of surgery really start to evolve. And then we start looking at the evolution specifically of the low-risk trials, whether it's the Partner 3 trial or some of the recent studies in the New England Journal that came out over the past couple of years. And summarizing them, fundamentally, it suggests there may be a benefit-based therapies, particularly in the low-risk patients, but this is only the early data, and it doesn't necessarily translate into all patients. Because in an editorial review of the low-risk trials, one of the things that was brought out were some of the major concerns, specifically highly selective enrollment that may have favored catheter-based therapies. Most studies were intention to treat as opposed to an as-treated analysis. Concerns about the randomization protocol and the enrollment of patients needing concomitant procedures, and fundamentally the significance of the endpoints, particularly only at 1 year. Fundamentally, these were not similar patient populations. And to address this, the group out of Israel presented some of their data, registry data, looking at the outcomes at early 1 year and 3 year, and not only in low-risk patients as defined by STS scores of 0.7 to 4, but also specifically very low-risk patients compared to their higher risk group. And what was quite concerning is that while the procedural mortality was quite low, once you started getting beyond 1 year, the mortality rate in this relatively young, healthy population was somewhat substantial. In fact, in their registry review of over 1,200 patients in both groups combined, the 3-year mortality for the low-risk patients was 20%, and in the very low-risk group, it was over 12.5%, which far exceeds the established benchmarks for surgical options in these patients, suggesting that we may be very cautious about low-risk patients. Furthermore, looking specifically again at the French registry longitudinal study, looking at 27 centers with 2-year data and beyond, some of them showing up to 60 months of follow-up and addressing both approximately 800 SAVR patients. What they found was that there was a significant increase in costs with catheter-based therapies beyond with surgery. In addition, they also found at 5 years for those patients that were still alive, a substantial increase in the need for pacemakers, increased risk of strokes, as well as myocardial infarctions. And this is, as I mentioned, once we start getting beyond 2 to 3 year data. In fact, the mortality in this group was almost as high as 45 to 50% at 5 years compared to 35% in the surgical group, suggesting that there really needs to be caution when applying this. The major concern that patients have related to procedure is the risk of stroke. And while some of the existing study data implies that the risk of stroke after TAVI is somewhat similar, if not lower than surgery, this does not necessarily pan out in some of the CMS data. And specifically looking at admissions for stroke, both hemorrhagic and ischemic, in the full spectrum of cardiovascular procedures, we're starting to see that TAVR outside of the trials is associated with a substantial, if not tenfold increased risk of readmission after the index procedure within 6 months than when compared to other cardiovascular procedures, including surgical aortic valve, cardiac catheterization, CABG, pacemaker, and in fact, the rate of stroke readmissions are even reported to be higher than ventricular assist devices. Obviously, this is a substantial area of concern that needs to be sorted out better. Furthermore, when patients are presented with the options for TAVR, they like the approach of a minimally invasive procedure, and they are told that the rate of permanent pacemaker and paravalvular leaks is much higher. However, the significance of these two events is not exactly completely defined or presented to them at the time. The pacemaker implants and leaks is much higher. We need to really better understand the significance of this. For example, in this one study that was published in the Annals of Thoracic Surgery in 2018, suggested a much worse survival in patients that required pacemaker after aortic valve replacement, either with catheter-based therapies or with surgery, suggesting that the need for a pacemaker independently reduces long-term survival, something that clearly must be presented to the patients when they consider catheter-based therapies, especially when one realizes that the rate of pacemaker implantation has been relatively constant over the years, depending on the techniques. Furthermore, paravalvular leaks, particularly moderate or severe, is not without substantial risk either. This is a review of the PARTNER 2 data that was published in the New England Journal in 2016 that again shows a substantially, if not threefold worse outcomes in terms of survival for patients that had at least mild or if not moderate to severe paravalvular regurgitation. Again, a complication that is incompletely explained and understood at the time when patients are evaluated for procedures. Furthermore, I need to illustrate a very strong word of caution with the growing trend of TAVR in patients that are relatively young. This is a paper that is still under press and will be coming out shortly in the Annals of Thoracic Surgery, specifically addressing the different techniques in those patients enrolled in the congenital heart surgery and adult cardiac surgery databases over the past couple of years. Specifically looking at over 45,000 patients that are in the age group of essentially 18 to 55 that got different types of valves. And I want to illustrate that the rate of persistent stroke was about 1.5 to 1.6 per either in mechanical or bioprosthetic valves, and almost twofold higher in those patients that are undergoing isolated catheter-based valve replacement. Obviously, an area of concern. And just as concerning is the 30-day mortality for those patients undergoing isolated aortic valve replacement, either with surgical therapies or catheter-based therapies. For the predominant number of patients that are getting either a mechanical or bioprosthetic valve, the mortality at 30 days with surgery is on the order of 1.3 to 1.8%. However, again, almost twofold greater for those patients that are undergoing catheter-based therapies. Again, recognizing that as these get expanded to lower risk patients and the desire for minimally invasive procedures, we need to recognize the limitations of the data and that we still need to understand better the role of these therapies. So in conclusion, there are a variety of myths that are associated with catheter-based therapy. Specifically, TAVR patients don't have strokes. We know that that's not true. TAVR patients all get better. That's not necessarily true. TAVR may make money and in fact cost less for the patients, and the French experience clearly shows that to not be true. And there is this misconception that TAVR patients live longer regardless of whether they're low, intermediate, or high risk. This has all led to the assumption that TAVR is better than surgical therapy. However, we still need to recognize that surgical aortic valve replacement is still indicated and appropriate in younger patients, those that are deemed to be lower risk and appropriate intermediate risk patients, particularly those with a life expectancy of greater than 5 years. Now, that's not to say that TAVR doesn't have a role in older patients, higher risk patients, or those with appropriate intermediate risk or life expectancy less than 5 years. Patients with pre-existing or certain high-risk groups such as previous heart surgery, hostile chest, or frailty often drive the decision for TAVR, which may be appropriate. However, as we see more and more, there's patients who frankly just don't want surgery, and it is our obligation as members of the heart team to recognize the limitations of current data and experience, particularly once we get beyond 2 to 3 years, in suggesting that many of these patients would be better served with surgery. Thank you very much, and I appreciate the opportunity to present to this distinguished group, and hopefully we'll have time for questions and answers at the end.
Okay, that's a great presentation from Dr. Fistenberg. I don't think he's online yet, but anyway, we wait after my talk and then see what if he can join us for discussion. So let's finish the third talk. I'm going to, this is a pre-recording. I'm going to talk about the remaining challenges for TAVR in the year 2020. We will have question time after this talk. Can we start my talk, please? Great. Good morning. I'm Michael Lee from Hong Kong. Thank you for your kind invitation and asked me to talk about the remaining challenges for TAVR in 2020. This is my conflict of interest. I'm proctor for the three TAVR companies. As you know, our population is aging. And with the increasing number of aging populations, the incidence of degenerative valvular disease, both aortic and mitral valvular disease, are actually on the increase. TAVR has been shown to be one of the best treatment options for this group of severe aortic stenosis patients. So as the patient are aging, the patients the age becomes higher and higher. The number of patients receiving TAVR procedures actually are also on the increase. It has been estimated that in the next 10 years, TAVR growth will increase at least by 3 to 4 folds. This increasing number has also been enabled by the expansion of indications. So to start with, we are treating high-risk patients and then intermediate risk patients. And recently, since last year, we are able to treat those low-risk elderly patients, both with balloon expandable devices or the self-expanding valves. So this will certainly increase dramatically the number of patients receiving these TAVR procedures in the near future. You all heard about how to handle or how to tackle the acute complications of TAVR. But there are some long-term concerns that we have to address before we can actually make these procedures more popular. I will talk this one by one. So first of all, patients receiving PCI after TAVR is not low. Number is not low. At least 3 to 5 to 7% of these patients might require some sort of coronary intervention, be it stable angina or ACS or even STEMI patients. But coronary access might be a problem if there is a TAVI device. Mainly because it depends very much on the valve design, the height of the frame, and as well as the patient anatomy. So in general, when we are doing coronary intervention for a patient has been implanted the balloon expandable S3 device, we can use the standard diagnostic and guiding catheters. But if we are doing coronary intervention for a patient after evolute or the self-expanding valve, sometimes we might need to undersize the guiding catheters by half size, or sometimes we might even need to use some sort of guiding extension catheter or even coronary wires to fish around for the coronary ostium. In general, the shorter frames, balloon expandable devices are actually more easy to get coronary access than the self-expanding higher frame device, especially for the supraannular type of device. But they are all doable. Coronary obstruction is sort of the very dramatic acute complications of TAVI procedure. These are the predictors. So usually when we see low-lying coronaries in a small sinus of Valsalva, then the risk of coronary obstruction might be much higher. Many a time we might put in a coronary stent inside the coronary artery as a protection. So if anything happens, if there's any obstruction, we can pull the stent out and then do a chimney stenting after the TAVI procedure. But recently, the basilica procedure, which is an intentional laceration, especially of the prosthetic valves, or sometimes in a native valve as well, try to make a laceration of the leaflets so that when we put the TAVI device in, it will not be obstructing the coronary ostium. So this is one of the more advanced procedures that we can consider when we are facing with this high risk of coronary obstruction patients. Pacemaker rate has not been decreased any further, even with the newer generation of TAVI devices. You see all the complications are on the decrease with new generation devices, except pacemaker implantation. And we know whenever patient needs new pacemaker, this will increase the mortality, future mortality after the TAVI procedure. So our every means is to prevent the implantation of this pacemaker implantation or to prevent heart block development. We know the main reason for patient to develop heart block is mainly because the membranous septum or the right fibrous trigone is very actually close to the non-coronary cups. So when we implant the valve too low, you might actually impinge on this system and then causing heart block. Our aim now is to try to implant high of the TAVI device. These are the possible predictors of conduction disturbances of the TAVI. There are some factors that we cannot control, like pre-existing right bundle branch block or first-degree heart block. But there are other factors that we might be able to control, especially the implant depth. So when we try to implant the valve higher, try to limit the implant depth, then sometimes the patient may end up requiring less pacemaker. This is our usual way to implant the valve. So this is what we call try to get a coplanar view when we align the three leaflets in a straight line. And by doing this, we can actually implant the valve, try to aim at a high implant with these three dots. But nowadays, it has been advocated that even a more accurate method is to use this cups overlap technique. So what they are suggesting is that they try to overlap the right and left coronary cups. And then by doing so, the lowest point of the non-coronary cups will be exposed. So if we can implant the valve in this angle, so the valve will, the height will be very, very much limited. So if we really try to implant the valve high, this will actually will give the best result of high implant and without missing the annulus. So by doing this, at least in one of the US centers, it has been shown that the pacemaker rate actually decreases quite dramatically by implanting the valve high and not missing the annular plane. So this is something that is newer to our thought that we can employ in the near future when we are doing the TAVI procedure. Reduced leaflet motion or leaflet thrombosis has been implicated in at least 1 in 5 our TAVI patients when we subject them to the 4D CT assessment if we do it after the TAVI procedure. This also happens in surgical AVR, though the frequency is not as high as TAVI procedure. Treatment-wise, we will prescribe patients with anticoagulation, usually warfarin. So although recently some operators might actually advocate the use of NOAD to treat this sort of patients when they have symptoms. But the real scenario of how to prevent this sort of reduced leaflet motion is still under question, because there are still studies going on whether we should add NOAD to our usual antiplatelet therapy. Nowadays, we give only aspirin after TAVI procedure. By added NOAD, might be it will reduce the incidence of this reduced leaflet function or even leaflet thrombosis in the future. But we are waiting eagerly for the Atlantis and the ACTION trial results. Valve degeneration has been implicated when Danny Dever actually presented this finding of dramatically decrease the leaflet function with leaflet degeneration after 6 to 8 years of TAVI procedure in the year 2016. But if you look at the most recent meta-analysis by Capodino, you can see that even after 5 to 8 years, we don't see a lot of severe structural valve dysfunction or prosthetic valve failure even years after the TAVI procedure, only 1.3% and 3.7% respectively. So there's no signal of early valve degeneration, at least it is in this meta-analysis. In our hospital, we have been following up with echo in all our patients. So up to 5 years, we don't see any signs of valve degeneration. We are analyzing the up to 10-year result, and I can report to you later on. But at least after 7 years, we have a very reasonable mortality rate of our TAVI patients. And I'm happy to tell you that 3 out of our 4 TAVI patients are still surviving after 7 years of the TAVI procedure. Lastly, bicuspid valve has always been excluded from the clinical trials, no matter it is high risk or low risk trials, mainly because of the heavy calcification associated with bicuspid aortic stenosis, as well as the bulky leaflet associated orthopathy and so on. Sizing is a problem, especially in clinical trials, but for us, we actually follow this recommendation from Didier. So whenever the annulus is smaller than the intercommissural distance size, we actually size according to the annulus. Only when the intercommissural distance is smaller than the annulus distance, then sometimes we might consider downsizing the valve in this bicuspid aortic stenosis patients. And then in the recently presented absolute low risk bicuspid study, you can see that with the use of absolute in this sort of high risk bicuspid AS patients, the primary endpoint at 30 days was only 1.3%. Very, very acceptable results. So out of the 150 patients, only 0.7% mortality and 0.7% disabling stroke out of the 150 patients. And also very reasonable, very comparable other complications as compared to our usual tricuspid patients. And if you look at the valve hemodynamics, well-maintained valves area as well as the mean gradient up to 30 days. And most gratifying to see is this, they don't see any moderate or severe valve regurgitation at 30 days, even for this group of bicuspid AS patients. So I would say for now, bicuspid AS patients, we still can offer TAVI procedure, but we have to bear in mind some of the more procedure details during the procedure. So nowadays, what we are practicing is a minimalist TAVI procedure. So first of all, heart team, we need to have a multidisciplinary heart team involving the surgeons, anesthesiologists, radiologists, cardiac nurses, all together in a heart team to decide whether the patient is a suitable patient for to go for TAVI procedure. Usually we will do this procedure under local anesthesia or conscious sedation, no TEE, no TTE, no central line. We don't put in temporary pacing wire anymore. We do the temporary pacing through the LV stiff guide wire. And then only 114 French sheath over one of the femoral arteries and another 5 French pigtail over the other. Systematically, we will use cerebral protection device through the right radial artery, try to reduce the stroke risk. And then the patient will be ambulated quite early, 4 hours after the procedure, and then discharged within 2 days. This is our usual practice. So with the higher bar in a TAVI procedure in 2020, I would say we are aiming quite high now. We are aiming at 1% inpatient mortality, 2% stroke rate, 3% vascular complications. Usually the procedure can be completed within 1 hour under LA or conscious sedation, and the patient will stay in the hospital for only 2 days. So in this way, more patients will be willing to undergo this sort of minimally invasive transcatheter procedure, and your waiting list will keep growing. Of course, we'll wait for more clinical trials to include more suitable patients. Like in this early TAVI trial, they are looking at whether even asymptomatic severe AS patients should receive early TAVI procedure, or whether moderate AS stenosis, aortic stenosis patients with heart failure actually will also benefit from the TAVI procedure. We will wait for this, the results of these trials before we will expand our indications more. So I would say we have entered a very exciting era for TAVI and also other structural heart interventional procedures. But there are remaining challenges that we have to overcome to make this TAVI procedure more widespread. And these are the remaining challenges that I've just mentioned earlier on. This is our coming meeting, the Chip and Complication Forum in Hong Kong in November. This is a virtual meeting, and you are all welcome to join us on the internet. Just register on the website, and then we will have you for the Chip and complication cases in November. Thank you very much for your attention.
Thank you so much, Michael, for a great lecture. Thank you so much.
Yes, great. So we heard the 3 presentations. I don't know whether Dr. Fistenberg is here. Seems he's not here. But anyway, we can discuss among ourselves. Paul, are you still here?
No, maybe is.
Okay, Paul might just be. So you've heard about the good clinical evidence of the TAVI procedure from inoperable, high risk, intermediate risk, and all the way to low risk patients from Paul. And there are some counter proposals of doing more surgical EVR. Actually, surgical EVR results, especially long-term results, might be better from Dr. Fistenberg. And I've also shown you the remaining challenges of the TAVI procedures, both long-term and some of the immediate challenges of this procedure. But I think it comes to the era that patients really want minimally invasive transcatheter procedures, especially the elderly patients, no matter they're high risk or low risk. So we have to offer this sort of treatment. We have to refine our technologies so that we can offer better for the patient and try to contain the possible complications that we will see with this transcatheter procedure. Lynn, you have any comments?
Oh yes, I I do agree that now we can expand the indication for TAVI for larger population.
Right.
But the main barrier in our community is that the price, and maybe it's not the problem in Singapore, in Hong Kong, or in the States, but in Vietnam, the price of the surgery is very, very low compared to TAVR. It's just $2,000 or $3,000.
Oh, that's very cheap.
Yes, and our surgeons are quite well. You know that they have performed many cases. Even with a 80-plus-year-old patient, they can still do the surgical replacement. So although all the patients come to see us first, but normally I recommend them or I refer them to the surgeon to see if the surgeon can do it or not. I think it's the main barrier is the price.
Okay, suppose, I don't know, if with more patients included, enrolled, when the price of the TAVI devices come down, will you be able to offer more of this transcatheter device? Because when you talk to the patient, most of them will not want a major surgery.
Oh, sure, agree.
Cut open the chest. And especially for the elderly, they really stand a very high risk to go for surgical AVR.
Sure.
So when the price comes down, do you see increase in the number of TAVI patients in your center or in Vietnam?
Excuse me, can you repeat?
Can you see the number of TAVI patients will increase when the price comes down? Yeah.
Yes, I can see the number of cases has increased already.
Right.
So I think since the beginning of this year, in Vietnam, we have up to 20 cases.
Okay,
good. More, which is very promising because in the last 7 or 6 years, we have the total number of just 90 cases in the whole Vietnam.
Okay.
But since the beginning of 2020, I think nearly 20 cases. In my place, we have done 4 cases, and the next case is hopefully next week. But I think we have many candidates for TAVI already, but most of them cannot afford the procedure.
Right.
Yes.
So Paul is not here, but actually I'm going to ask him with the good clinical evidence from this high risk or low risk patients. Most of them are actually not in Asia, not from Asia. So
Okay.
Paul, you are here. You're good. So you see, the evidence you presented, most of them are not from Asia. Do we have good evidence to convince our Asian patients to undergo this procedure? What's your opinion? Sorry, Paul, we cannot hear you.
Can you hear us? You are muted or not? You are muted, Paul.
He's unmuted, but we cannot hear you.
Yes, please unmute.
Okay, maybe something wrong with your computer, Paul. We cannot hear you. So your speaker might not be working well. But anyway, I think this is sort of a generalizable disease because all the populations are actually more or less the same, both for the Caucasians and the Asians. And we actually have our local Asian data, both from the Ocean Registry in Japan, the AP registry, both from Korea. They have sort of collected data from some of the Asian countries. And then there's Asian Pacific TAVI registry from the APSIC, in which we are actually doing the analysis. I think there will be a paper published soon in Asia Intervention that we have actually shown our AP TAVI registry patients actually doing better actually more or less the same, or if not better than the other registries in other parts of the world. So I think we have good clinical evidence from this part of the world that actually TAVI procedures can be safely and very practically done in our locality. And we have very good operators in which the complications are actually not higher than any of the European or US countries. I think that's something that will grow because we have 3/4 of the world population in our locality. And I think the TAVI procedures will be increased dramatically in the very near future.
That's great. Michael, may I have a questions for you?
Yes, sure, please.
So based on your presentation, do we have any consensus now about antithrombotic therapy for patients before and after TAVI?
For now, I would say there are clinical evidence to show that single antiplatelet agent might be the same as dual antiplatelet agents after the TAVI procedure for now, but we don't know the exact incidence of reduced leaflet motion or even valve thrombosis after the procedure. So we will wait for the proper clinical trials, the Atlantis, the action trials, to tell us more whether we should actually put some of these more high-risk patients under the newer anticoagulant, the NOACs, to prevent this sort of valve thrombosis. But for now, at least in our hospital, we are only giving single agent, aspirin only, to our post-TAVI patients, and they don't come back with any problem so far for the past few years.
That's
so
very good.
I would say aspirin for now, and we wait for whether we should add NOAC in the future.
Yes, but aspirin, you mean that for patient without AF, but if patient has AF,
of course, if patient is with other indications, we would just give NOAC.
Sure.
And no aspirin, just NOAC.
Okay. Thank you so much. Thank you.
Thank you. So it seems Paul is not able to join us at this moment.
You can hear me now?
Oh, yeah.
Yeah, sure.
I don't know what happened.
Okay, Paul.
I'll come back.
Yes.
Oh, Dr. Fristenberg is here already.
Yeah. Michael is also here. Good to have you. Paul, would you like to say something more about our Asian evidence, Asian population?
No, I heard you. I think the randomized data is what it is, and I think the results that we see in Asia, it's equivalent. I think it applies, but just that there are some things that we have to be careful about. The randomized data is promising, but it doesn't tell us everything right now yet. So we just have to be careful and follow the evidence that we get as we go along.
Okay, good to know. Sorry, Dr. Fristenberg, we don't have you for the past few lectures, but now we have you. Can I just ask you, in your presentation, you stress very much on the better clinical outcome, especially the long-term outcomes with surgical AVR, both in terms of mortality and stroke. So in your opinion, would you, what sort of patients would you actually subject them to the TAVI procedures instead of surgical AVR? What do you think of the bicuspid patients? You didn't specifically mention about the bicuspid patients. Can you unmute yourself, Dr. Fristenberg?
There you go.
Yeah, we can hear you. Thank you.
Thank you. So I think a couple of things. One is with the bicuspid valves, a lot of it depends on the actual anatomy of the valve. But one of the problems that we've seen is that sometimes you really don't get a very good seal with the TAVR valves, and that sets patients up for at least some degree of paravalvular leak. And when you consider that this is a population that is relatively otherwise young, I think we're starting to see more and more that paravalvular leaks are in themselves an independent marker of a poor outcome. And so I think that in a younger population with bicuspid valve, even though it is feasible and the short-term results are reasonable, I think it's very difficult to really get a good seal. And also because of the nature of the, from a surgical standpoint, the valves I think are much heavily calcified in that area. And so it doesn't really allow for good expansion. And I've seen quite a few bicuspid valves that leave the hybrid room or are back a couple months later with very high gradients. And gradients 20 as high as 20 millimeters of mercury mean gradient, which really, again, when you're thinking about a younger population, is an issue. Yeah.
Yes, great. And the other question is, we know the ESC have updated their guidelines, and I bet the US is going to update their guideline too, because they put in maybe at the very end, patient preference as one of the indicators to guide the heart team whether to subject the patient to surgical AVR or a TAVR procedure. So in your opinion, how important should we consider patient preference?
It's most patients don't want surgery, and I think that's somewhat reasonable. In the United States, I think it's more of an issue than in other parts of the world where patients are more likely to listen to their to their doctors. I think the problem is that we're seeing a lot of patients already coming in and saying, I want TAVR, I don't want surgery, I don't want I don't want it, and they have a hard time accepting that that's not really a good answer for them. And one of the things that I think we're going to start seeing is what we call buyer's remorse. I'm not sure if that's a term that you're familiar with in your country, but it's when you buy something and you can no longer return it and you're not very happy with your purchase. And I think we're going to start seeing over the years a lot of younger patients that have gotten TAVRs that are really not very happy with their choice. Whether it's several years down the road when they need a repeat intervention, when there's concerns of coronary obstruction, and I think we're starting to recognize that the decisions that we're making now really impact these patients long term, and it's going to probably take a few years to settle that out. But I think part of the problem is also the way that the systems are set up. Cardiologists, and I know this is a cardiology meeting, are very aggressive in pushing and wanting to do TAVR, but they also have to recognize that sometimes that's not the best option. So.
Yes, I agree. Actually, we work very closely with our surgical colleagues. We have a heart team, so we decide together which patients go for TAVR, which patients go for surgical AVR. And we always have a compromise or consensus on what kind of stand to take to refer these patients. And
right. No, and I think, people try to do that, but, so for example, today I saw a patient, he was otherwise a low risk patient, and as part of his workup, he gets a catheterization, and the cardiologist, knowing that this is part of a workup for TAVR, sees that he's got a proximal LAD lesion and puts a drug-eluting stent in.
It was stented.
And and you're like, okay, and there's no data to support that, and it really creates a problem, and all of these issues add up. One of the things that I was actually talking with somebody today. I don't remember what trial it was, but I could try to pull it up while we're talking here. But they just released the outcomes of one of the cerebral protection device trials, and the device itself was associated with a much higher rate of neurologic events than what was seen in the patients that were randomized to no device. Okay, that's understandable. But in both populations, and I think this was an intermediate risk population, the stroke rates that were being reported in this study were actually much higher than what we saw in, let's say, the CERT-TAVI or the original Partner 2 trials. And so I think we have to be very careful as we start filtering through all this data to recognize that in a very highly selected patient population for some of these very high profile trials, that doesn't necessarily correlate to what we're seeing in real life. And I think that that's something that, when a surgical patient has a stroke after surgery, everybody knows about it because it's in the hospital. But, when a TAVR patient has a stroke, they're already home. And then they get admitted to another hospital or they get admitted to another service. And, as I, in my presentation where I showed one of the data that shows that there's a lot of these patients that are having neurologic events that we may not necessarily know about. And I think we have to be honest with this. And I've seen some, not necessarily in our program, but in talking to colleagues around, the country, I think that the outcomes in the original Partner 3 trial were very good, and it's going to be very difficult for them to be matched in real life. And I think that's going to set up for a lot of problems. I think when this first started sorting out early on, people were saying, if you have surgery and then there's a bad outcome, they're going to say, well, why didn't you have TAVR? I think that pendulum is going to switch in the other direction, where if people start, when you start having bad complications in low-risk patients, that's really going to start opening people's eyes to these kinds of things.
Right. Okay, thanks a lot. I think our time is up. Thank you very much, Paul.
And I apologize for being late. Yeah, hopefully my presentation came through.
Oh, your presentation was excellent. Great.
Okay, thank you.
And we asked you all we want to ask at the end. Thank you very much, Dr.
All right. Well, I apologize. The time differences are a little bit, I thought it was coming up shortly, so I'm sorry.
No problem. Okay, so if you let me summarize, I would say we have a very good session on the aortic valve disease this morning. We have Paul to show us very good clinical evidence from the inoperable to intermediate risk and then to the low risk group of patients going for TAVR procedures. And we discuss whether most of Asian patients should receive this treatment as well. And then Dr. Fistenberg actually showed us his perspective of the surgical AVR. We know most of this, especially the low risk younger patients, should go for surgical AVR instead of the TAVR procedure, mainly because of the long-term outcomes have not been matched with the surgical AVR patients with our TAVR procedure, especially for the low-risk younger patients. And lastly, I've shown you the remaining remaining challenges of TAVR in the year 2020, both in terms of coronary access, pacemaker rate, valve thrombosis, valve degeneration, and then touch on some of the bicuspid aortic valve issues. So I hope you've enjoyed the session, and we hope the procedure, the TAVR procedure, as well as surgical AVR, actually will be on the increase as we recognize the problem as more and more patients are coming to our treatment in the very near future, not only in Asia, but across the world. So thank you very much for attending this session, and we hope you enjoy the rest of the session, the rest of the meeting. Thank you. Bye-bye.
Thank you so much.
Thank you, Michael.
Thank you.
Thank you.
Bye bye.
Have a good morning.
Okay.
You too. Have a good morning. Or you have a good day. Good night.
Thank you. Yes.
Thank you.
Yes. Bye bye. Bây giờ mình nhớ em cái này phải không? Thôi nhá.
Second, we can start now.
Yes, okay, please.
Yes, yeah. Dr. Ng, please proceed. We on air now, Dr. Ng.
Good, thank you.
Yes. We can start now, Dr. Ng. Yes.
Okay, thank you.
All right.
Well, good morning to all participants and the panel. A very warm welcome to this special Chien Foundation webinar on the ischemic heart disease. My name is Richard Ng from Singapore, and on behalf of the Chien Foundation, together with my co-founder, Teddy Chen and David Chen, it is our great pleasure and privilege to participate in this Vietnam National Heart Association Congress. This is Vietnam's first virtual cardiology congress, and we are delighted to be part of it, having participated regularly in previous congresses in Vietnam. I must congratulate everybody in the Vietnam Heart Association, especially the president, Professor Dom Van Phuoc, the vice presidents, Professor Nguyen Lan Viet, Professor Pham Man Hung, our old friends, and of course our Secretary General, Professor Nguyen Ngon Quang, one of our very promising, outstanding Chien Foundation fellows long ago, and also Dr. Dat, who is moderating this session and translating, and all your council members for staging a very successful virtual congress so far in Hanoi. I would also like to acknowledge the academic support from our Singapore Cardiac Society and the AFC, or ASEAN Federation of Cardiology, for this webinar. Today's special webinar on ischemic heart disease comprises a very distinguished panel of speakers who are world-renowned and very influential KOLs, or key opinion leaders. Each will present a highly useful facet of ischemic heart disease. With me to co-chair this seminar is Professor Philip Wong, another of our Chien Foundation trustees and a leading senior cardiologist at Singapore National Heart Centre. I would also like to thank our Chien Foundation Secretary, Ms. Cheryl Ong, for all the help to organize this webinar from the Singapore end. Without further ado, let me introduce to you our very first speaker, Professor Caroline Lam from Singapore National Heart Centre. Really needs no introduction, as she is, as you all know, world-renowned for her special expertise in the world of heart failure, echocardiography, epidemiology, amongst others. She has contributed significantly to important publications and sits on the editorial board of many international journals. Professor Caroline Lam will start off today's session very appropriately with the topic of ischemic heart disease, 2020, challenges and opportunities. Caroline, thank you.
Thank you so much, Dr. Richard Ng, to the Chien Foundation, to the organizers of this wonderful symposium. It's a real honor to be able to speak on ischemic heart failure. I want to start with the challenges. And here, let's start with our own data here in Asia. Very proud to share the Asian Heart Failure Registry, that we combined forces and recruited more than 7,000 patients with heart failure across many parts of Asia. And the first thing we realized is that a lot of our patients have coronary artery disease, and especially those with heart failure and reduced ejection. This is despite our Asian patients being younger compared to the American or European counterparts.
Có bệnh nhân ở Thái trẻ hơn nhân ở châu Âu.
Was associated with more than 50% increased risk of death at 1 year. in these patients with heart failure with reduced ejection fraction. Looking at it the other way, and this is again one of those big challenges, these heart failure patients would tend to then have inpatient and heart failure hospitalizations, and also can be outpatient and stable. And it's the ones with the heart failure hospitalizations that have almost 2 times the increased risk of death at 1 year.
Tập viện do tự suy tim có liên quan là tăng gấp 2 lần tỷ tử vong trong vòng 1 năm. Và đây là một số kết quả nghiên cứu từ các bệnh nhân của nhóm và đại đa số các bệnh nhân suy tim đều có bệnh mạch vành, mặc dù đã được điều trị đầy đủ, nhưng mà kết cục của các bệnh nhân cũng khá là kém ở các bệnh nhân suy tim, đặc biệt với những người có kèm theo bệnh mạch vành. Nhân suy tim thường là có nguy cơ cao phải nhập viện hoặc tử vong, mặc dù nay đã có rất nhiều các phương pháp điều trị kết hợp. Các nghiên cứu so sánh giữa warfarin và aspirin trong người suy tim và nay vẫn còn cho kết quả ở thời hiện tại.
Not only have they been inconclusive with regards to efficacy, they cause more bleeding. However, there appeared to be hope with the newer anticoagulants, rivaroxaban at a low dose of 2.5 milligrams BID on top of aspirin in the COMPASS trial of patients
kết hợp với rivaroxaban 2,5 mg kết hợp với aspirin kết của các bệnh nhân bệnh định có suy tim trong COMPASS. Cái này cho thấy là các bệnh nhân sử dụng tỷ lệ mắc bệnh yếu thấp hơn 5%.
The other way around, looking at it from the heart failure, ischemic heart failure point of view. And I'm very proud to have been part of this landmark trial called the Commander HF trial, where patients within 21 days of a worsening HFrEF event who had coronary artery disease, but who were in sinus rhythm, okay? We're not talking about those with atrial fibrillation, were randomized to rivaroxaban.
Nghiên cứu này thực hiện trên các bệnh nhân có rối loạn nhịp là dung nhĩ.
Now, this is an unusual outcome for heart failure trial. It's all-cause mortality, myocardial infarction,
Kết cục chính bao gồm có tử vong do mọi nguyên nhân, nhồi máu cơ tim, đột quỵ. Kết quả cho thấy là không có biệt giữa hai nhóm bệnh nhân kết hợp hoặc là placebo. Về tính an toàn thì có tăng nhẹ
So the summary here is that in patients with the receding chronic HFrEF who have coronary artery disease and
suy tim EF giảm, những người có bệnh vành và không có sự khác biệt giữa việc điều trị bằng 2,5 mg 2 lần một ngày và là được trong việc giảm các biến cố là tử vong của bệnh nhân người suy tim hoặc đột quỵ. Không có sự khác biệt.
With the COMPASS population. And here you see the striking difference between the two is that there were a lot more deaths in this very high-risk population with a recent decompensation of heart.
Bệnh nhân mà có những bệnh nhân suy tim tử vong cao hơn do
outcomes like stroke or MI, there appear to be similar reductions. And so this was the impetus for this next look that we did in Commander heart failure, this time looking and focusing at the stroke outcomes. The first message is stroke events were very common in these patients. It approximated the rate you would see in patients with HFrEF with atrial fibrillation, even though these are, again, remember, patients who were in sinus rhythm. Not only are the strokes common, half of them months.
Nguy cơ
And
đột quỵ thì gặp thường xuyên nhưng mà sẽ gặp nhiều trong thời gian 6 tháng. Liều 5 mg mỗi ngày thì sẽ làm giảm nguy cơ đột quỵ. Với bệnh nhân mà có chất FAT cao hơn 4, số lượng bệnh nhân cần điều trị là 152 là 96. Với những bệnh nhân những bệnh nhân
a risk of stroke. And in those with a higher risk anticipated, for example, with a CHA2DS2-VASc score of more than 4, the use of rivaroxaban did appear to reduce the risk of stroke with a number needed to treat of less than 100. Importantly, unlike the prior antithrombotic trials, low-dose rivaroxaban was efficacious in this stroke prevention without an appreciable increase in major bleeding. And so the opportunity perhaps is that select populations with HFrEF and sinus rhythm may be identified by the use of traditional risk scores for additional therapy with low-dose rivaroxaban. And this is a strategy that warrants further investigation. So thank you once again for the opportunity to present at this very important symposium. Thank you.
Thanks, Carolyn. Very excellent presentation. So immediately, because of the interest of time, we'll just serially transfer the presentations one-on-one after I, of course, introduce the very distinguished panel. Our next speaker is very well known to us, Professor Koh Tien Hai. He's, of course, been the department and head of the National Heart Center for a long time. And he's my boss, was my boss for quite a while. He's also the course director of the Sing Life course since 2003. And today, Prof. Koh is going to speak to us on how to minimize heart failure post-MI on primary PCI. Prof. Koh.
Tien Hai, we don't have your sound. Sound. You know, Philip, if it's
I think he needs to unmute his microphone. His microphone is muted. Prof. Koh, you need to unmute your microphone.
Yeah.
Okay. Yeah, now you are
okay.
muted.
Now okay. My goodness.
I think you guys are muted me, so.
All right. Sorry.
Yeah. Let me just. Okay. Sorry. Thank you very much for inviting me to this Vietnam National Cardiology Congress, and with the Chien Foundation. I'm very grateful to Dr. Quang, Dr. Pham, and Dat, and Richard for involving me in this meeting. I was tasked to talk on how to minimize post-myocardial infarct heart failure in the setting of primary PCI. So I think because of interest of time, I'll quickly move on. These are my conflicts of interest. Basically, I'm going to talk on the infarct size and correlation with prognosis, then on current PCI strategies that might be effective in reducing infarct size. We'll discuss a little bit on the unproven but still some attractive PCI strategies we can look at. And of course, adjunctive drugs, which I hope that Caroline might have touched on before. Then also there are many failed strategies, so we'll quickly touch on that. And one or two words on the new initiatives that are being trialed at this time. And then lastly, I would like to conclude. So without further ado, I'll move on to this infarct size. We know that when you have an infarct, your mortality will depend on your infarct size. This is a very elegant series of trials that were collated by Greg Stone, around 10 randomized primary PCI trials in the recent literature, looking at more than 2,500 patients, and all these trials had either a CMR or SPEC assessment of the infarct size. And they correlated with the events that happened at 1 year on follow-up. And you can see on your left side of your screen that basically mortality, reinfarction, and with relevance to our talk today, hospitalization of heart failure are all increased and are statistically significant when you have a larger infarct size, as denoted in the sort of orange or brown bars. If you look at the right side of your slides, the heart failure hospitalization at the bottom, you can see that the infarct size actually correlates very well with heart failure. And the larger your infarct size, the more the risk of getting hospitalized for heart failure, as is evident also for mortality in the upper graph. So therefore, the cause of myocardial infarction and the increased mortality, of course, is due to various factors. The ischemia caused by the myocardial infarction, and when you open up the artery, of course, you can get distal embolization of thrombus as well as arteriomatous debris. But I think equally important, or even more important, there is a lot of reperfusion injury, which I don't have time to discuss. But we know that after your myocardial infarction, you will sustain injury and the LV will remodel very quickly.
Sau những lần nổi máu thì chúng ta sẽ có những tổn thương ở phần cơ tim và gây giãn tại cấu trúc thất trái.
You will develop heart failure pretty quickly. So you might be well when you're hospitalized after infarction, but after returning home in a couple of weeks, you might return with heart failure.
Sau đó rất nhiều bệnh nhân sau khi trong thời gian nằm viện và sau khi ra viện khoảng 2 tuần cũng có thể phải nhập viện lại do vấn đề về suy tim. Vì vậy, làm thế nào để cải thiện các cái cục và tình trạng suy tim trong PCI lần đầu? Điều đầu tiên là phải giảm thời gian can thiệp.
Trial done by the German group called Viet trial with very recent publication, and you can see on the left side of your graph, the one in blue when the patients are neither having a cardiac arrest nor in
nghiên cứu về
you can see that beyond 120 minutes the mortality really increases. And if you look at the right side of our graph, every sort of delay, 10 minutes delay, you're going to have an increased mortality of about 0.1%. So that is not something that we would want to do. So therefore, the earlier you can do, the better will be.
Nó khoảng gần mỗi 10 phút mà bị giảm sẽ làm tăng tử vong lên 3,3 lần.
Of course, in not every center or country, you can have immediate access to PCI. So when you have transfer delays, then their mortality.
Khi chúng ta có các delay khi vận chuyển bệnh nhân làm PCI lần đầu.
What do we do in the meantime to reduce that? There's this very nice trial called the
stream về tỷ lệ mắc trong 30 ngày. So sánh giữa nhóm sử dụng thuốc và nhóm PCI lần đầu.
More than 1 hour and less than 3 hours, and if you
bệnh nhân đến trong khoảng từ 1 đến 3 tiếng
primary PCI center, then it's better to give them thrombolytic therapy. So you can see the primary endpoint on the left side of your graph, looking at all death, shock, and cardiac failure or 30-day reinfarction, that the comparing fibrinolysis with primary PCI, really there is no difference in the outcome. In fact, it looks like the fibrinosis might be trending to better outcomes compared to primary PCI. Of course, there's a slight increased risk of a stroke happening. That's because they gave a full thrombolytic drug dose. But when they reduce that to half in patients more than 75, it has become not significant. And this has also been borne out by the large national registry.
Đánh giá 120 phút điểm cut off khi mà vận chuyển bệnh nhân đến PCI lần đầu. Nghiên cứu thực hiện trên 9.506 bệnh nhân, so sánh giữa sử dụng tiêu sợi huyết hoặc là PCI lần đầu. Guideline ESC năm 2007 thời gian để
but you must also send the patient to a primary PCI center because roughly about a third of them will still have sort of closed artery that will require rescue PCI. For those that meet the reperfusion criteria, then of course you can do a routine angio within the 1 day when they get to the primary PCI center. What about other strategies can reduce the risk of infarct size?
Các chiến lược có thể làm giảm các lượng nhồi máu ở các bệnh mạch vành ba thân, bệnh vành có nhiều nhánh. Các chúng ta chứng minh nghiên cứu so sánh chiến lược tái tế máu toàn bộ vành hoặc là chỉ nhỏ động mạch vạn. 2016 bệnh nhân được can thiệp mạch vành toàn bộ và 2025 bệnh nhân chỉ can thiệp động mạch thổ phạm với thời gian theo dõi trung bình là 3 năm.
With a significant p-value compared to just doing culprit lesion PCI. And this is the difference in the outcomes. There's also other treatment modality that has improved outcomes in anterior MI called a super.
Chiến lược điều trị khác có thể làm cải thiện.
Device here in Singapore, so maybe perhaps Alan Young when it's
Cải
around
thiện diện máu bệnh nhân.
this one. But let's look at what are the unproven but still I think attractive PCI strategies.
Vẫn còn những cái chiến lược khác mà dù
see this thrombus from a patient we did a primary PCI on a right coronary artery. These are all three thrombus from the same patient. But should we still do thrombectomy? We know that the total trial was negative in terms of doing thrombectomy for all patients, but they did a meta-analysis of the three major trials looking at 18,000 patients, and they find that for the overall population, it was not significant with a p-value of 0.15. But if you look at patients just having a high thrombus grade, that means more than 3, you can physically see the thrombus there, and it's more than half the vessel diameter. That actually the p-value is significant, meaning that they improve in terms of cardiovascular death at 30 days. However, you pay a price in terms of having a higher risk of stroke, and therefore you have to weigh the risk versus benefit. I think we still have to wait for bigger trials to give us a more definitive answer in this subgroup of patients. Also, we can defer the stent implantation if we find there's a large thrombus load, because when you implanting a stent immediately, you can dislodge more arteriovenous emboli and cause more distal occlusion. And this is the largest trial to date, the Dynamic 3 defer sub-study. However, there was no difference. But if you look at the subgroup, in patients who receive stent more than 24 millimeters, the infarct size actually is reduced. So I think there's now another trial called a primacy trial that will see whether overall there might be improvement with a deferred stenting strategy. Some practical tips that might reduce infarct size might, as I said, because they all are not proven. You can consider deferring your stenting if you have slow flow or no reflow. If your vessel size is very large, because then that's the largest risk of getting atraumatus embolization. Consider aspiration thrombectomy if you have a high thrombus load, and maybe protect your side branch. What about the medications that we can use to reduce infarct size at the time of primary PCI? I think the main thing is to use intravenous beta blockade, but again, even that is a bit controversial, even though some trials have shown it to be positive, some negative. There's a meta-analysis that says that it might be useful. This is the ESC guideline on management of LV dysfunction. In the interest of time, I don't have time to go through it, but things like ACE inhibitors, MRAs, and other things might be useful. However, what has not worked so far is that there are multiple trials have been done in terms of trying to manage the reperfusion injury, and all these trials unfortunately has been inconclusive. Well, there's a other new initiative. I think one of the more promising one is the fact that if you unload the LV, meaning reduce the LVEDP before you reperfuse R3 using an impeller approach, you might be able to reduce infarct size. So I think there's an ongoing trial looking at this, and other trials like ice intracoronary injecting ice to say ice saline to cool the coronary vasculature might be helpful. So in conclusion, I would say that the mortality outcomes in STEMI are very low now.
Ở STEMI hiện nay rất là thấp với trường hợp STEMI và thời gian PCI trừ những trường hợp mà có sốc tim. Vẫn có những trường hợp có diện lớn do bệnh nhân và do
good nowadays. However, large infarcts still occur due to patient and system delays, and of course, a reperfusion injury. Proven strategies have enumerated, like shortening your door to balloon time, pharmacoinvasive approach, complete revascularization, and use of adjunctive drugs. However, the methods to reduce reperfusion injury unfortunately has been all negative so far, but I don't think we should lose heart, because it's like prevention of in-stent restenosis. It took a long time before we got really effective therapies, and hopefully that the new innovative approaches continue to be explored. The final message I would like to give you is that basically time is muscle, so do your PCI as quickly as you can to improve survival and heart failure outcomes. Thank you very much. And I hope that you can attend my virtual Sing Live program next year, 22nd to 23rd January. Thank you very much again.
Thanks, Prof. Koh, for that very good and extensive review of PCI strategies. Our next speaker is Prof. Chia Pao Lee, who is currently Senior Consultant and Head of Department of Cardiology in the Tan Tock Seng Hospital in Singapore, a very big hospital. His subspecialty is electrophysiology, and today Pao Lee is going to speak to us on atrial fibrillation in ischemic heart failure, a therapeutic conundrum. Pao Lee, please go ahead.
Thanks very much, Prof. Koh, for the kind introduction. Prof. Koh, can I trouble you to stop sharing your screen so that I can share mine, please? Thank you.
Okay, apologies.
No problem. Okay, a very good afternoon to all friends and colleagues. I would like to thank the chairperson and the organizing committee for this opportunity to share my thoughts on the management of patients with atrial fibrillation and ischemic heart failure with reduced ejection fraction. So AF is actually the most common arrhythmia encountered in patients with chronic left ventricular systolic dysfunction with or without an ischemic etiology. Its prevalence increases as symptoms progress, and it approaches 50% in NYHA class 4 patients. The incidence of AF complicating myocardial infarction is estimated to be between 2.3 and 21%. The close association between AF and myocardial infarction relates to common risk factors such as age, hypertension, diabetes, coronary artery disease, and heart failure. As illustrated in this diagram, AF and heart failure share many fundamental predisposing risk factors, such as hypertension, diabetes, ischemic and valvular heart disease, and an increased incidence in the elderly. Even more interesting is how AF and heart failure collaborate to promote each other. AF can facilitate the development of heart failure by several mechanisms. The irregular rapid ventricular response, loss of atrial contraction result in a reduction in cardiac output. This then leads to increases in plasma epinephrine and endothelin, augmenting the typical neurohormonal vasoconstrictor excess observed in heart failure. AF can cause functional mitral annular enlargement with resultant mitral regurgitation, even in patients without structural heart disease. Finally, AF may result in tachycardia-related cardiomyopathy. Heart failure itself can also promote the development of AF through structural, ultrastructural, and neuroendocrine processes. Heart failure exerts a prominent effect on atrial structure with left atrial enlargement, increased left atrial pressure, atrial fibrosis, and functional mitral regurgitation. All these changes are not only profibrillatory, but cumulative and progressive. The literature describing association of heart failure with adverse outcomes in patients with heart failure is conflicting, with only some studies identifying AF as an independent risk factor for mortality and morbidity in heart failure patients. Other studies reported that when analyses were adjusted for common confounding factors such as demographics, AF was no longer an independent predictor of death. Post hoc analysis of paradigm HF and atmosphere trials found that paroxysmal AF, but not persistent permanent AF, was associated with increased composite risk of cardiovascular death or heart failure hospitalization.
Một số báo cáo cho thấy dung lượng tăng nguy cơ tử vong.
That AF is associated with increased mortality in patients with heart failure of ischemic
Có bệnh nhân
pathogenesis,
suy tim có bộ
to progressive pump failure deaths during long-term follow-ups.
chủ yếu do tiến triển của suy tim trong theo dõi dài hạn.
The major goals of therapy in patients
Chính trong kiểm soát suy nghĩ là dự phòng đột quỵ, kiểm soát nhịp thở, giảm chứng và cải thiện chất lượng cuộc sống.
and these priorities
Và ưu tiên của mục tiêu.
patients with AF complicated by heart failure. By definition, the presence of heart failure in an AF patient represents 1 point under the chart's vast scoring system. The combination of heart failure and AF significantly increases the risk of thromboembolism compared with the risk of either condition alone. Guidelines therefore recommend oral anticoagulation in patients with heart failure accompanied by AF. The two largest trials to evaluate the potential benefit of pharmacological rhythm control over rate control in patients with heart failure are the AF-CHF trial and the Diamond-CHF trial. Each of these trials involved 1,200 to 1,500 patients. Both, however, failed to show any difference in cardiovascular mortality. Sub-analysis of both trials comparing outcomes of patients in sinus rhythm versus those in AF also showed no benefit in cardiovascular mortality. In fact, sinus rhythm does not appear to prevent worsening of heart failure. Unfortunately, antiarrhythmic options are rather limited in HFrEF patients. Current guidelines state that dofetilide and imiodarone are the only antiarrhythmic medications that can be safely used in patients with HFrEF. Importantly, class 1 drugs and dronedarone are contraindicated at the moment in HFrEF patients. Beta blockers and digoxin are atrioventricular nodal blockers that can be used to obtain rate control. The non-dihydropyridine calcium channel blockers, diltiazem and verapamil, are contraindicated in patients with LV systolic dysfunction due to increased mortality. No single study has primarily addressed the question of whether one should adopt a strict or lenient control for patients with AF and heart failure. There are some recommendations that for symptomatic patients, a strict heart rate control strategy will be preferred. The advent of catheter ablation has allowed a clearer assessment of the impact of eliminating AF in heart failure. Smaller randomized trials initially demonstrated that restoring sinus rhythm by catheter ablation improved LV function, exercise capacity, heart failure symptoms, and quality of life. The larger clinical trials such as ATEC, Castle AF, and Cabana showed reduction in hard outcomes such as death and hospitalizations. However, the most recent 2019 update of the US AF guidelines stated that both the ATEC and Castle AF trials were limited in size and included highly selected patients. Furthermore, the main Cabana trial showed that AF ablation was not superior to drug therapy for the primary composite outcome. AF catheter ablation was therefore given only a class 2B indication in patients with heart failure. In the August 2020 issue of the European Heart Journal, there was a very comprehensive meta-analysis of the existing randomized data comparing rhythm control with medical rate control of atrial fibrillation in patients with heart failure. This analysis of 11 randomized controlled trials included close to 3,600 patients. Studies were divided into two subsets. Subset A compared medical rhythm versus medical rate control, and subset B comparing catheter ablation with medical therapy. Patients in subset B were notably younger than those in subset A, had more hypertension and diabetes, but notably less coronary artery disease, perhaps reflective of the fact that these patients were considered suitable for catheter ablation. The primary finding was that compared with medical therapy, patients undergoing catheter ablation had improved survival and reduced hospitalizations. In addition, greater freedom from AF recurrence, greater improvement in LV function, and improved heart failure symptoms were observed with catheter ablation. In contrast, no demonstrable benefits were observed in the pooled comparison of pharmacological rhythm versus rate control treatment strategies, with in fact significantly higher hospitalization seen in the medical rhythm control arm. At the opposite end of the therapeutic spectrum for AF in HFrEF patients is the ablate and place strategy. Atrioventricular node ablation with permanent pacemaker placement is an option for patients with permanent AF and systolic dysfunction who have rapid ventricular rates despite optimal medical therapy. Unfortunately, this ablate and pace strategy results in permanent pacemaker dependence. AV node ablation should therefore be undertaken with caution and only used when alternative rate and rhythm control therapies have failed. There is evidence to suggest that biventricular pacing is superior to right ventricular pacing with respect to quality of life, exercise capacity, and hospitalization in patients undergoing AV node ablation. In summary, there is actually a close relationship between atrial fibrillation and heart failure of reduced ejection fraction. It is also apparent that in many heart failure patients, AF causes symptomatic deterioration and may be associated with increased mortality. Although clinical trials are no doubt the gold standard for evaluating strategies for treatment of AF in HFrEF patients, they can never fully address the need for an individualized approach. For all patients, oral anticoagulation, lifestyle modifications, and optimization of guidelines-directed medical therapy are a must. For patients who deteriorate early after onset of AF, despite adequate rate control, it is logical that an aggressive approach to rhythm control and rate control would be warranted. Catheter ablation is an emerging and potentially promising therapy for heart failure patients in whom lasting rhythm control is desired. And finally, ablation may reduce the morbidity associated with long-term treatment with antiarrhythmic agents such as amiodarone. AV nodal ablation with resynchronization therapy should also be considered, particularly for patients who may not be good candidates for catheter ablation and in whom strict rate control may not be achieved through pharmacological treatment alone. Thank you very much for your kind attention.
Thanks, Pauli, for that very clear and lecture on the EP points when we deal with ischemic heart disease. Our next speaker, Professor Alan Young, needs no introduction. He is the Li Ka-shing Professor in Cardiology, Stanford University, United States of America, and is a trustee of the Chien Foundation. His subspecialization is interventional cardiology as well as cardiovascular medicine. He sits on multiple editorial boards of major CV journals and is chairman of the Interventional Cardiology Board. So he's been a great mentor to many doctors, including myself, in the Asia-Pac region. And Dr. Young is going to speak to us today on the optimal and complete revascularization for stable ischemic heart disease using FFR. Alan.
Thank you very much, Philip and Dr. Ng for this opportunity to speak at the Chien Foundation Symposium, and obviously all our colleagues at the Vietnam National Cardiology Congress. Obviously, we wish that we could be there and be seeing you all face to face and enjoy our camaraderie as well. But hopefully next year we'll have that opportunity. So Philip will talk about this particular title already, but I just want to emphasize that obviously because of time that the topic really is focusing on revascularization. But there's obviously a bigger question is that in ischemic heart disease, when to revascularize. And as you know from the recent ischemia trial, there is a discussion about a patient with stable coronary disease, even with ischemia, medical therapy may be equivalent to revascularization. Obviously, there's a lot of discussion what are the limitations in that conclusion. But just to sort of set up this discussion is that once you decide to revascularize for patient with stable ischemic heart disease, how should we do it? So this is my disclosure. So does complete revascularization matter? So in patients with multi-vessel coronary disease undergoing PCI, if you achieve anatomical complete revascularization,
cần làm PCI thay tế máu toàn bộ mạch vành, kết quả tốt hơn trường hợp thay tế máu không hoàn toàn.
And also, if you compare PCI,
mổ bắc cầu nối, bệnh nhân được thay tế máu toàn bộ mạch vành, và tương tự như khi mổ bắc cầu nối.
Have similar outcomes with bypass patients. So complete revascularization seems to be a very significant determinant of how patients perform after your procedure. The third questions we may not have the answer yet, but it's a very
FFR có thể hướng dẫn chúng ta thay tế máu toàn bộ về mặt chức năng như thế nào.
Complete revascularization guided by FFR can it be even better than bypass surgery? And that is a trial that I will.
Này có thể tốt hơn đối với trường hợp mổ bắc cầu nối hay không?
So why are we relying on angiogram, and why are we now not so sort of relying on angiogram to determine?
Vành và hiện nay thì ta không dựa vào phương pháp này nhiều nữa. Chúng ta để biết rằng là chụp mạch vành có thể gây nhầm. Đây là nghiên cứu năm 2014 bệnh nhân mạch vành được làm FFA ở tất cả các nhóm.
Left side of the scale to the right side of the axis, you can see as you increase
mức độ hẹp ở trên trục mạch vành từ 0% đến 70%. Có thể là nhiều bệnh nhân mức độ 0 đến 30% trên trục mạch vành thì số FFA cũng có thể hiểu gì và chức năng không đáng kể.
Information. But what is also surprising is that there are a fair amount of discordance in patients who have greater than 70% stenosis that are FFR negative, that they are greater than 0.8.
Ở nhóm hẹp 70% một nửa trục mạch vành đáng kể, nhưng rõ ràng cho FFA thì nhiều.
But there's some patients also have lesions that have positive FFR as positive as 0.2, 0.3. So clearly angiography, maybe because of the angles, maybe because of overlap, you can actually miss some of these lesions. So revascularization basically meaning that you could be over treatment, you could also be under treatment. So this is a deferred trial, which is 180 patients or so with intermediate lesions with FFR that is greater than 0.75, randomized to deferring the treatment or perform PCI. This is a 15 years follow-up. Essentially, this is saying that if the FFR is negative, waiting, what does that mean if you don't treat right away with PCI? So obviously, the number of patients are relatively small, so mortality is not going to be different. The MI rate in the deferred group, if anything, is smaller, as 2.2% versus 10%. And the target vessel, which is the more relevant information, is 1.1% versus 8.9%. So obviously, if you perform PCI right away, you pay a price of some increased MI, probably related to the procedure itself. If you look at revascularization over time of that 15 years, again, let's focus on the target vessel numbers. So on the deferred group, you have 33 target vessel revascularization. And then if you look at the performant PCI group has 25. So you may say, well, there's less target vessel revascularization in the performed PCI group. But you have to remember 100 of, meaning all of these patients, 100% of these patients have a PCI in the beginning. So you kind of have to add that 90 into that number. So it's actually 115 PCI, if you may, over that 15 years, versus only 33 in the deferred group. So clearly, if you sort of treat everyone that has a negative FFR, you pay a price of actually overdoing with more PCIs as well as more myocardial infarction. FAME2 is a study that essentially compare patients that have lesions that have ischemic value of FFR less than 0.75, and they're randomized to PCI medical therapy. This is a 5-year outcome data showing that you have significant increased numbers of spontaneous MI in the patients that have medical therapy. So here again, showing that if you undertreat, that meaning that, even if it's ischemic FFR, if you go with medical therapy, you pay the price of more MIs later. So previously I showed you overtreatment, you treat sort of everyone, even if their FFR is negative. Here you're showing undertreatment, FFR that is positive, and you still go to medical therapy, you could actually pay the price of more spontaneous MI. This is just to reinforce the idea of FAME2, is that this is a meta-analysis of FFR-guided PCI, 2,400 patients with stable CAD, randomized trial from 3 of them, and comparing FFR-guided PCI with medical therapy. Again, this is consistent going for 5 years that you have death or MI is significantly higher in the medical therapy group, and the FFR-guided PCI group has less primary event of death or MI. So again, showing you under treatment, you actually pay the price as well. So what does it mean when you use FFR in sort of the real world situation? Does it really impact the outcome? Data showing that information have undergone PCI at 68 VA hospital in US, and this is published by my previous fellow, Rishi Parikh, and basically showing that, and has been accepted for JACC, is that if you use FFR as part of a practice of doing a PCI, you actually have a better outcome over time. Obviously, the y-axis here is very stretched out, meaning the top is 1.0, the event-free interval is 0.94. So over 1 year is really still angiographically based is 6%, while the FFR guided type of PCI, it may be in the 2% range. So again, showing large number of data that FFR indeed, if you use it to guide your PCI, will help your outcome. So now you've decided that indeed overtreatment with PCI is no good, undertreatment with PCI is no good, that what is the right amount? So if you look at some of the data using a sort of syntax score, which is an angiographically based way to analyze, to sort of determine the amount of atherosclerosis load of a particular patient. So if you perform revascularization, and then you can also afterwards calculate a syntax score and see how much is actually left for what we call residual syntax score. It's a sort of a reflection of the residual amount of atherosclerosis or lesions that were not treated. So we know that from angiographically guided revascularization, if you don't perform complete revascularization, the residual syntax score actually predict MACE. So this is sort of elaborating that particular observation. Here again, MACE over 5 years, and these are the residual syntax score. So your residual syntax score is high, you will have an event rate that is higher. And obviously, if you have a syntax score that is low or 0, in this particular case, your outcome after this particular, obviously, database is from the syntax trial, that you have better outcome. So the importance of complete revascularization by angiogram shows that, it is a way to do it, but at the same time, you still kind of missed a lot of angiographically maybe felt to be non-significant, but actually turned out to be important lesions. So what about if you use the residual syntax score and see if you use FFR guided to treat patients, and see, would that be the same thing, predicting the same sort of residual syntax score predicting outcome? This is done by our previous fellow as well, Dr. Kobayashi. And what he shows is that the residual syntax score in this case, different from the angiographically guided PCI, the FFR guided PCI really doesn't have a residual syntax score bias, meaning that after functionally complete revascularization, the amount of coronary left behind is really not important. The reason is that the left behind coronary disease is really non-ischemic producing, or if it is, could be a lesion that is supplying also a very sort of non-functional myocardium. So essentially what it tells you is that functionally revascularized lesions, patients actually do as well just using that as a determinant rather than using angiogram. So this is a very sort of provocative way of thinking about it, is that you would base your revascularization based on FFR. And again, this is just showing the functional complete revascularization and functional incomplete revascularization, just to emphasize that question same again, that if you have functionally complete revascularization, you do better over time. So do we have some data to sort of support that in the bigger numbers? So this is the Syntax 2 trial. As you all know, this is a single-arm study comparing physiologically guided PCI to historical control of bypass surgery. So these are patients included in Syntax 2 studies. It's a single arm, is using IFR to be your triage. If they are significant already, you'll be treated with a stent and IVUS optimization. If it is felt to be insignificant, you'll be medically treated. If you are in between IFR 0.86 to 0.93, you'll be using FFR to further triage those lesions. Positive FFR, meaning less than 0.8, getting the stent. Negative FFR, 0.8 or above, you'll be optimally medically treated. So what it shows is really for the first time that, if you use functionally guiding PCI, you actually can beat bypass surgery. So this is obviously not a randomized study using historical Syntax 1 CABG data and basically showing to the Syntax 2 data. So you can see that it is equivalent, obviously non-inferior in this situation, but the curve obviously shows that you actually could be achieving fair amount of positive, less poor outcome especially in the first half of the year. So the definitive trial is the FAME3 trial which is being coordinated by my colleague Dr. Bill Fearon. And what we are doing is that all comers with 3 vessel disease, no left main, and basically the heart team felt that this could be done either way. And then you have FFR guided PCI with resolute stents, and basically stent all the lesions that are FFR less than 0.8. And then based on angiogram, the other arm will be performing bypass surgery. You may argue, why won't you use FFR to guide which vessel should be bypassed? But again, that is a provocative sort of approach, but at the same time, that's not what the current standard is. The current standard is that bypass surgery is based on corneal angiography. And therefore, this is the arm for comparison. Follow-up for 1 year and looking for death MI, CVA, as well as revascularization and the non-inferior design. So this trial is actually completed. This is just some of the data, the last look before we complete the trial enrollment, about 1,500 patients, and basically majority of male Caucasians. It'll be interesting to see how this particular sort of will sort out over time. And how about the baseline syntax score? We look at the core lab here, and majority of these patients are obviously with the syntax score less than 32, it's about 46% in the intermediate tertile, and then 41% in the low syntax score tertile. 13% is in the high risk greater than 32 syntax score group. You may ask, how does it compare to the other trials? So whether syntax, freedom, best, or FAME1. The FAME3 vessel disease trial will be having a syntax score, mean syntax score around 25. So it is really relatively comparable to the best and freedom data, maybe a little lower than the original syntax score. So in conclusion, anatomical complete revascularization is associated with improved outcomes after PCI. Anatomical complete revascularization with PCI compares favorably with CABG, as we discussed before. Functionally, complete revascularization guided by FFR may result in even better outcomes for PCI, and this approach will be tested in the FAME3 trial. Hopefully, we'll be presenting in sometime next year in a major meeting. Thank you so much.
Thanks, Alan, for that very extensive review of the trials. Our next speaker is also very well known in Asia and internationally. Professor Tan Wei Chim is Director and Senior Consultant at the National University Heart Centre, Singapore, Professor of Medicine NUS, and Chairman of the Singapore Heart Foundation. He is also past President of the EPSIC and founding member of the AICT International Meeting. He is a well-known professor in China and is a visiting professor to 11 university-affiliated hospitals in China. And it's the current editor of Asian Interventional Journal. His topic today is hybrid revascularization. Is there a role in current times? Wei Chim. Wei Chim, you got to unmute first.
Sorry, can you hear me now?
Yeah, great. Thanks.
Thank you very much for the kind introduction. I think this lecture ties in very well with what Alan has just spoken. When we look at major society recommendations regarding patients with multivessel coronary artery disease, you will see that the coronary artery bypass surgery is always the preferred strategy, particularly in patients with more complex disease and with or without diabetes. And the reason is because in patients with multivessel coronary artery disease, CABG offers a complete revascularization, whether anatomical or functional. It confers survival advantage in selected subsets of patients. It has a lower chance of a repeat revascularization. It avoids stent-related issues. However, there are also disadvantages of CABG. We know it is a major operation. It requires longer duration for hospitalizations and recovery. There's a higher bleeding and arrhythmias accompanying the operations, higher initial expense, leg incisions, limited alignments of venous bypass conduit, and the repeat CABG is always more difficult and of higher risk. So if we have an opportunity to combine CABG and PCI in what we call hybrid coronary revascularizations, we pretty much combine the benefits of both modalities of treatment. So first reported by Angelini way back in Lancet 1996, this is a strategy that can be done at the same on the same patients, either simultaneously in a one-stage procedure or could be a two-stage procedure where you actually do them on two different occasions. The whole idea here is to have a surgical left internal mammary artery graft with LAD through a mini thoracotomy because this offers sternal sparing and a quicker recovery, and coronary stenting to the non-LAD lesions with buccal stents, which all we know has got a better patency than the saphenous vein graft conduit. So let's look at the effectiveness of revascularization. Lima to LAD we know has got a long-term patency rate of 98% at 10 years. Saphenous vein graft occlusion, 20% at 1 year, 30% at 10 years, 70% at 15 years. In fact, if you look at the PREVENT-4 trial, SVG failure occurs in 46% of patients at 1 year. When we look at DES and just looking at the early years of data from everolimus eluding stent and zolderolimus eluding stent, the 1 year target lesion revascularization rate is 3%. So clearly DES fares better than an SVG conduit. So when we look at the NUH hybrid revascularization setup, this is how we go about doing it. So we offer a simultaneous hybrid revascularization. The whole idea here is to reduce the recovery duration, minimize hospital complications and surgical trauma, while maintaining the durability outcome similar to a conventional bypass surgery. So this requires the presence of a hybrid operating suite equipped with the latest radiographic technology, will allow for surgical and percutaneous procedure to be performed consecutively in the same setting. So what we do here is that we start off usually with a bypass surgery, and the surgeons can choose any of these approaches: left anterior thoracotomy, xiphoid approach, thoracoscopic approach, or a left posterior thoracotomy approach. Well, whatever it is, the anastomosis of the lima to the LAD is performed under direct visions on a beating heart. And so in MÉCH here, what we do here is we have a incision that is usually small and left-sided, and it's a non-rib spreading thoracotomy in the fourth and fifth intercostal space via a direct visualizations. So this is also assisted by thoracoscopic as well as robotic techniques to avoid significant chest wall manipulation and to improve post-operative pain control. And so this is the McGinn's setup for MÉCH in NUH here. Basically, you have a left thoracotomy incisions, then you have a retractor, and you have a octopus heart stabilizer to stabilize the heart as the surgeons perform the operation. So this procedure is non-rib spreading, so you don't cause injury to the ribs, and you minimize operative pain sensations in the process and allow for a faster recovery. So the whole idea here, and actually the most important part of the hybrid revascularization, is the quality of the lima to the LAD anastomosis. And if you have a good lima to the LAD, we know that MÉCH results do actually compare very favorably to a conventional coronary bypass surgery. So we need to do a pretty good MÉCH procedure here. The advantage of a MÉCH in this hybrid approach is that you avoid aortic clamping and manipulation, so it provides superior neurologic outcomes with reduced embolic strokes. There's a lower invasiveness, obviously, for, requiring less ventilation and ICU stay, less blood transfusion, less infection risk, less nerve injury, better cosmesis, obviously, and likelihood of repeat revascularization is low with lima graft. However, to do MÉCH, there are unfortunately limitations. When patient has concomitant valve disease, not a good idea to do this hybrid approach. When you have an intramyocardial LAD, is also no good. When you have a pulmonary conditions that prohibit single lung ventilation, because oftentimes the surgeon will have to collapse the left lung to allow for the bypass to be done. Or when you have left clavian artery stenosis or history of chest with radiations, all these are limitations for a MÉCH approach. Once the lima to LAD is done, we go to the PCI part. And this will be a typical patient, a long diffuse LAD, which were deemed to be not suitable for PCI. So surgeons did the lima to the LAD and can clearly see that the lima anastomosis is well done. And then with the interventionists then come in soon after and then finish up the stenting on the right side for the right coronary artery stenosis. So this is a typical patient. So within 5 days of the procedure, he's up and about, ready to go in, following a hybrid revascularization. So the practical concerns for setting up a hybrid simultaneous revascularization is that you need a hybrid operating room. You have a logistic concern here. You have to time your procedure. You have to sequence the procedure involving 2 teams. You need specific technical competence and close cooperation of the surgical and interventional group. The risk of perioperative bleeding will be slightly higher because these patients would have been loaded with dual antiplatelet therapy in preparations for PCI. And there's always a concern about the left main cohort outcomes and the uncertain cost effectiveness with this approach. So let's look at some clinical evidence here. When we compare hybrid revascularizations with conventional off-pump CABG, as in many retrospective propensity match cohort study, you find that most times there's actually no difference in mortality and no readmissions post-op, but clearly patients in the hybrid outcomes do have certain advantages, which we mentioned earlier on: lower blood transfusion, shorter intubation time, shorter length of ICU stay, and so forth. The only randomized control trial that was performed will be shared afterwards, but certainly from when we compare the cost of the hybrid versus OpCare, while there is an initial expense with the hybrid approach, but because of the shorter hospitalization, the overall cost actually turns out to be normal, quite the same as a conventional off-pump coronary artery bypass surgery. But what is impressive is that the patient satisfaction score is way higher in the hybrid.
Trong nhóm nào phối hợp có 83% bệnh nhân đạt điểm 6, trong khi ở nhóm kia 2%. Đây là nghiên cứu lớn nhất đánh giá các phương pháp phẫu thuật và can thiệp nghiên cứu bệnh nhân tổn thương nhồi nhánh mạch vành được hiện diện là một trong 3 chiến lược phối hợp mổ mở và làm PCI. Kết cục chính là thiếu máu cục bộ tuần dư đo trên SPECT sau 1 năm và kết quả là 3 làm giảm đáng kể lượng bộ.
But when you look at the major adverse cardiocerebral vascular event, free survival at 12 months, they were also the same. But what is different here is that obviously when you have PCI and hybrid, your risk of bleeding is low. And certainly when you have PCI, your hospital stay and sick leave is going to be shorter compared to CABG and hybrid revascularization. But importantly, at 12 months, the clinical outcomes is the same. Target vessel or graft failure is the same across all 3 modalities. So what do the international guidelines say about hybrid revascularizations? ACC says that in the 2012 recommendation, it's reasonable if either CABG or PCI are contraindicated due to severe clinical or anatomical reasons. ESC European says that you can consider it as a class 2B recommendations for specific patient subsets and only an experienced centers. So in our centers here, we deem the following patients to be suitable for hybrid revascularizations. When you have a patient that has the LAD that's suitable for MICAP and the rest are suitable to PCI. When you have a kidney failure patients, particularly those with end-stage renal failure on hemodialysis, oftentimes with very calcified porcelain aorta, hybrid is the preferred approach. Diabetic patients with diffuse disease, frail elderly patients, morbidly obese, impaired pulmonary functions, you can all consider a hybrid revascularizations. But there's always a challenge, a hybrid mantra as we call it, because the greatest barrier to this hybrid revascularization is the ability of the surgeons and the cardiologists to work together, to engage in hybrid thinking with close collaborations between the 2 disciplines. And oftentimes, it is the willingness and the ability to create this collaborative culture, which is the largest barrier to creating a successful hybrid program. So in conclusion, I think a hybrid procedure which combines a minimally invasive arterial grafting with PCI is a feasible and a safe strategy in selected patients. However, the use of hybrid remains low because of multiple practical limitations, particularly in developing countries where you need a hybrid revascularization, hybrid OT. And until a hybrid revascularization can prove superior to a conventional CABG in clinical outcomes, I think adoption of this strategy will likely continue to be modest in these present times. Thank you very much for your attention.
Well, thank you very much, Hui Chim, for that very current status of hybrid revascularization. And I would invite questions now, but before that, I'll just recap the 5 excellent lectures given by Caroline Lam on the ischemic heart failure and the challenges today and what are the opportunities in future. This is still a very much area of working in progress. And then Koh Tian Hai, Professor Koh talked about the time is muscle and how to minimize myocardial problems in primary PCI. And then Chia Pao Li gave a state-of-the-art lecture on atrial fibrillation in ischemic heart disease and the newer areas like pacing and also AV nodal ablation, and besides the AF ablation to try and improve the atrial fibrillation problem that we all seem to be seeing more and more as the population ages. And Professor Alan Yang gave a very elegant talk on the use of functional testing for ischemic or ischemia in coronary artery disease. It's interesting to see his studies and his tables that some of the cases where the FFR is actually normal, or rather the artery coronary, what strikes me was the table on the angiographic stenosis of something like 30%, and yet your FFR is abnormal. Maybe you can elaborate on that, because then we are going to promote more unnecessary stenting in those cases, and whether your FFR has got further refinements like IFR. I hear now a lot of FFRs are being refined. Now you can use saline instead of having got to use adenosine, etc. And whether this FFR can be taken further to actually improve and refine the need for stenting or revascularization by surgery. And Professor Tan Hui Chim brought us to this current status of technology, where I think is going to play a big part if it is possible to see whether we can do both the Lima and maybe the Rima to the right as well. And in this technological age of laparoscopic surgery going more and more with robotic help, I think his question is very pertinent, is whether this role of hybrid revascularization is going to go further or is going to actually fade off because of many practical problems as he has just mentioned. At this stage, I'd like to introduce the panel. Thank you all so much for your excellent lectures. And any questions from either Dr. Dat, who can kindly translate it to English for us, if you have questions from your Vietnam side. And if not, we will ask questions too. Thank you.
Yeah, good afternoon, Dr. Chairman, Dr. Richard Ng, and everyone. And it's my pleasure to be here today to be the moderator for this symposium. And before we are going to the Q&A section, allow me to thank you so much, Dr. Richard Ng, for leading and planning this event. And our organizing team would like me to say thank you on their behalf. And big thank you to everyone this morning to attending this Chien Foundation Academy Symposium. And on behalf of Vietnam Heart Association and organizing team, Professor Phước, Professor Viet, Professor Hung, and Professor Quang, Dr. Diep, and myself, we wish to thank Dr. Richard Ng, the organizer and chairperson for this symposium, and the team for this event, the Prof. Alan Yang of Stanford University in the US, and Prof. Tan Hui Chim of National University Heart Center of Singapore, and Prof. Koh Tian Hai of National Heart Center Singapore, Prof. Caroline Lam of National Heart Center in Singapore, and Prof. Chia Pao Li of Tan Tock Seng Hospital in Singapore, and Prof. Philip Wong of National Heart Center in Singapore. And we also wish to thank the Chien Foundation for their continuous and consistent support as the academic partner of our Vietnam National Heart Association Congress for the past 10 years. And we believe that for many years, into the future. And the Chien Foundation is founded by the Dr. Richard Ng and Teddy Chien and Mr. David Chien, and our trustee Chien Foundation include Prof. Alan Young, Prof. Tanny Chien, and Prof. Philip Wang. And thank you so much, very much, Dr. Ng and the faculty team, and also Mr. Teddy Chien and Mr. David Chien. And actually, we have a few questions to the panelists. And the first question that for the Prof. Caroline and all of you, that COVID-19 is a new disease that has become prevalent in the past few months and causing a disruption of cardiac service and new challenge in the management of heart failure patients. So this outbreak is quite under control in Vietnam. And until now, Vietnam recorded about the 35 coronavirus deaths since the epidemic began. And I know that the number of COVID-19, the single population is roughly about 15 times higher than Vietnam, but the same death number. And so the question from the audience that what are the challenge in the management of heart failure patients during the COVID-19 pandemic?
I hope it's okay, maybe that I go, since I suppose in seeing heart failure patients, I think the challenges are a few. Number one is recognizing that they are at risk of severe COVID-19 infections. And so, you know, we have to take care of them, but at the same time, recognizing that they're also at risk of their own disease. And so, you know, it's a fine balance between managing the prevention of infection and maintaining their usual therapy. The other thing is, the other challenge is the clash in the diagnostic symptomatology. So when we see a patient with decompensated heart failure, sometimes it's very difficult to tell what it is from. And the problem is sometimes both exist together, because we know that an infection is a very common trigger of acute decompensated heart failure. So that can be very, very tricky when you have infiltrates in the lungs and you don't know whether it's infective or whether it is fluid. The third thing is the other way around, that actually COVID can cause heart failure, and we know that more and more. So I think it's a very intertwined thing. There are lots of challenges, but I think thankfully we haven't seen that many severe cases and florid myocarditis, for example. So we've been fortunate in that sense. It was a little bit different in SARS. SARS was terrible.
Thank you. So from the U.S. perspective, obviously, you know, our numbers are very high in terms of number of deaths and number of infections. But luckily, in our Bay Area, things were pretty much under control, except for the early surge back in March, April, and we were concerned about capacity of the hospital. But it never, the wave never arrived in terms of the number of cases. But what is important is, I think a lot of patients that got very sick with COVID, they usually come to the hospital very late. So typically they have, from the symptom onset before they come to the emergency room, is on average of 10 to 14 days, meaning that, as Carolyn was saying, many of them may have previous heart failure issues, and they might be a little short of breath, a little this, and they thought it was maybe just an exacerbation of what they had, and delay the therapy or potential, obviously, isolation, and therefore spreading it more to the family and then trigger more disease. So I think the concern obviously is when you have symptoms that could be commingled with heart failure, is to get treatment early, and, you know, obviously can be able to separate out the two a bit and direct the therapy accordingly. And even though in the beginning we don't have a whole lot of therapy, but we now are pretty aggressive in using remdesivir early, even though these trials are a bit mixed, and as you know, the recent data that is real life use maybe not as impressive at the randomized study, and also obviously other potential treatment as well. So I think for patients, the message is that, you know, seek help early and let the doctors help you sort it out, because we can have diagnostic tests, have, you know, obviously X-rays, you know, CT and otherwise, and also prevent it from spreading further in the household.
Okay, any other questions?
Yeah, we have the second question from Prof. Ko and Prof. Philip Wang. In terms of the stem cell, over the past 20 years, the bone marrow stem cell was widely used, investigated for the clinical efficacy in the patient following the heart failure after the QMI. But unfortunately, in ESC 2020, the BAMI trial failed to show that the bone marrow stem cell intracoronary therapy was superior to the standard therapy. So with the Prof. Cole and Prof. Philip Wong, the expert in stem cell, do you think that the stem cells still have any promising roles in treatment of heart failure after QMI?
Maybe I can quickly jump in first before Philip's answers. Philip's the expert in the stem cell treatment, yes. So I'll let him answer this. But in terms of the COVID, I listened to a TCT broadcast just 1 or 2 days ago. And if you actually have a STEMI, you should still bring the patient to the cath lab. But the finding that they did was that there's roughly about maybe only 50% actually have occlusion of the epicardial coronary arteries, and the other 50% maybe actually is only the small little arterioles that get clogged up because of thrombosis. So it's not always that even if you have ST elevation, there's going to be acute epicardial artery occlusion. So just for the information. Yeah. Philip, yeah.
Yeah, this stem cell thing is really a very complex issue. I think a lot of the trials that have been done, first of all, were not powered enough to really show good efficacy for whatever stem cell has been done. I think that's one point. So the data is not convincing either for or against. Second thing is, I think it's targeted towards a very selected group of patients. And I think the patient selection is going to be critical in the future. So the typical patient that is selected is one which we consider very poor prognosis and no likely option, or the no option type of patient. So this is the type of patient we would like to select for any stem cell therapy. So typically the patient will have perhaps revascularization done before, but no viable areas and with very poor ejection fraction. The next thing is, I think we have not given up hope. So we actually have an ongoing trial that is a pilot trial for 10 patients, and this is quite an unusual use of patients' own circulating stem cells. So we are selecting GCCF boosted stem cells, CD34 positive stem cells from the bloodstream, and then re-giving it back to the patient after a few days after post-infarct. So it's a very selected population. Only patients that have been fully revascularized have EF of less than 45% will be selected for this trial. Now, this trial was actually approved just before COVID-19, but it has been suspended. And we've just only last week gotten permission to restart the trial. So we're going to start this trial. There's a lot of controversies to how the stem cells will be given back to the patient. So initial proposal was to use an intravascular, intraventricular device, the intramyocardial injection catheter. But the company, the sponsor, has now changed to another possible route, which is intracoronary epicardial injection using a very unusual catheter called the bullfrog catheter, which is traditionally used for peripheral injection of drugs. So this is, I think, the state of art is still very open in terms of stem cell. But again, these are probably the three important points about stem cells moving ahead.
Okay. So stem cell is something I think which has been going on for a long time. It's very appealing. It's very sensational. But I think so far, I must say, with all the research going on in the West, in the East, in countries that are easier to do stem cell research, we haven't had a great breakthrough, but that doesn't mean that we shouldn't continue. Any other questions, Dr. Dutt?
Yeah, we have one question from Prof. Alan Young. That thank you for a very nice presentation about the role of FFI in stable angina patient, but the major drawback of either FFR and IFFR is that they are done only in the cath lab. Though also the significant proportion of patients who go to the cath lab based on the stress test have non-obstructive coronaries or non-hemodynamically significantly stenosis. So could you suggest any non-invasive test that can increase the pre-cath lab probability of the identify this patient with the hemodynamically significantly stenosis or not, and determine who will actually benefit from the revascularization?
Very good question.
Thank you. Very important questions that have multiple layers of possible answers. And I think the key part is that, you know, when we look at a trial like ischemia again, it's very sort of a focused group of patients. I think when we're dealing with patients with possible ischemic heart disease, we have to sort of adjust the test according to what the problem is. For example, in patients that have risk factors only, and no symptoms that are with reasonable activity, likelihood is that they have significant coronary disease is relatively low. So the test that may be helpful is, for example, calcium score. So you have an idea of how much atherosclerosis load there is. A CTA would be quite helpful in terms of determining whether this person have any atherosclerosis at all. So as you move to atypical chest pain, angina-like symptoms, then you start to couple that with you know, a bit more you know, tests that looking for ischemia and amount of disease. So I think a CTA in those situations is very helpful to, again, quantitate amount of disease as well as are there significant lesion, coupled with probably a stress testing if you can, whether it's nuclear, whether it's echo, whether it's MR, to be able to then start to really, before even going to the cath lab, an idea of the amount of disease. And obviously, if you have a CT FFR capability, that's another way of predetermine how much atherosclerosis you have and how much stenosis you have. So I think it depends on the patient presentation and the spectrum of their symptoms. As you know, ischemic heart disease, the major benefit of any revascularization is really treatment of symptoms, right? Getting rid of the symptoms. Of course, if you have left main disease and triple vessel disease, decreased ejection fraction on top, revascularization, especially by surgery in diabetic patients, will improve their outcome in terms of mortality. So I think by tuning the test that you need, and not like one test for all, kind of ischemic heart disease will be the sort of modern approach. I know that, you know, going to the cath lab is really, I think most of the time is when you are thinking that this patient would need revascularization. Before you do it, you know, we don't do diagnostic angiogram just to check how much, whether the person has coronary disease or not, very rarely, except for very, you know, transplant patient, very specific group of people, because our non-invasive tests are so good now and so reproducible across the world. You know, a CTA with contrast is done by the CT scan so well across the board, whether you are India, in China, US, you get pretty good similar results. So I would say that, you know, that is really quite a good test to start if that's what is available.
Alan, what about stress echo and isotopic tests? Would they give you a good indication of the percentage of ischemic area involved, and therefore, you know, be another way of testing before cath lab?
Yeah. So from the ischemia trial, you know, it seems like the amount of ischemia does not determine whether you benefit from revascularization or medical therapy alone, meaning that the amount of ischemia doesn't matter. Obviously, the testing that they use to determine ischemia is about 25, I remember 30% just plain stress tests. And then the rest is a lot of them are nuclear, you know, stress tests, and a small amount, 10-20% are stress echo. So the difficulty is that if you use, as you know, stress ECG alone to check for ischemia, there's a fair amount of false positive and a fair amount of false negative. So I am still a believer that if you think that there is this issue of how much is there ischemia presence, a stress test is very helpful to determine the sort of the functional significance of these symptoms. So if cost is not a big issue, I think a CTA combined with some sort of stress test is really a very helpful combination to test out the ischemic heart disease load and how does it affect the patient.
Good. Any other questions or anybody want to make any additional comments from the panel?
My comment here is that I think the future is really about CT-FFR, because I think if we can have a combination of both anatomical and physiological information within one test, I think that this is going to be a game changer. And I'm glad that the two national centers in Singapore are doing this particular study evaluating a CT-FFR. So we'll just wait and see.
Yes, I think the future in the cath lab will be a lot of functional testing, which I think Tan Hui Chim and his group are all doing very well. Dr. Dutt, any other points?
Yeah, we have another question for the Prof. Tan Hui Chim, that hybrid revascularization is quite interesting approach. And the question from the audience, that what is the anticoagulation and antiplatelet strategy in the patient who underwent the hybrid revascularization to keep the balance between the bleeding complication and ischemic MACE?
So these patients will have to be loaded with dual antiplatelet therapy, just like they are going for a PCI. And during a CABG itself, surgeons typically will have to start them on high dose heparin. So the antiplatelet and anticoagulant regimen is pretty much consistent with what a normal PCI or CABG will require. The only thing that the surgeons always complain about is the increased risk of bleeding perioperatively because this dual antiplatelet therapy. But hopefully, with all this minimally strategy, they can minimize that bleeding, and so far the experience has been okay. So the bleeding can be controlled intraoperatively and postoperatively as well. So that's the downside of it for the surgical part, is that you have to operate with dual antiplatelet on board.
Yes, I think you need a lot of cooperation and you need a special setup. So the more you do the hybrid, the better you are. And at one stage, I think in US, Alan, they were very keen on this hybrid, but now it seems the enthusiasm has kind of tapered off a little bit. Do you think so? For hybrid?
I think Hui Chim pointed to it very elegantly, is that it is a very elegant procedure. It just takes a bit more coordination, a bit more time to sort of get the surgical team and the interventional team to sort of tie together to do things. So, and also if you have a CTO in one of the vessel and it's not the LAD, then the hybrid becomes a little bit not as attractive, right? Because then you have to deal with that non-LAD CTO. How do you do that? And if you do it by a PCI, that seems to be not particularly a way to go. So if you have a CTO of the LAD, that's even obviously a very good choice to do Lima to the LAD and then fix whatever the rest is. And I think the advance in the future is that really, if we indeed doing mid-cap, the issue mainly again with hybrid is bleeding, is the combination of heparin, combination of P2Y12. If we use again the second generation, maybe even a bigger issue is how do we actually maybe reducing the dose of heparin, because now you are not in bypass. The surgeons obviously are traditionally like to have a very high ACT, large amount of heparin, is that they probably don't need to have that, and start to work towards sort of a common anticoagulation pathway that if we can reduce the bleeding from post-op for their surgical wounds and chest tube, and also from our standpoint, not have excess bleeding, for example, I think that will be make it much more attractive as a way to do revascularization.
Thank you. May I just move quickly to Dr. Chia Pao Li for one or two quick questions. Pao Li, as you know, atrial fibrillation is the actual cause of many TIAs and falls and head injuries as the population ages. Now, can I ask you, for what do you see the role of telemedicine to diagnose paroxysmal AF, say in our society? Number one. Number two is how do you think the AF ablation will go on? Will we be seeing bigger numbers for this sort of procedure or less, knowing that the success rate at the moment is kind of hovering around 70–80% only?
Thanks, Dr. Ng, for the questions. I think one of the biggest game changers recently is the Apple Watch, as everyone knows. I have personally seen and received a number of ECG tracings from patients with Apple Watches, and I must say that they are really impressive. But the problem with all this telemedicine and all these monitors is that they actually create a lot of noise in the background. They end up detecting a lot of arrhythmias, which actually in the clinical sense, they may not actually require treatment. And what happens then is it creates a lot of patient anxiety and downstream unwarranted clinical investigations. So although I think it empowers patients to monitor their health and their heart rhythm and ECGs, it also creates downstream effects like maybe increased healthcare expenditure, unwarranted tests, and so on. So I think there's always pros and cons with technological advancements. With regards to catheter ablation, definitely there still is a role. I am quite sure with the advent of technology, success rates will probably be much higher. But at this point in time, I think, especially in the local setting, I think there's always this unwillingness to go for a procedure for something that the patients think they can actually take medications for. But I think that the future is bright for catheter ablation. At this point in time, it's still regarded as second line as compared to medications, but I think sooner or later, it probably be one of the first line therapies for patients with AF.
Okay, thank you. Dr. Dutt, shall we close this session?
Yes, Prof. Yeah, yes, Dr.
Yeah, well, on behalf of the Chien Foundation and our panelists and our speakers, we've delivered excellent lectures. I'd like to thank the Vietnam Heart Association for accommodating us, and I wish everybody a good day. And we look forward to participating in Vietnam again, on, as Alan said, on a face-to-face meeting, which is quite different from this virtual meeting. But be that as it may, I think this has been a very successful virtual meeting from Hanoi, and we'd like to congratulate you on a very successful meeting. I thank all of you, especially the speakers and all the participants for this meeting. Thank you and good day.
Yes, on behalf of Vietnam Heart Association, we would like to thank you so much for Dr. Richard Ng, the chairman, panelists, and all the speakers for the informative and interesting talk, and to the audience for your active participation. And hopefully all the presentation will be beneficial for everyone, and have a great rest of your day. Thank you so much, and bye.
Thank you. Bye.
Thank you, everyone.
Here, folks.
Thank you. Bye-bye.
Where's your slide, Philip? Philip ran away.
Thank you, Prof. Thank you, Prof.
No, I'm still here. If you go to the chat panel, I took a
We can start now this session. So good afternoon, everybody, especially our faculty, Dr. Olaf Frazen and Professor Ewan Donald and Dr. Olivier Laser
Chào mọi người,
from
chương trình của chúng ta sẽ bắt đầu với các báo cáo viên Dr. Edward Donald, Dr. Oliver Days và Dr. Olaf Frazen.
association. So we are very happy to have all you here and we are
Đại diện cho Hội Tim mạch Việt Nam, chúng tôi rất vui mừng khi có thể có các báo cáo viên ở đây và xin cảm ơn các báo cáo viên đã tham gia.
In this 17th Congress of Cardiology of Vietnam, so we turn into online all of the session because of COVID-19, but we think we can make the challenge to become the opportunity here. So our session today, we discuss.
Thứ 17 của chúng tôi thực hiện online, nhưng hy vọng là chúng tôi thể biến những thách thức thành cơ hội.
So I would like to ask Dr. Olaf Frazen to have some opening remark for you, please.
Yeah.
Xin mời Dr. Olaf Frazen có những lời.
And I'm very curious to hear the presentations from the following speakers. And treating mitral regurgitation by intervention is not a very new thing, interestingly. It all started 2009, around 2008.
Tôi rất tò mò với các báo cáo sắp tới, bởi vì là điều trị hở van hai lá thì không phải là mới bắt đầu từ năm 2009, nhưng mà đây là rất là thú vị.
But I think there is so much technology now and also growing body of evidence.
Hiện nay thì càng ngày càng có nhiều các kỹ thuật mới và có nhiều những cái bằng chứng để đánh giá cái hiệu quả của phương pháp điều trị này.
And how may it be in the future? So I'm very curious to hear about data and presentations in this field.
Thank you. May I invite Dr. Ewan Donald from running.
Xin mời.
You may have some opening speech.
Yes, thank you.
Xin mời
Invitation.
bác sĩ Edward Donald.
We do a lot actually in France with mitral regurgitation percutaneous treatment.
Ở Pháp chúng tôi thực hiện rất nhiều thủ thuật điều trị hở van hai lá. Trong đó nhiều như là điều trị bằng mitral clip.
That come in the field. So it's a moving field. It's a very interesting field because we don't understand everything. So we have a lot to learn, and it's a good session. I think that we will.
Lĩnh vực này thì vẫn đang liên tục phát triển và còn trở nên rất thú vị. Xin mời giáo sư Edward Donald với bài trình bày về nên hay không nên sửa van hai lá qua đường ống thông cho hở van hai lá cơ năng.
Or medical treatment for secondary mitral regurgitation. It's a subject that is very important nowadays because we see.
Hiện nay chủ đề này đang ngày càng quan trọng, bởi vì càng ngày chúng ta càng có nhiều bệnh nhân hở van hai lá.
But first of all, I want to emphasize the fact that secondary mitral regurgitation is a complex disease and we don't know.
Tôi cần phải nhấn mạnh rằng là hở van hai lá cơ năng là một bệnh lý rất là phức tạp. Có nhiều cái cơ chế để gây hở van hai lá. Đầu tiên là các bệnh nhân có bệnh tim thiếu máu cục bộ.
Mitral regurgitation.
Và có thể gây rớt fail van hai lá dẫn đến hở van hai lá. Cũng có những trường hợp bệnh nhân là có bệnh cơ tim không liên quan đến thiếu máu cục bộ. Thất trái giãn và gây ra hở van hai lá đường dòng hở trung tâm.
Extremely enlarged, and with this enlargement of the atrium, you can get an enlargement of the mitral annulus and then
khi nhĩ trái giãn thì vòng van hai lá cũng giãn và cũng gây hở van hai lá.
You can have a symmetric tethering linked to a dilated cardiomyopathy, non-ischemic dilated
Chúng ta thấy
cardiomyopathy.
là hở van hai lá dòng dịch lệch hở tâm, dòng hở lệch tâm thì có thể liên quan đến bệnh tim thiếu máu cục bộ. Dòng hở trung tâm thì có thể liên quan đến bệnh tim không thiếu máu cục bộ và giãn nhĩ trái.
When you have a patient with a secondary mitral regurgitation, you can consider the treatment of this regurgitation if you are pretty sure that the patient is symptomatic because of the severity of the mitral.
Khi bạn có một bệnh nhân hở van hai lá thì chúng ta có thể cân nhắc việc điều trị khi mà có thể chắc chắn rằng là triệu chứng của bệnh nhân là liên quan đến hở van hai lá. Với những bệnh nhân mà hở van hai lá cơ năng mức độ nặng và EF dưới 30% mà vẫn còn có triệu chứng, mặc dù đã dùng thuốc điều trị tối ưu bao gồm cả biện pháp CRT, và những người không có khả năng tưới máu thì có thể thực hiện kẹp clip van hai lá.
On the echo images on transthoracic and transesophageal echo that you have a severe secondary mitral regurgitation.
Đây là hình ảnh siêu âm tim của hở van hai lá nặng.
And also dilatation of the left atrium.
Ở đây có thể giãn vào thất trái và giãn nhĩ trái. Khi mà chụp buồng tim bên thất phải, đây là chúng ta thấy hình ảnh tăng áp lực động mạch phổi, và chúng ta có thể khá chắc rằng là triệu chứng của này là chủ yếu là do hở van hai lá.
Should be performed in a patient that is correctly treated with the correct dosage of diuretics, especially. When you do the echo, you have to look very carefully at the mechanism of the regurgitation.
Khi chúng ta làm siêu âm tim thì cần phải đánh giá chắc chắn là cơ chế gây hở van hai lá để có thể xem là có thể kẹp clip van hai lá hay không.
To make sure that you understand perfectly where the regurgitant jet is coming
Chúng ta cần phải chắc chắn là cái dòng hở van hai lá xuất phát từ đâu, và nếu mà bệnh nhân liệu có được hưởng lợi khi mà điều trị van hai lá hay không. Sử dụng siêu âm tim để đánh giá cơ chế hở van hai lá thì cần phải chúng ta thấy rằng là siêu âm tim qua thực quản thì không quá rõ ràng, nhưng mà hình ảnh 3D thì là chắc chắn thì có thể sẽ giúp chúng ta hiểu về cơ chế tốt hơn rất nhiều. Việc đánh giá hở van hai lá thì cần phải cá nhân hóa, bao gồm có cả về kích thước cơ thể, nguyên nhân gây hở van hai lá, các biến chứng về tim và chức năng tim, hở van hai lá mãn tính hay là cấp tính, các yếu tố về huyết động, và đặc biệt là stress echo thì cũng thể sẽ giúp được chúng ta nhiều. Chúng ta cũng cần phải đánh giá là mức độ ảnh hưởng của hở van hai lá đối với tái cấu trúc thất trái.
You have to very precisely look at the mechanism of the mitral regurgitation.
Việc đánh giá hở van hai lá rất là phức tạp, chỉ cần phải đánh giá cả cơ chế hở van hai lá, định lượng mức độ hở van. Đây là khuyến cáo từ Hội Tim mạch Hoa Kỳ. Hở van hai lá nặng được gọi là nặng khi mà chỉ số EAO từ 0,3 đến 0,39, volume của thể tích dòng hở 45 đến 59 mm và tỷ số dòng hở là 40 đến 49%, được gọi là
that is close to 50% or higher. So when you assess a patient for a severe secondary mitral regurgitation, you
Khi
start
chúng ta
by
đánh giá bệnh nhân hở van hai lá để đánh giá mức độ thì chúng ta cần phải tìm thứ nhất là về các về lâm sàng như chiều cao, cân nặng, huyết áp, nhịp tim và các chỉ số để đánh giá mức độ hở trên siêu âm, chỉ số EAO và thể tích dòng hở là quan trọng nhất. Ngoài ra còn phải đánh giá các tất nhiên là cũng phải đánh giá các ảnh hưởng của hở van hai lá đối với cấu trúc tim như là kích thước và chức năng của thất phải, thất trái, nhĩ phải, nhĩ trái và các bệnh van tim kèm theo. Đôi khi có thể kết hợp với cả MRI và chụp thất phải để đánh giá thể tích dòng hở. Chúng ta cần phải kết hợp tất cả rất nhiều các yếu tố để đưa ra kết luận về mức độ hở van.
In a patient with a secondary mitral regurg, you can use this technique. It's not that easy to measure the mitral.
Nếu bạn không chắc khi mà mình đo các kích thước về vòng van thì có thể sử dụng một kỹ thuật khác để đánh giá dòng hở, kích thước dòng hở.
If you have a 3D probe, you can quantify the LV volume in N.
Chúng ta đánh giá thể tích cuối tâm trương và thể tích túi tâm trương, thể tích túi tâm trương, thể tích cuối tâm thu để đánh giá thể tích của dòng hở.
LVOT VTI. So this is quite easy.
Dựa vào đường ra thất trái, VTI là đường ra thất trái. Nếu mà thể tích lớn hơn 45 thì coi là nhiều. Chúng ta đã biết là có hai nghiên cứu về đánh giá về mitral clip là nghiên cứu Mitral Friend và năm 2018 và co-op cũng vào sau vài tháng là tháng 9 năm 2018. Trong khi đó co-op thì cho thấy là bệnh nhân sẽ được hưởng lợi từ mitral clip, thì nghiên cứu mitral FR thì cho kết quả ngược lại. Như vậy điều gì khiến cho hai nghiên cứu này có kết quả khác biệt? Thì chúng ta thấy rằng là đây là vấn đề của khi mà lựa chọn bệnh nhân. Bệnh nhân trong co-op, trong nghiên cứu co-op thì có mức độ hở van hai lá nặng hơn. Tuy nhiên thì là thể tích cuối tâm trương thì lại thấp hơn so với cả nghiên cứu mitral FR.
In mitral FR as compared to co-opt. It means that in co-opt, the patient had more severe mitral regurgitation and less severe enlargement of the left ventricle.
Điều này chứng tỏ là các bệnh nhân ở trong co-op thì mức độ hở van hai lá nặng hơn, nhưng mà mức độ giãn thất trái thì ít hơn. Khi chúng ta xem các dữ liệu từ nghiên cứu co-op thì sẽ thấy rằng là lợi ích của mitral clip là lớn nhất ở nhóm bệnh nhân có chỉ số EAO trong khoảng 30 đến 40 mm vuông và chỉ số thất trái về dưới 96 mm trên mét vuông. Có nghĩa là hở van hai lá nhiều nhưng mà thất trái không quá giãn.
That mitral clip is not useful in that case.
Tất nhiên là trong nghiên cứu mitral thì thất trái giãn nhiều.
Discuss about proportionate and disproportionate mitral.
1/3 bệnh nhân có suy tim mãn tính thì có kèm theo do hở van hai lá nhiều có liên quan đến việc giãn thất trái hoặc là mất đồng bộ giữa thất trái. Nếu mức nếu mà mức độ hở van hai lá thì tương ứng với cả mức độ giãn thất trái thì chúng ta sẽ hướng đến là điều trị bằng nội khoa. Cần phải chắc chắn là điều trị nội khoa của bệnh nhân là tối ưu. Và khi đó thì hở van hai lá thì sẽ đáp ứng tốt với những việc điều trị bằng các biện pháp làm giảm mức độ giãn thất trái, như là các thuốc ức chế men chuyển, ức chế beta hoặc là CRT.
So use medical treatment, use the new treatment like Entresto, and don't forget that if you have broad QRS, then
Chúng ta có thể dùng các thuốc như là Entresto để giảm cái kích thước nhĩ trái.
and probably a decrease in mitral regurgitation. So it's
Các cơ quan này có thể làm giảm mức độ hở van hai lá.
And if the mitral regurg is proportionate, then make your best to treat medically the patient before.
Nếu chúng ta thấy là nếu mà mức độ hở van hai lá tương ứng với cả mức độ giãn thất trái thì cần phải chắc chắn là bệnh nhân được điều trị tại khoa tối ưu trước.
Show you that paper that is published this week.
Đây là một bài báo mới được công bố vào tháng này, vào tuần này. Đây là những bệnh nhân mà có hở van hai lá và giảm chức năng thất trái. Những bệnh nhân màu xanh là có hở van hai lá nhiều và thất trái không quá giãn. Hở hai lá nhiều và giãn thất trái ít.
Looking at the impact of mitral clip in these patients, you see that mitral clip was effective to decrease the risk of.
Đối với những bệnh nhân này thì mitral clip làm giảm mức độ của hở van hai lá và làm giảm tỷ lệ tử vong.
Enlargement of the left ventricle. But when you have a patient with a too dilated left ventricle and a less severe mitral regurg, then really.
Với những bệnh nhân mà thất trái giãn nhiều và hở van hai lá không nhiều lắm thì mitral clip không có nhiều ý nghĩa.
So this is important to consider mitral clip, even if the patient has a severe heart failure, but he has to have and to keep all over the time a severe mitral regurgitation. In mitral affair, it has been looked at the proportionate and disproportionate mitral regurg, and no positive results were observed. But Olivier will discuss that. So really, the most important is to very precisely assess the severity and the mechanism of the mitral regurg.
Nên điều quan trọng nhất là phải đánh giá được mức độ hở van hai lá và cơ chế gây hở van.
If the LV myocardium is not too thick, then probably treating the mitral regurg in a symptomatic patient might be helpful. But if you have only fibrosis in the myocardium of the left ventricle,
nếu thất trái không giãn lắm thì việc điều trị bằng thuốc thì có thể làm thay đổi cái mức độ hở van hai lá. Tuy nhiên nếu mà hở van hai lá nhiều và thất không có giãn thì có cần phải điều trị bằng các phương pháp can thiệp trực tiếp vào van hai lá. Do đó chúng ta cần phải sự đánh giá về cả chức năng và kích thước của nhĩ trái, của thất trái nữa.
Much lower mitral regurgitation.
Đây là nghiên cứu để đánh giá về hở van hai lá chức năng và tiên lượng ở những bệnh nhân suy tim đã được điều trị với thuốc với EF giảm. Đối với những bệnh nhân đã được điều trị thuốc tối ưu thì chúng ta thấy rằng là có những bệnh nhân mà cái tỷ lệ tử vong vẫn khá là cao. Với những bệnh nhân có nhiều bệnh nhân mà hở van hai lá thì cái nguy cơ để chuyển thành suy tim khá là cao. Đây là hình ảnh để cách lựa chọn bệnh nhân khi mà làm mitral clip. Những bệnh nhân mà thất trái giãn nhiều và nhĩ trái nhưng hở van hai lá không có nhiều thì cũng có thể không thể sử dụng điều trị bằng MαίCh TOÀN QUուցC cũng có thể không có ý nghĩa. Nhưng mà những bệnh nhân mà có hở van hai lá nhiều nhưng mà không thất trái không quá giãn thì MαίCh TOAN QUուցC là sẽ có tác dụng.
If you have a severe mitral regurgitation, for sure. And if you have a less severe mitral regurgitation, you will not treat the patient. So you have to.
Tuy nhiên là khi mà chúng ta theo dõi bệnh nhân thì những cái chỉ số này cũng có thể thay đổi. Ở đây chúng ta không có câu trả lời chỉ trắng hoặc là đen. Chúng ta cần phải theo dõi bệnh nhân và có khi phải sử dụng MαίCh TOAN QUուցC khi mà bệnh nhân vẫn còn hở van hai lá rất nhiều mặc dù đã điều trị tối ưu. Chúng ta cần phải và khi có những bệnh nhân mà tình trạng bệnh quá nặng thì có thể cũng không thể làm MαίCh TOAN QUուցC mà nên chuyển sang thai tim. Hy vọng thể gặp các bạn ở Barcelona vào tháng 12 năm sau và tháng 12 và chúng ta sẽ có nhiều bài hơn về điều trị hở van hai lá. Cho nên là bài báo cáo thứ hai của giáo sư Oliver về hở van hai lá tương ứng và không tương ứng đối với mức độ suy tim, khái niệm hữu ích hay là vô ích.
Thank you so much for Prof. Ewan Donor for exciting presentation, and we move on to the second speaker. Prof. Oliver, he will deliver the presentation entitled "The Profession Net" or "These Profession Net are Useful and Useless Concept." This is a recorded presentation, so we can see him on the screen right now.
Thank the scientific committee to give me the opportunity to talk about this.
Xin cảm ơn vì đã cho tôi cơ hội để trình bài về chủ đề hở van hai lá tương ứng và không tương ứng.
And the real question, I think it's what are we talking about when I say this mitral regurgitation? I know that there is also something else. I mean that there is left ventricular dilatation and left ventricular dysfunction. And the real question.
Chúng ta đang nói về vấn đề hở van hai lá nhưng mà cũng phải cần phải để ý là liên quan đến giãn thất trái và rối loạn chức năng thất trái. Đây là vấn đề giống như là một tảng băng và hở van hai lá thì giống như chỉ là một cái phần nổi của tảng băng.
Submerged part of the iceberg. So when I say this mitral regurgitation,
vậy thì ở đây hở van hai lá mới là vấn đề hay là giãn thất trái mới là vấn đề?
The matter, or is the mitral regurgitation the matter?
Giãn thất trái và rối loạn chức năng thất trái là vấn đề cần quan. Có hay chúng ta biết là có hai loại hở van hai lá là hở van hai lá tiên phát và hay là thứ phát.
It's easy to quantify and to know if there is severe mitral regurgitation because the left ventricular dysfunction and remodeling.
Trong hở van hai lá tiên phát thì các vấn đề các tổn thương ở lá van hai lá dẫn đến tình trạng hở van. Tuy nhiên trong hở van hai lá thứ phát thì rối loạn chức năng thất trái mới dẫn đến tình trạng hở van.
Because the left ventricle is already damaged. So in the first case of primary mitral regurgitation, the abnormal valve make the heart sick.
Như vậy là trong hở van hay lá tiên phát thì những cái lá van bất thường làm cho trái tim yếu đi. Và do đó là hở van hay lá là cái làm sửa được quá tải của thất trái. Áp dụng tính chất về tiên lượng của hở van hay lá thứ phát dựa theo mức độ hở van trong một nghiên cứu dài hạn. Thế là càng hở van nặng thì tỷ lệ tử vong càng cao. Đây là cho thấy là đây là biểu đồ về đánh giá tỷ lệ tử vong sau khi mà sửa vòng van hai lá.
Mitral regurgitation with worsen the prognosis. The correction of the mitral regurgitation is not going to improve the prognosis.
Ở đây thì thấy là mức độ hở van hai lá này không làm cải thiện mức độ tử vong.
The left ventricular dysfunction and the left ventricular dilatation and remodeling.
Vấn đề có hơn cả hở van hai lá có là đánh giá cần giãn thất trái và nhĩ trái. Và chúng ta cần một phương pháp tiếp cận dựa trên nhiều yếu tố hơn. Đây là một số những cái hạn chế khi đo bằng cái phương pháp PISA. Khi mà cái hình ảnh cái dòng hở không phải là hình cầu, hoặc là trong hở van hay lá thứ phát thì cái dòng hở van hay dòng EAO thì nó lại là hình bầu dục thay vì là hình cầu, giống như là trong hở van hay là tiên phát.
And the geometry of the proximal convergence zone in secondary mitral regurgitation is most of the time complex and often asymmetrical.
Do đó khi việc đánh giá ở hở van hay lá thứ phát thì thường rất là phức tạp và thường là chúng ta đánh giá dưới mức độ nặng thực sự.
Leaf left of the mitral regurgitation, leading to a more hemielliptic regurgitant orifice area. So there is a lot of limitation to the.
Có một số hạn chế về PISA trong điều trị trong việc đánh giá hở van hay là thứ phát, vì dòng hở thường là lệch tâm, khó trong việc đánh giá đánh giá từ vị trí xuất phát của dòng hở. Vì kích thước đo thì được đánh giá được đo bằng đơn vị mét vuông, tức là do đó khi mà chỉ một sai sót nhỏ cũng thể dẫn đến cái sự sai lớn, sai số nhiều ở kết quả cuối cùng. Và cần phải khi đo thì chúng ta cũng cần phải tính đến là mức độ thẳng hàng giữa cái đầu giò và dòng hở.
So there is really a need to an integrated approach because we know that
khi mà phân chia hở và mức độ hở van hay lá ở nhẹ, vừa và nặng thì cần phải phụ thuộc vào các chỉ số, và cũng cần phải liên quan đến cần phải xem đến các bằng chứng ở trên lâm sàng. Chỉ số EAO cần phải kết hợp với cả chỉ số về đường kính cuối tâm trương của thất trái để đánh giá mức độ hở van hay lá.
Consider that regurgitant fraction over 50% is the reasonably a good cutoff to assume the severity of the mitral regurgitation.
Khi mà thể tích dòng hở hơn 5% thì có thể coi là hở van hay là nhiều. Bởi vì có đến 50% dòng hở, dòng chảy từ nhĩ trái xuống thất trái thì bị quay ngược trở lại nhĩ trái. Nên là vị cut off ở 50% là có độ nhạy và độ đặc hiệu khá là cao.
and diastolic volume, you will see that the value defining severe mitral regurgitation in individual patient depends on multiple factors, including
khi chúng ta đánh giá về thể tích dòng hở và thể tích cuối tâm trương thất trái, chúng ta sẽ thấy rằng mức độ hở van hai lá nó sẽ phụ thuộc vào chỉ số EF.
And the effective regurgitant orifice area should be indexed to the left ventricular and diastolic volume to determine the mitral regurgitation severity. And in this example, we can see that for the same regurgitant volume, depending on the left ventricular ejection fraction, you will not have the same.
Như ví dụ chúng ta thấy rằng là khi mà thể tích dòng hở khoảng 40 ml thì giờ với EF khác nhau thì cái thể tích cuối tâm trương thất trái sẽ khác nhau.
To the left ventricular ejection fraction and to the regurgitant volume. So if you consider that the regurgitant fraction, it's the good parameters to quantify the severity of the mitral regurgitation, we see in these figures that the regurgitant fraction depend of all these parameters.
Nên là nếu mà chúng ta thấy rằng là tỷ số hở van hai lá mà là nếu bạn nghĩ rằng là tỷ số hở van hai lá là chỉ số chính xác để đánh giá hở van hai lá thì ở đây chúng ta thấy rằng nó còn phụ thuộc vào EF nữa. Cho nên là không thể chỉ dựa vào một chỉ số này để đánh giá mức độ hở van hai lá. Mức độ hở van hai lá tương ứng với cả thể tích cuối tấp trái. Đây là một quan điểm có ích hay là vô ích?
I think it's useful, and I'm going to show you two studies that show that these concepts can be useful. If you consider the MITRA FR, which is a study which randomized patients.
Nghiên cứu MITRA FR thì hở van hai lá nhiều được định nghĩa là có EAO trên 20 mm² hoặc là thể tích dòng hở trên 30 lít. Trong đó thì EF trong khoảng từ 15-40% và có suy tim có triệu chứng. Điều trị cái clip van hai lá thì được kết hợp cùng với cả điều trị nội khoa tối ưu đối với nhóm can thiệp gồm 152 bệnh nhân, hoặc là chỉ điều trị nội khoa tối ưu cũng với 152 bệnh nhân trong nhóm chứng. Kết cục chính bao gồm tử vong sau. Kết quả cho thấy sau 12 tháng thì không có sự khác biệt về tỷ lệ, không có biến cố ở cả hai nhóm chứng và nhóm can thiệp.
The result was really good, and there was an improvement of the dyspnea. But there was an improvement in both groups, and that means that typical optimal treatment was as good as the intervention.
Cải thiện triệu chứng thì có ở cả hai, đạt được cả hai nhóm, và do đó chúng ta thấy rằng là điều trị nội khoa tối ưu cũng có kết quả tốt như là can thiệp van hai lá. Trong trường hợp này thì khi bệnh nhân thường là có giãn thất trái nhiều và thay đổi cấu trúc thất trái này đáp ứng tốt với cả việc điều trị thuốc. Trong nghiên cứu co-op thì các bệnh nhân có suy tim có triệu chứng và kèm theo hở van hai lá chức năng mức độ vừa đến nhiều, có được chia thành hai nhánh, can thiệp van hai lá kết hợp với điều trị nội khoa tối ưu với 302 bệnh nhân gọi là nhóm can thiệp, và nhóm chứng gồm có 312 bệnh nhân được điều trị nội khoa tối ưu đơn thuần. Kết cục chính là tỷ lệ tái nhập viện vì suy tim trong vòng 24 tháng. Trong kết quả cho thấy rằng là nhóm can thiệp thì làm giảm tỷ lệ nhập viện do suy tim và cả giảm cả tỷ lệ bệnh nhân tử vong do mọi nguyên nhân.
Than predicted by the left and ventricular and diastolic
Và cái có thể tiên lượng cái kết quả này dựa vào cái mức độ hở, mức độ giãn của thất trái, tức là cái mức độ tương ứng của hở van hai lá với giãn thất trái. Những bệnh nhân này thì sẽ được hưởng lợi từ điều trị hở van hai lá bằng clip. Như vậy chúng ta thấy rằng là các bệnh nhân ở trong nghiên cứu MATRA thì thực ra là thuộc nhóm hở van hai lá tương ứng. Trong khi đó thì bệnh nhân trong co-op thì thuộc nhóm bệnh nhân không tương ứng.
But the left ventricular end-diastolic volume. And in this patient, and only in this patient, the correction of the mitral regurgitation.
Những bệnh nhân trong co-op thì việc điều trị hở van hai lá thì có thể làm giảm mức độ hở van. Như vậy chúng ta thấy rằng là những bệnh nhân hở van hai lá thì thực ra là một nhóm khá là phức tạp, gồm có thể chia thành nhiều các dưới nhóm dựa vào ERO, mức độ ERO đáp ứng hoặc là phụ thuộc đối với cả thể tích cuối tâm trương của thất trái. Việc chia hở van hai lá thứ phát thành nhóm tương ứng hay không tương ứng với thể tích cuối tâm trương thất trái thì rất là quan trọng khi lựa chọn các bệnh nhân có thể hưởng lợi từ điều trị suy tim hay là
for example, the medical optimal treatment to reduce the left ventricular volume and to reduce the mitral regurgitation.
Ví dụ như là những bệnh nhân mà đáp ứng với cả điều trị thuốc có thể làm giảm kích thước thất trái thì do đó có thể giảm mức độ hở van hai lá và bệnh nhân có thể hưởng lợi về vấn đề về điều trị siêu tim. Còn vào những bệnh nhân ngược lại thì sẽ được hưởng lợi từ việc can thiệp hở van hai lá bằng kẹp clip.
Thank you so much, Professor Oliver Myron, for the very interesting presentation. And allow me to introduce the last speaker, Dr. Olaf Franzen from the.
Sau đây là bài báo cáo cuối cùng của bác sĩ Olaf Franzen với chủ đề sửa van hai lá qua đường ống thông, thách thức và cơ hội năm 2020.
To give the lecture about the transcatheter mitral valve repair challenge and opportunity in 2020. Please, Dr. Olaf. You please to unmute first. And you share the screen. We cannot hear you, Dr. Olaf. You have to unmute first. Dr. Olaf, we still cannot hear you.
Can you hear me now?
Okay, clearly. Please proceed.
Can you see my presentation?
You can proceed.
Yeah, can you see my presentation?
Yes, very clearly. Thank you.
So thank you for giving me the opportunity to also sum up a little bit what's already has been said and see what the challenges.
Xin cảm ơn vì cho tôi cơ hội để tổng kết lại những vấn đề đã được trình bày và đưa ra những cái thách thức trong năm mới. Chúng ta sẽ nhìn lại lịch sử phát triển của các thiết bị khi mà điều trị hở van hai lá.
From the findings, like it's done also in 2020. So it started actually with a device for percutaneous treatment.
Đầu bằng các thiết bị để điều trị hở van hai lá. Các thiết bị hiện nay.
I think it's almost the standard in the moment for treating mitral regurgitation interventionally. And while there was an ongoing trial in the US
Nghiên cứu tại Mỹ với tên là Everest 2 sử dụng MyczTOÀN để trong năm 2009 để điều trị hở van hai lá.
From the Everest trial from US, and this was the trial was randomized.
Đây là một nghiên cứu ngẫu nhiên có nhóm chứng trên 279 bệnh nhân từ 37 cơ sở y tế. Trong đó bệnh nhân hở van hai lá mức độ 3, 4 và có một số và chúng ta so sánh xem là hiệu quả của các phương cổ điều trị bằng MyczTOAN. Tất cả các bệnh tiêu chuẩn lựa chọn là tất cả các bệnh nhân đều phải có chỉ định mổ van hai lá và mức độ hở van là nhiều đến rất nhiều, xin lỗi, từ trung bình đến nhiều, 3 cộng đến 4 cộng. Bệnh nhân có triệu chứng EF trên 25% và thể tích cuối tâm thu dưới 55 mm. Những bệnh nhân không có triệu chứng thì sẽ có một trong những cái tiêu chuẩn sau như là EF trong khoảng từ 25 đến 60%, thể tích cuối tâm thu trên 40 mm thủy ngân, tăng năng về phổi và dung nhĩ, loại trừ những bệnh nhân mà có MI trong vòng 12 hở van này là nhiều do lá van rớt. Đây là đặc điểm bệnh nhân. Thì cái nhóm có phẫu thuật thì có tiền sử tiền sử suy tim nhiều hơn. Chỉ cơ chế gây hở van hai lá do thoái hóa thì
about degenerative mitral regurgitation. And if you compare, everybody knows probably the results of the Everest 2 trial. It was that the mitral clip in comparison to surgery was a very safe procedure, not very effective.
Kết quả nghiên cứu như chúng ta đã thấy thì là kẹp clip van hai lá thì an toàn hơn so với mổ, nhưng mà hiệu quả về điều trị thì không nhiều.
Efficacy of the mitral clip was still not bad. If we compare it, you can see that it mainly came from severe to mild to moderate mitral regurgitation. I will show that.
Rằng là mitral clip thì sẽ có hiệu quả ở những nhóm bệnh nhân trên 70 tuổi, hở van lá chức năng và EF dưới 60%.
This is what you can expect from reduction of mitral regurgitation is
biểu đồ để đánh giá mức độ giảm mức độ hở van hai lá.
Mild or mild to moderate mitral regurgitation, and maybe grade 1 and grade 2 is separated 50-50, and 80% of the patients have a good reduction, while
cả nhóm thì đều có làm giảm mức độ hở. Trong nhóm trong nhóm kẹp clip van hai lá thì vẫn sau 2 năm thì vẫn còn những bệnh nhân hở van hai lá mức độ vừa đến nhiều. Trong khi đó với nhóm phẫu thuật thì mức độ hở van hai lá giảm đáng kể.
So if you look on New York Heart class, the improvement for the mitral clip was at least as good.
Tuy nhiên thì mức độ cải thiện về triệu chứng thì ở nhóm can thiệp thì ít nhất là sẽ bằng với cả nhóm phẫu thuật.
So there was a big question then, does this last? Does the reduction of
Có một câu hỏi lớn là những cái kết quả này thì những kết quả này có kéo dài được hay không, hay là chỉ diễn ra trong thời gian ngắn, và bệnh nhân sau đó thì cần phải phẫu thuật để sửa van hoặc thay van hai lá. Sau 5 năm, đây là kết quả nghiên cứu của Everest 2 sau 2 năm.
that if there was a good result from mitral regurgitation, it stayed good.
Kết quả này cho thấy rằng là nếu như mà ngay sau can thiệp mà kết quả tốt thì kết quả này vẫn sẽ tiếp tục ổn định trong 5 năm tiếp theo.
This early phase with a good result, they stayed also with a good result and didn't need too much surgery. And you can see.
Và chúng ta cũng không thấy cần có nhiều phẫu thuật lại ở nhóm can thiệp van hai lá.
Here in the upper bars, you can see that the device stayed quite good with 1 and 2 plus grade MR and surgery.
Đầu tiên thấy là
the benefit for the patient stayed also out after 5 years. So
kết quả này, các kết quả về đánh giá về mức độ hở van hai lá vẫn ổn định trong vòng 5 năm.
And here you see such a ventricle from
chúng ta có thể nhìn thấy là hở van hai lá do thất đắn không kín. Vậy đâu là bệnh nhân để tốt để điều trị? Chọn đúng, làm sao để chọn đúng được bệnh nhân để chỉ định can thiệp?
So what we did, we looked in the patients who came in 2009 and when the technology.
Và chúng tôi đã nhìn lại về dữ liệu về các bệnh nhân đến với chúng tôi năm 2009 và chúng tôi thấy rằng là có một số những cái tiêu chí để lựa chọn bệnh nhân thích hợp với có thể hưởng lợi được từ can thiệp, bao gồm có là thể đường kính thất trái trên 60 mm, EF dưới 20%, ERO dưới 4 cm², chiều dài đoạn đóng van dưới 2 mm, độ rộng của lá van rớt là trên 15 mm và khoảng cách giữa van là dưới 10 mm. Đây là kết quả can thiệp van hai lá ở những bệnh nhân nguy cơ cao. Vậy với những bệnh nhân mà suy tim giai đoạn cuối thì sao?
And it was also in these end-stage heart failure patients that we could see we can reduce mitral regurgitation efficacy.
Chúng ta thấy rằng là sau 6 tháng thì chúng ta cũng giảm đáng kể mức độ hở van hai lá.
There were also patients who were not good candidates for mitral clip.
Tuy nhiên khi nhìn vào tỷ lệ tử vong, tỷ lệ sống còn thì thấy rằng là vẫn có những bệnh nhân mà không phải phù hợp để điều trị can thiệp van hai lá.
I think this is a very important slide still for 2020 that we have the great opportunity to help patients with heart failure to improve.
Đây sẽ không chỉ là thách thức mà đây sẽ là cơ hội. Đây sẽ là cơ hội chúng ta để điều trị rất hiệu quả đối với những bệnh nhân suy tim. Tuy nhiên cũng là thách thức để vì chúng ta tìm được đúng bệnh nhân mà sẽ được hưởng lợi từ can thiệp van hai lá. Đây là những thay đổi về test đi bộ 6 bước, 6 phút. Đây là kết quả về nghiên cứu mitral MR. Với báo cáo viên trước thì chúng ta cũng đã biết rằng là có những sự khác biệt về hai nghiên cứu về can thiệp van hai lá.
And in the MITRA-FR trial, which came out negative, there was no benefit.
Kết quả từ nghiên cứu mitral FR là âm tính, có nghĩa là can thiệp van hai lá thì không mang lại lợi ích cho bệnh nhân so với cả điều trị nội khoa tối ưu.
Who were intended to be treated but didn't get a mitral clip after all then in the end. And maybe we can also talk a little bit later about that. So challenge is that there was another trial which was called the co-op trial, the American trial.
Trong khi đó thì trong nghiên cứu có một nghiên cứu co-op thì lại có kết quả dương tính rất mạnh, rất rõ ràng.
Effect like in the co-op trial on patients with heart failure and
Chúng ta thấy là kết quả này mạnh hơn rất nhiều so với những cái nghiên cứu về điều trị thuốc ở bệnh nhân suy tim. Vậy chúng ta sẽ tìm xem là tại sao hai nghiên cứu này lại có kết quả khác nhau đến thế. Và chúng ta cũng đã thấy rằng là có một trong những điểm được đưa ra là do sự khác biệt về thể tích thất trái. Đó cũng có thể là một phần của câu trả lời. Tuy nhiên thì vẫn cần phải tìm thấy những câu trả lời khác nữa để có thể tìm được chính xác đâu là những bệnh nhân có thể hưởng lợi từ can thiệp van hai lá. Một thách thức nữa trong năm 2020 là ngoài microclip thì chúng ta có thể sử dụng những cái thiết bị khác để làm giảm mức độ hở van hai lá hay không?
That reduction of mitral regurgitation will improve that. Until now, it's shown for the MitraClip that there may be in one trial, it's have been proven.
Cái nghiên cứu sử dụng thiết bị.
Showed that they can also reduce mitral regurgitation.
Một thiết bị như chúng ta thấy ở đây thì làm giảm cái kích thước của đường kính van hai lá và do đó cũng có thể làm giảm mức độ hở van hai lá và có tác động tốt lên bệnh nhân suy tim.
And this would lead, if this is also a survival benefit, then this would lead to the estimation that it is the mitral regurgitation reduction which does it, and it's not dependent on which kind of device you use. So these kind of trials we also need is a challenge. Is it the same device to...
Nếu mà nghiên cứu về dụng cụ này chứng minh được sự thay đổi về tỷ lệ tử vong thì chúng ta thấy rằng là ngoài MitraClip chúng ta có thể có những lựa chọn về thiết bị khác về điều trị hở van hai lá.
Regurgitation reduction by mitral valve replacement in comparison to repair. Obviously, all the repair.
Một thách thức nữa là chúng ta sẽ cần phải so sánh mức độ hiệu quả trong khi mổ sửa van hai lá hay là sử dụng một loại cách sửa hở thay van bằng can thiệp.
But
nghĩa là
valves have the potential to be much more effective, but maybe less safe, as we saw already in beginning feasibility trials.
Các bệnh nhân có thể hưởng lợi rất nhiều về mặt lâm sàng, tuy nhiên thì cũng có thể có những vấn đề về tính an toàn đối với các van này khi chúng ta sẽ xem những ca đầu tiên, xem kết quả các ca đầu tiên.
Like in the Apollo trial, or we have data about the tendon valve already. And if we have patients, is it that we have to treat them with the valves, or do we have to wait? This is still a challenge if I look.
Một thách thức nữa là khi có một bệnh nhân hở van hai lá, chúng ta cần phải quyết định là chúng ta sẽ điều trị can thiệp với bệnh nhân hay là chờ đợi và can thiệp bằng dụng cụ gì. Kết luận thì về cơ hội và thách thức, chúng ta thấy rằng là càng ngày càng có nhiều các bằng chứng làm cho thấy rằng là giảm hở van hai lá chức năng sẽ mang lại lợi ích cho bệnh nhân suy tim. bao gồm cả về vấn đề về tỷ lệ tử vong, tỷ lệ sống còn. Có thể chúng ta có thể có những cái cần phải quyết định về vai trò của can thiệp van hai lá thay van so sánh với sửa van. Mình thấy vẫn còn một con đường rất dài để chúng ta quyết định là giá trị của các kỹ thuật can thiệp so với cả mổ van hai lá.
And the last challenge is for me, if it comes to interventional techniques, to see the repair in comparison to the replacement.
Một thách thức khác là chúng ta cũng cần phải làm sao để có thể chọn được đúng bệnh nhân để can thiệp hay là để mổ và mổ điều trị hở van hai lá.
And the last step would be if all this is clear. In the moment, nobody asks if surgery is an option. Surgery is the gold standard for treating this patient. But there are more patients now coming and saying, look, I don't want to have
Hiện nay thì phẫu thuật thì vẫn được coi là một cái phương pháp điều trị tiêu chuẩn. Tuy nhiên vẫn càng ngày càng có nhiều bệnh nhân đến và nói rằng là tôi muốn điều trị bằng can thiệp. Và việc trả lời những bệnh nhân này vẫn là một thách thức cho
just before that there are so many technologies on the horizon.
Và cơ hội ở đây là chúng ta càng ngày càng có nhiều nhiều thiết bị và ngày càng được tối ưu trong tương lai để có thể can thiệp sửa van hai lá. Có thể là không chỉ ở những bệnh nhân hở van hai lá chức năng hay là những bệnh nhân nguy cơ cao, hoặc là mà thậm chí là có thể sửa với tất cả các bệnh nhân. Xin cảm ơn.
Now I can't hear you.
Hello, thank you so much. You can hear me?
Yes.
Okay, thank you so much, and Dr. Olaf Franzen for very interesting presentation. So
cảm ơn bác sĩ Olaf về một bài trình bày rất là thú vị. Trên đây là câu hỏi dành cho các báo cáo viên. Câu hỏi với Dr. Olaf.
Has already become the standard care for the treatment of aortic stenosis, but the transcatheter mitral valve replacement has not been achieved.
Desatavi đã trở thành một trong những điều trị tiêu chuẩn đối với van động mạch chủ. Tuy nhiên thì điều trị can thiệp van hai lá thì vẫn chưa đạt được thành công như vậy. Theo ông thì đâu là nguyên nhân? Đầu tiên là do vấn đề giải phẫu của van động mạch, van hai lá và van động mạch chủ. Thì van hai lá thì phức tạp hơn nhiều. Sau đó rất khó để có thể có được những cái thủ thuật an toàn đối với van hai lá.
Myself didn't show that this was a very safe procedure. Now with the tendine valve, we see it can be much safer, but it is very selected patients.
Nay thì các kỹ thuật thì cũng thể an toàn hơn, tuy nhiên thì nó vẫn chỉ đối với cả một số bệnh nhân nhất định. Hơn nữa là cái cơ chế hở van hai lá cũng rất là phức tạp. Trong đó thì điều trị bằng TAVI thì đơn giản hơn nhiều.
And we have another question for the speaker that in Vietnam we are the developing country, so we still have the rheumatic heart disease, especially the MR is caused by the rheumatic valve disease.
Nay thì ở Việt Nam vẫn còn nhiều tình trạng hở van hai lá do thấp tim.
From from National Center
Năm ngoái, bác sĩ KK ở National Heart Center Singapore thì đã điều trị lần đầu tiên một ca 85 tuổi dùng MitraClip để điều trị hở van hai lá do thấp tim. Ý kiến của ông về hiệu quả điều trị như nào?
Professor Olivier, do you have any comment?
If I understand well, it's regarding the rheumatic disease for the mitral valve. I'm not sure that the rheumatic disease for the mitral valve are the best candidate for mitral clip. I mean that most of the time there is a thickening of the valve, and I think that this is not the good candidate for the mitral clip.
Tôi thì nghĩ rằng là hở van hai lá do thấp tim thì không phải là một lựa chọn tốt đối với mitral clip.
So that can be an issue. So that's the issue, is that I think that's nowadays the best candidate for the age-to-age reparation. I mean, the mitral clip are probably the pure regurgitation without stenosis and with a normal valve leaflet.
Đến nay thì lựa chọn tốt nhất đối với cả kẹp clip van hai lá là những bệnh nhân hở van nhưng không có hẹp van và lá van không bị rớt quá nhiều.
Yeah, sure. I completely agree that if we have a stenosis, if we have thick leaflets and decrease in leaflet motion in diastole, then the patient will not be suitable for mitral.
Tôi nghĩ là những bệnh nhân có hẹp van và có hạn chế về di động của lá van thì không nên làm kẹp clip van hai lá.
The mean pressure gradient between the LA and the LV is not greater than 5 mm of mercury.
Chúng ta phải đảm bảo là sau khi kẹp clip thì chênh áp giữa nhĩ trái và thất trái thì không được quá 5.
Thank you. How about you, Dr. Olaf Razen?
If it comes to selected patients, it has been done. You showed, and it has been done successfully. But the problem is, like the colleagues say, it's on the same like for surgery. You start already with a reduced opening because it's rheumatic disease usually, and you have this commercial fusion in these patients, and you further reduce with the mitral clip this opening. And for most patients, you may try is no pondering, right? Then it's very clear the orifice is too small. In some patients, you may
chúng ta thấy thực tế thì các bạn đã làm và cũng đã thành công. Tuy nhiên phải nói rằng là với những trường hợp mà hẹp van, tổn thương van do thấp tim này thì thực ra thì không tính khả thi thì không cao, và chắc là chỉ có rất ít bệnh nhân có thể thành công bằng biện pháp này. Trong trường hợp mà chúng ta cần phải đến kẹp clip thứ hai thì rất là khó để thực hiện. Cho nên là theo tôi thì đây vẫn không phải là một lựa chọn tốt đối với cả mitral clip. Tuy nhiên trong một số trường hợp nhất định thì bạn vẫn có thể thực hiện.
It's important to consider that we changed the selection process of the patient, and that at the beginning the process was really restrictive, and we select only few patients. And now with the increasing experience of the team using mitral clip, we know that we can do it in some other patient a little bit more different than the first one. So maybe in some really selected patients.
Thực ra thời điểm đầu thì chúng ta mới thực hiện mitral clip thì có rất là nhiều nguy cơ khi mà thực hiện thủ thuật. Tuy nhiên hiện nay thì chúng ta đã vượt qua được nhiều cái khó khăn hơn và có sự khác biệt hơn, nhiều khác biệt so với những ca đầu tiên kẹp mitral clip. Tuy nhiên thì do đó thì có một số bệnh nhân nhất định thì chúng ta cũng thể thực hiện được với dưới hướng dẫn của siêu âm.
Delegates concerned about the feasibility and the effectivity when we use clip for the tricuspid regurgitation.
Tính khả thi và hiệu quả khi mà kẹp clip đối với van ba lá trong trường hợp hở van hai lá.
for the mitral valve because there are 3 leaflets, and the pathophysiology of the regurgitation is
trường hợp này thì khó hơn rất nhiều so với kẹp van hai lá, vì nó có 3 lá van và vị trí thì nó cũng khó tiếp cận hơn rất nhiều.
issue about
Một vấn đề khác nữa là về vấn đề hình ảnh.
transesophageal echocardiography is not
Vì
that
siêu âm tim qua thực quản đối với hình ảnh của van ba lá thì không dễ tí nào.
initial experience about these treatments. It's feasible, we get good results, but still it's much more complicated than for the secondary
Thực tế thì cũng có tính khả thi và thực tế chúng tôi cũng thành công với một số ca. Tuy nhiên thì nó khó khăn rất nhiều so với cả kẹp clip van hai lá.
study that has been published. We will get soon the 2 years follow-up, and there are one randomized study in
Tới nghiên
US.
cứu của chúng tôi với những bệnh nhân kẹp van ba lá thì chúng tôi sẽ công bố kết quả sau khi theo dõi được khoảng 3 năm. Và 5 năm tới khi mà chúng tôi công bố kết quả nghiên cứu thì chúng ta có thể thảo luận tiếp.
I think we can conclude this session.
Chúng ta có thể kết luận về phiên họp này. Đại diện cho Hội Tim mạch của Việt Nam, chúng tôi xin cảm ơn các báo cáo viên về các bài trình bày. Bài báo cáo này thì rất là có giá trị của chúng tôi và hy vọng năm tới là chúng tôi hy vọng có thể mời đón chào các vị đến Việt Nam. Xin cảm ơn.
Thank you for your warm welcome. Thank you.
Thank you. Bye bye. Thank you.
Talk. I'm Joshua from Manly General Hospital, Myanmar. I'm talking about is there any role of thrombolysis in AMI? If someone asks me this question, my answer is yes, definitely yes for low and middle income countries, and still yes for developing countries. As we all know, STEMI is caused by acute thrombotic occlusion of epicardial coronary artery. Aims are to prevent the death, to limit the myocardial damage, to minimize the discomfort of the patients by providing reperfusion therapy either mechanically or pharmacologically. We have known that the improvement in mortality from 30% to 6% by giving reperfusion therapy from pre-CCU era to reperfusion era. But reperfusion therapy should be prompt, but it improves the patient's outcome. According to wavefront theory, the longer the duration of occlusion of the coronary artery, the larger the damage of the myocardium. So the reperfusion should be very quick. There's a golden hour. We can save 65 lives for every 1,000 patients treated with thrombolysis in the first hours. So not only prompt, the reperfusion therapy should be complete to achieve high TB3 flow and myocardial perfusion grade 3 flow. That will improve the patient's outcome. So ideal reperfusion should be rapid, complete, sustained, and less complications. So there are two different types of reperfusion strategy, pharmacological and mechanical. Let's see fibrinolytic therapy. So there are several agents for fibrinolytic therapy that can be used either IV bolus or infusion. In ISIS-2 trial, streptokinase and aspirin reduce 35 days vascular cause mortality from 30% to 8%. In GISI trial, the same, IV streptokinase reduced 21-day hospital mortality 10.7% compared to 30% in placebo. Gastro trial proved that TPA is better than streptokinase. So overall, fibrinolytic therapy improved mortality with slight increase in stroke and major heart bleeding. However, the mortality benefit of fibrinolytic therapy will be lost if it was given over 12 hours of symptom onset. So fibrinolytic therapy that can be given very easily, available in most hospitals and ED, good efficacy in the first 3 hours. But there are some relative contraindication. We cannot use thrombolytic therapy in some patients. So how about primary PCI? It is a reperfusion method of choice, but can achieve high rate of TB3 flow more than 90%, that improve outcome in terms of lower 30-day mortality, lower death and non-fatal reinfarction, and lower rates of stroke. This meta-analysis comparing 23 trials of primary PCI and fibrinolytic therapy. Primary PCI has lower death, reinfarction, stroke, and overall combined endpoint compared to fibrinolysis. However, primary PCI has some problems. But primary PCI is the treatment of choice that's only given in time. So, however, in the real world, all STEMI patients may not be able to receive primary PCI in developed countries as well as developing countries. Most of patients live in a rural area. They may not arrive PCI center in time. Even in the United States, primary PCI can be performed only 25% of acute care hospital. So even patients reach the hospital in time, they may not undergo primary PCI. So more than half of the patients, half of the peoples globally live in rural area, same as in our ASEAN countries. So moreover, there are some obstacles for primary PCI for developing countries. In rural area, no CAT lab, no EMS, no STEMI network. Even there's a CAT lab 24/7 around facilities not available, less number of trained interventional cardiologists. In some countries, they adopted cost-based healthcare system rather than value-based healthcare system. So in that situation, pre-hospital thrombolysis could be the most feasible strategy. So many cities around the world, traffic jam. So ambulance cannot get up on the traffic jam. So we know that the primary PCI is better than fibrinolytic therapy, but that depends on door-to-balloon time. The longer the door-to-balloon time, the higher the mortality. So PCI-related time delay versus mortality benefit in this trial. So mortality benefit from primary PCI may be lost if door-to-balloon time delay by more than 60 minutes compared to door-to-needle time. So every 30-minute delay will increase 7.5% 1 year mortality. Not only that, thrombolysis can be performed equally during regular hour as well as the out of office hour. But for the primary PCI, the door-to-balloon time will be more longer in out of office hour compared to regular hours. So the advantage of PCI will be lost if door-to-balloon time minus door-to-needle time is more than 114 minutes. So even primary PCI is a preferred reperfusion strategy. The limited availability of primary PCI centers, outcomes depend on expertise, operator expertise, and if 2 or 3 STEMIs arrive hospital at the same time, there will be delay for door-to-balloon time. So in such cases, pharmacoeconomic strategy should be alternative. So it is class 1 recommendation in ESC guideline and class 2A indication in American guidelines. So in PAMI trial, PCI followed by fibrolysis will achieve higher TME3 as well as perfusion rate flow. So if we want to overcome these delays, door to needle time and door to balloon time, we should adopt pre-hospital thrombolysis and hospital transfer for pharmacoinvasive therapy. So pre-hospital thrombolysis has more MI abortion compared to in-hospital thrombolysis. In French nationwide registry, pre-hospital thrombolysis is even better than primary PCI in terms of age-related survival. So we need pharmacoinvasive strategy for socio-economic reasons, country-specific healthcare resources, practices, and policies, non-patient-related factors such as transport conditions and location availability of PCI capability. There are several studies supporting pharmacoinvasive strategy. Almost all trials supported pharmacoinvasive therapy is non-inferior to primary PCI. In some study, pharmacoinvasive strategy is even better than primary PCI. 3 registries supporting pharmacoinvasive strategy. In VNHA registry, if thrombolysis can be given 2 hours of symptom onset, that is better than primary PCI. In Manipoli's strategy registry, the pharmacoinvasive strategy is equally safe and effective compared to primary PCI. In French registry, comparing 3 different types of reperfusion therapy, thrombolysis and primary PCI has a similar 5-year mortality. So this meta-analysis comparing 5 different Asian Pacific countries, all country has similar infrastructure and 24/7 primary PCI availability, but in Malaysia, majority 72.6% of STEMI still receiving fibrinolysis compared to 91.6% primary PCI in Korea. So this study done at our hospital comparing primary PCI and pharmacoinvasive using streptokinase. So both groups have equal in-hospital mortality and slightly increased minor bleeding in pharmacoinvasive group. So in India, every year more than 3 million of STEMI, but less than 10% of STEMI patients receive primary PCI. Although there are many hospitals with primary PCI facility, there are several reasons for delay to getting primary PCI. So STEMI India, they adopted STEMI India model to get optimized reperfusion therapy for pharmacoinvasive strategy. So they use spoke and half model. So in India, in 2030, the consensus statement suggested for STEMI patient symptom duration less than 6 hours, fibrinolysis followed by PCI is suggested. So in 2017, both fibrinolysis and primary PCI are class 1 recommendation for STEMI with 12 hours of symptom onset. So this latest 2020 meta-analysis comparing thrombolytic, primary PCI, pharmacoinvasive, and facilitated PCI on 31 eligible articles. According to multivariate network meta-analysis, primary PCI is preferred treatment for STEMI. When primary PCI is not available as a reperfusion therapy, pharmacoinvasive approach is superior to facilitated PCI and standard fibrillary therapy in terms of mortality, stroke, and major bleeding. So that will guide better design of STEMI system of care across the diverse healthcare system. So, ladies and gentlemen, not only PCI, primary PCI and fibrinolysis, there are one more new reperfusion strategy, that is pharmacoinvasive approach that will improve patients' outcome. So, the choice of reperfusion therapies depend on patient orientation. It's not possible to say definitely which reperfusion therapy is better than other. The appropriate and timely use of reperfusion therapy is more important than choice of the therapy. So, fibrillary therapy
point in the new ACS guideline from ESC is that we do not need to preload the DAPT before the angiogram was performed. So, Dr. Yeo, what do you think about that?
Thanks very much. So I think we do have some concerns about that, and I suspect most of us, I think that's really an operational issue and a practice issue within the healthcare systems as well. So in Singapore, we haven't adopted those guidelines, and in our case, we still preload our patients because it is a lot more efficient. And I think that's a system, a hospital and healthcare system constraint. So I think, you know, as we look at those guidelines, we would have to apply it to our local context. Hope that helps. And good to see you.
That is very nice to know. Even in Vietnam, we still preloaded that. Okay, so now I think the video is ready now. So may we broadcast Dr. Srigatili's video now?
Good afternoon to everybody. I'm Dr. Rigatelli. It's a huge pleasure to be here present, even only virtually, to this Vietnam Heart Association meeting. And I miss you all. And it's a huge pity that we cannot meet in person. Anywhere, I think that we can start with our presentation, and the topic of today will be complete revascularization in acute coronary settings, should or should not. Well, I will just start with a clinical case. A male, 70 years old, 59 kilograms, not too much tall, risk factor hypertension, hypercholesterolemia, diabetes, previous ictus. It is a non-STEMI presentation, ejection fraction, 31%, previous aortic bifemoral bypass, OCPD, and a JFR of 61. This is the left coronary angiography. You can appreciate how huge is the complexity of the disease of the left main, LAD, circ, whatever. This is another view, and you can appreciate also the angles of the left circ. And this is the right coronary artery, which had severe subocclusive disease on the first middle portion. Well, what literature told us? A couple slides just to remember you, a couple of very important studies. This is from the last year, the complete trial, patient with STEMI, multi-coronary disease, randomized to complete or culprit-only revascularization, and you can appreciate that culprit-only revascularization has got 30% more of major bleeding and a cardiovascular death or myocardial infarction at 3 years. Another study, more recent, taking account patient with acute coronary syndrome, STEMI and STEMI, and again you can see that complete revascularization has a huge gain of survival compared to incomplete revascularization. There are some general considerations to keep in mind. The symptom score in our patient was 32, high risk for PCI, the Aero score and Aero score 2 told us that the patient was high risk also for CABG. The DAPT score was 3, so high thrombotic risk. The PRECISE DAPT was 23, so moderate bleeding risk. And there was also an 80% long middle distal disease of the lady that we have to consider. However, the patient categorically refused any surgical option, if any, so we decided to proceed with the PCI. This is the shadow of the precise DAPT that show a moderate cluster of risk and a major bleeding risk at 12 months of 1.6%, so not too much. There are some PCI planning to consider. The patient is not a real cheap patient, but it can be considered high risk. The approach was important. We choose radial approach 7-in-6. Also, the possibility to stage the procedure is an option, but we decided for the same session because the patient was stable. So the circulatory support was not possible to implant because of bifemoral bypass surgery. So IVOS is the logical option, and the technique was our usual non-inverted T technique, the old nano crash, and which is really simpler than the culotte decay crash. So we started with the right, and this is the result after 3 Orsiro 2.75 stand. And this is the pre-op angio with the IVUS. We perform also an FFI just to be sure that the real of the real severity of the disease, and you see how much calcium and how tight is the lesion in the run left main versus AD and SEX versus left main. So we start with predilation of the left main, predilation of the left circ, and then we put the stent with a little portion of the one ring into the left main, and then crush this little piece of stent with the balloon, and then the stenting the main vessel, and kissing balloon first, then pot, and another stent into the middle portion of the artery, which has a severe disease. And after final pot, this is the final result, which is a very fine, I think. So this is the run after the stenting, and you see a very nicely implanted stent over all this segment. Also, the FFR was very, very nice. So, which are the consideration to decide to perform in acute coronary setting a complete revascularization? The age, the risk factor, the thrombotic risk, the bleeding risk, in order to choose the proper EAPT therapy. The patient, our patient was put in ticagrelor 90 milligram twice a day for 12 months, plus 60 milligram twice a day for other 6 months. And at 18-month follow-up, the patient was asymptomatic with a negative submaximal hygrometric test, no bleeding, no recurrency, so was switched to mono antiplatelet therapy. So taking account the balance between thrombotic and bleeding risk, keeping in mind the patient renal function, using effective but relatively simple technique. Our patient, in our patient, we use 180 milliliter of contrast medium. You can decide to have a complete revascularization in acute coronary setting and to be successful in this clinical setting. Thank you so much. And I wish you a very pleasant Congress. And again, I miss you all. I hope to see you soon when this pandemic for sure will end. Thank you again.
Thank you so much, Dr. Rigatelli. But due to the tight schedule, I suggest that we move on with the next lecture provided by Professor Yo KK before we yield back for the discussion at the end of the sessions. So please, KK.
Thanks very much, Lin. I recorded the video. Can we use the video?
Sure. Yeah.
KO from the National Heart Centre, Singapore. My talk today is how to demystify MÉNOCA. These are my disclosures as shown on the slide. Well, what is MÉNOCA? In today's discussion, I will talk about the definition, the key diagnostic criteria, its relevance to our clinical work, important differentials, as well as the management. This term MÉNOCA first came about in 2012, during which Dr. John Beltrame discussed the term MÉNOCA as myocardial infarction with non-obstructed coronary arteries. There had been preceding terms used such as MINCA, myocardial infarction with normal coronaries, but what was important in the term MÉNOCA is that you can have coronary artery disease, but as long as it was not obstructive. The relevance of this is that MÉNOCA has a better prognosis than CAD, resulting in acute myocardial infarction. There are different terminologies used, of course, but what is important is that because of the limited data surrounding MÉNOCA, it is important to have the standardized definitions. In this slide here from the Japanese Circulation Journal, you can see that you have difference in outcomes both in hospital and in at 12 months between patients with MÉNOCA and those due to MI due to coronary artery disease. So it is important to be able to define well what MÉNOCA is. The Europeans in 2017 came up with a working paper on MÉNOCA, and now this is important. However, this has been, I would say, the more updated version is from the American Heart Association, which in 2019 put up a scientific statement on the contemporary diagnosis and management of patients with MÉNOCA. Now, I want to highlight a few key differences between the European and the American papers. First, the American Heart Association used the fourth universal definition of MI, which importantly defines or rather differentiates troponin rise as being different in the setting of ischemia versus injury. Because based on the third universal definition, you could have a situation where a patient with a myocardial injury and not necessarily ischemia would have been included. In MÉNOCA, this is for ischemia only. The Japanese had a very nice review also. This is a bit further back in 2016. I just want to highlight a few slides. And again, this was written with John Beltrame as the senior author. In that, what was useful was that the myocardial MÉNOCA can be defined as a myocardial infarction in the absence of obstructive coronary artery disease. And it is really a working diagnosis because it is also a diagnosis of exclusion. Maybe just let me spend a bit of time. When a patient first comes in with an MI, until we do the cardiac catheterization and until we have excluded key differentials, MÉNOCA becomes a working diagnosis. So when the patient first comes in, it is MI, and we do an angiogram, there's no significant coronary artery disease, and we say that, well, maybe it's MÉNOCA, but we got to exclude the presence of, say, Takotsubo, and we got to exclude the presence of myocarditis. So I think this is an important conceptual framework that MÉNOCA is not a diagnosis we can make right at the beginning because you need to exclude key differentials before a diagnosis of MÉNOCA is made. What are the diagnostic criteria? This is taken from the Japanese paper I showed earlier on. Well, first it has to meet acute myocardial infarction criteria. This includes a positive cardiac biomarker with at least one value above the 99th percentile, and there has to be a typical rise and fall in serial levels. And there should be other clinical evidence of MI, such as ischemic symptoms, ischemic ECG, new pathological Q waves, new loss of viable myocardium on some form of imaging or in regional wall motion abnormalities. Second, there should be absence of obstructive coronary artery disease on angiography, and largely this is defined as the absence of lesions greater or equal to 50%. And then, of course, lastly, no clinically apparent cause for the acute presentation, such as myocarditis. The more detailed definition is seen on this slide, which is from the American Heart Association guideline. The only thing which I think is additional to what I had, in addition to what I had showed earlier on in the preceding slide, is point number 2, where you see that it is defined as the absence of any CAD as defined as nothing more than 50%, but you can have in the subsection there showing normal coronary artery disease, in other words, no angiographic stenosis. Next line, mild luminal irregularities, that is less than 30%, or moderate disease, that is between 30 and 50%. Point number 3 also highlights some of the alternate diagnoses that are shown, such as sepsis, PE, or myocarditis. Now, this is a very important slide that is really the crux of how we should think about MÉNOCA. So, if you look at the top, this is what they call the traffic light scenario, or the sequence of thinking. If you look at the top of the slide, you have the clinical presentation, which is what was seen in the definition. And then you have the working diagnosis, and then finally the diagnosis of MÉNOCA. So going from top to bottom, the clinical presentation, additional investigations, the alternative diagnosis may be obtained, and clearly if you have pulmonary embolism, this will not be MÉNOCA. The working diagnosis looks at other problems which may result in ischemia or myocardial injury, and for the top panel, the top panel in the yellow box, review angiogram for, say, spontaneous coronary artery dissection, missed occluded flush occlusion of side branches. You look for left ventricular functional assessment, such as Takotsubo. Now note that Takotsubo is technically not a myocardial infarction based on the 4th universal definition, and therefore would be excluded from a diagnosis of MÉNOCA. And then if you can also look for myocarditis again, which would exclude MÉNOCA. And then finally, if you've done all that and this is not, and none of the key differentials are present, then you would have said this is probably MÉNOCA, but you might want to look for other causes of ischemia which will be compatible with MÉNOCA, such as plug disruption and very distal embolization, the presence of dissection without significant occlusion, significant obstruction, microvascular disease, spasm, etc. So this workflow is critical, and I would like you to remember this, and I will reference it towards the end of the talk as well. Now, some key points to note. I've already mentioned that Takotsubo is not considered an MI and therefore technically not MÉNOCA. Next point is that not all tests that are listed in that workflow are available in every country or every hospital, and therefore may not be reasonable from a practical point for your general workflow. This, for example, would include MRI scans for the heart. Third, this is a dynamic diagnosis and a working diagnosis that I've mentioned before, meaning it can change. For example, you might have somebody come in as a so-called Takotsubo, you do an MRI, and then you find the presence of myocardial injury or infarction, and then that would make it more MÉNOCA. And if you have a diagnosis of MÉNOCA at the beginning, and then you you find out that there is myocarditis on MRI, and this would then therefore no longer make it a MNOCA. The evaluation of ischemic mechanisms will also need to be considered on a case-by-case basis. For example, for a variety of reasons, not every hospital or every case will require OCT, FFR, IVUS, etc., etc. And of course, for the diagnosis of coronary vasospasm, the traditional acetylcholine challenge may not be performed in every hospital. For example, I've not done it in Singapore at all, partly because we don't think it's necessary, and it is there's some element of risk as well. This figure from the AHA statement highlights some of the differential diagnosis which may help inform us of the specific causes of MNOCA, for example, plug rupture, spontaneous coronary artery dissection, microvascular dysfunction, etc., etc. What is the management? First, I think very like all cases of myocardial infarction, we deal with the emergency care first. So, and that includes supportive care, oxygen, diuretics, etc., morphine if needed. And then there's the cardioprotective care, antiplatelet agents, statins, ACE inhibitors, ARBs, beta blockers, etc. Now, I want to add that there's some nuance here because of the nature of the underlying pathology. Not every case will require a statin. For example, the data or the evidence base for, say, microvascular disease is a lot less clear as to the role of some of these agents. Of course, we like to treat the underlying reversible risk factors. If there's diabetes, hypertension, smoking, these should be addressed, and of course then cardiac rehabilitation after the event. Bear in mind that there will be some evidence of myocardial injury arising from the ischemia, so cardiac rehabilitation is important. The treatment of the underlying specific cause is crucial because obviously if there is a coronary vasospasm, the use of vasodilators such as nitrates and calcium channel blockers would be important. Now note that stenting is not routine for these cases, and we shouldn't think that because there's an MI, we should stent. And in fact, I would say that unless there's a clearly abnormal area of plug rupture that you think would be highly at risk of thrombosing, stenting is not the standard of care in this setting. This next two slides show some of the specific management for selected conditions. And this, of course, is not just for MNOCA. This is also for everything else, such as the cardiomyopathies. This is more along the causes of the specific causes of MNOCA, such as coronary artery spasm seen in the second row, where the use of calcium channel blockers, etc., is one such agent. The use of other treatments, say under coronary embolus or thrombus in the fourth row, would include, of course, antiplatelet and or anticoagulation therapies. And the underlying hypercoagulable states should be treated. The prognosis for MNOCA is generally better than CAD due to MI, but recurrence is possible. One study quoted a 25% risk of recurrent angina within a year. And in the NZAC registry, you can see that the rate of MI or death is not low at 4.6% over 2 years, compared to 2.2% in age and gender matched patients without prior coronary heart disease or diabetes. In the Sweetheart study, looking at a mean of 4.1 years of follow-up, the mortality was as high as 13.4% and the MI rate of 7.1%. But bear in mind that these are retrospective registries, and we would have to be mindful that the data may be different if we look at it from a prospective, very detailed cohort point of view. In my last couple of slides, I want to summarize the key concepts. This is MNOCA is a myocardial infarction, but with non-obstructing coronary artery disease. Ischemia must be present. This is not just injury from other causes like myocarditis. It is not Takotsubo. It is ischemia driving the MI, but in the absence of significant coronary artery disease. We therefore must exclude other causes, and in addition to general treatment, specific treatment depends on the underlying cause. Again, I want to finish off with this very important slide, which I think is the key to demystifying MNOCA. first you make a diagnosis, you exclude the key differentials, and then you work and exclude other causes which may mimic MI, such as Takotsubo or a missed flush occlusion. And then finally, you have a diagnosis of Minoka, and you try to look for the underlying specific diagnosis, which may include coronary spasm, microembolus, etc., etc. With that, thank you very much. Thanks very much, everyone.
Okay, for great lectures. So now I think we have about 10 minutes for discussion. But Dr. Rigatelli, about your presentation about complete revascularization, do you think that we should do it in one stage or multiple stage PCI for patients with multivessel disease?
It depends, I think, on the renal function and the hemodynamical status of the patient. Now the guidelines, the 2020 guidelines on acute coronary syndrome say that it can be done in one session if the patient is hemodynamically stable. So I think that you have to consider the stability and the renal function. If the patient is stable, renal function good, you can go for one same session. On the contrary, you can fix the worst lesion and then take another session for the complete revascularization. The trial I show you in the presentation didn't focus on two stage or one stage. They are focused on complete or incomplete revascularization. So I think it depends on clinical status and renal function.
Yes, thank you. But I mean, if you want to open all the vessel in normal clinical practice, you do it in one hospital phase, or you let the patient discharge and then you do let him admitted again and do it in the second.
No, normally, yeah. Normally we do in two sessions if we need to do in two sessions, but without discharging the patient home.
Okay.
Within the same hospital stay, 1 week. Normally we do the worst, and then after 2 or 3 days we do the complete.
Yeah, thank you. So Professor Kyo Sowin, what is your practice when you have to open all the vessels?
Yeah, we normally do perform complete revascularization, but you know that's depend on individually. If patients' renal functions, you know, if patients and elderly function, if we cannot use too much contrast, we stage the procedure. So even though there's a complete revascularization is better than the stage revascularization, I think we should be individualized and the patient, different patient settings. Thank you.
Yeah, thank you.
Prof. Ajanta, I have a question to you. And you have mentioned that prasugrel, you prefer prasugrel, the guideline prefer prasugrel than ticagrelor. In our country, you know, we mostly have the clopidogrel, and then we have a generic prasugrel, but no ticagrelor. So what's the reason that prasugrel is more preferred to the ticagrelor?
That is the recommendation. That is the recommendation of the European Society of Cardiology in their 2020 from the findings of the ISARECT 5 trial where they found that the prasugrel is more beneficial than the ticagrelor in respect of the P2Y12 inhibition, and also without any extra bleeding risk. So, for the last long time, it was the ticagrelor which was the drug of choice. But this guideline, they changed on the findings of that. That was a very big trial, the ISAREC trial, ISAREC 5 trial. So, the ticagrelor is the 2A indication. So it is not that we cannot use the ticagrelor, and there is also one option of the de-escalation from the ticagrelor or prasugrel to the clopidogrel if the patient has got the increased bleeding risk. So I think these are all the P2Y12 inhibitors are indicated. No one is contraindicated, but they are the choice, depending on the choice which one will use. It is also depend on the cost and availability of the country. You know, the prasugrel is costlier than the ticagrelor in our country.
Thank you. I have another question to Prof. Kiki. Kiki, that you have, I heard that you have mentioned about the microvascular spasm. And how would you differentiate between coronary artery spasm and microvascular spasm?
I think that is very difficult. I think for practical purposes, some people have used the TIMI frame rate counts to see the flow of contrast. Others have used what is it? There's this not FFR. I forgot the name. You know what I'm talking about? The
IFR?
Not IFR, no.
CFR.
CFR to help assess that. And others have used acetylcholine challenge test to study that up. Frankly, for practical purposes, we don't do it. And what I've done in clinical practice is that on rare occasions, you do catch the spasm happen. I remember a long time ago, we had a death from it. Patient had a massive spasm and had an arrhythmic arrest. But on other occasions, you can treat empirically with a calcium channel blocker and watch for clinical improvement. But honestly, I think we have limited experience with this with Minoka due to coronary vasospasm. So I suspect it might be a diagnosis made on circumstantial evidence. Happy to hear the thoughts from others, though. I mean, I think this is not something that we have. I don't have that much experience on, and happy to hear others' thoughts on it.
Yes. If you don't have any questions, I think we can close the sessions now. And on behalf of the Vietnam National Heart Association, I would like to say thank you so much for joining us today. The COVID-19 has changed everything, but we do hope that everything will be back to normal again and we can meet each other in person. And I really appreciate your lecture, and I think that all of the audience will learn a lot from that. Thank you so much.
Thank you very much. Thank you. Good to see everyone. Take care. Bye-bye.
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 Okay, so welcome every people. Welcome to the last section today involved in the appropriate test for the chronic coronary syndrome. I am Dr. Quang from Vietnam National Heart Institute, and we have a very famous expert from the French. We have a Professor Olivier Lazier from Toulouse, Ranger University Hospital. We have a Professor Edouard Donan from Hospital Pontchartrain, Rennes. And we have a Professor Hubert Couchet from University of Bordeaux. So welcome on you, our local
participants on live and our faculties. You might know that for the chronic coronary syndrome, it's very important to choose the appropriate imaging test, and this depends a lot on the local expertise and also the evidence-based what we have today. So to start the program, we start with the first lecture about the scintigraphy, when to choose the nuclear imaging for chronic coronary syndrome and how to interpret. Present by Professor.
Hello everyone. I want to thank the scientific committee to give me the opportunity to do this presentation about the choice of the appropriate technique to explore patients with chronic coronary syndromes. I'm going to talk in this presentation about the nuclear cardiology and the nuclear technique for exploration of myocardial perfusion imaging, and these are my disclosures. So first, it's important to consider the ischemic cascade. And if we consider the ischemic cascade, we will see that the first step of the coronary artery disease, I mean, when there is a functional repercussion, will be the perfusion abnormality, and then the diastolic dysfunction, then the systolic dysfunction, and after that, the ECG modification, and at least the chest pain. So if we want to diagnose coronary artery disease at the beginning of the functional repercussion, the best technique probably will be to explore the myocardial perfusion. Nuclear medicine allow the myocardial perfusion exploration, and the principle is pretty simple. You administrate a radiotracer inside the blood, and the myocardium is going to extract the radiotracer, and the images are going to give you the myocardial blood flow, which will be proportionate to the extraction of the radiotracer by the myocardium, and will be proportionate to the myocardial blood flow. So the second principle will be to explore that during a stress, and you can the best stress is probably to do exercise, and in the normal situation we will have a normal myocardial perfusion at rest, but during the stress, if there is a coronary artery stenosis, the coronary flow reserve will not be enough to compensate the coronary stenosis, and we will have a decrease of the myocardial blood flow. So myocardial perfusion imaging allows to see this difference between a normal myocardial blood flow and impaired myocardial blood flow because of the coronary stenosis. And the principle of nuclear myocardial perfusion imaging is to compare normal perfusion to impaired perfusion. So the interpretation is pretty easy, and you can see there that on the top you have always the stress, and on the bottom you have the rest, and you have different view of the left ventricle, and you can see there is a myocardial perfusion defect on the lateral wall, and this defect is reversible at rest. So there is a defect during the stress, and this defect is reversible at rest, and you can see the same there in the lateral wall, and this is the typical aspect of myocardial ischemia. So the interpretation is pretty simple. So the myocardial perfusion imaging is probably the oldest and the most validated technique to explore myocardial perfusion and myocardial ischemia. And you can see there that the technique has a pretty good sensitivity and a specificity of 85%. And we will see that there is maybe more sensitive and specific technique, but we will see that nuclear cardiology is the oldest technique and the most validated technique in clinical practice. And I think that one of the advantages of nuclear cardiology is to allow the quantification of ischemia, because we know that it's not enough to say that there is myocardial ischemia, and particularly since the last result of the ischemia study, we know that the quantification of the myocardial ischemia is really important, because the prognosis will not be the same according to the quantification of the myocardial ischemia, and more you will have a myocardial ischemia and poorest will be the prognosis. So it's really important to be able to quantify the myocardial ischemia, and nuclear cardiology, myocardial perfusion imaging allow the quantification of the myocardial ischemia. And that's particularly true if we consider the result of the sub-study of the COURAGE study. And in this sub-study of the COURAGE study, which compared PCI to optimal medical treatment, they show that independently of the technique choose to treat the myocardial ischemia, the presence of residual myocardial ischemia was associated with a poorest prognosis, and this prognosis was decreased if the myocardial ischemia was the residual myocardial ischemia was greater than 10%. So it's really important to be able to quantify the myocardial ischemia. So myocardial perfusion imaging using nuclear medicine allow the quantification of the myocardial ischemia, and you can perfectly quantify the myocardial ischemia and the reversibility of this myocardial ischemia comparing stress images and rest images. But I think that one of the best and the most advantage of the myocardial perfusion imaging using nuclear medicine is to be able to quantify the depth of the myocardial ischemia, because if you consider a normal flow and a flow with a coronary stenosis, you will be able to quantify the difference between the normal flow and the stenosis using color scale, allowing to perfectly assess the depth of the myocardial ischemia. So in practice, it's pretty easy to interpret. You are doing the stress images. If the stress images are normal, the rest images are going to be normal. So there is no myocardial ischemia, there is no myocardial infarction, and in practice, the test is normal. If you have a defect during the stress images, you have to do the rest images. And if the rest images find the same defect, the defect is fixed, that's probably a myocardial infarction. That's typically the aspect of myocardial infarction. If there is reversibility, this is typically the aspect of myocardial ischemia. Defect during the stress, reversibility, and normality at rest. And if there is partial reversibility, that means that there is probably subendocardial myocardial infarction with probably residual myocardial ischemia. And this is the typical aspect of this last presentation. And you can see there is a septal, infraseptal defect and a little bit inferior defect during the stress, and you can see that there is reversibility of these defects there, and there is partial reversibility, probably because of subendocardial myocardial infarction there in the infraseptal wall with a residual myocardial ischemia. So the interpretation is pretty easy. The last advantage of SPECT, of myocardial perfusion imaging using nuclear medicine, is probably the ability to use exercise. And we know that in this study, after adjustment for age and cardiovascular risk factor, we know that the prognosis is better if we can perform exercise. And in all the technique exploring the chronic coronary syndrome, it's important to be able to perform exercise, because we know that exercise by itself can explore the prognosis of the patient, and the prognosis is better if patient can perform exercise rather than pharmaceutical stress. This is exactly the same result, showing that exercise is always better with a good prognosis. But probably the main advantage of nuclear medicine is to be able to perform mixed stress, and in patients unable to perform maximal exercise, you can combine exercise with pharmaceutical stress with a good results according to the prognosis. And we can see that patient, even in this is the quantification on the right. This is the quantification of the defect perfusion, and we can see that even in the presence of high defect perfusion, patients with mixed stress have a better prognosis than patients with pharmaceutical stress alone. So in all the cases, it's better to be able to perform exercise, and nuclear medicine allow to perform exercise, which is not the case of MRI, for example. But the main limitation probably of the technique is that in patients with balanced coronary artery disease, we will not be able to see a difference between the different parts of the left ventricle. That's why we can quantify the function by using gating, like gating that we use when we are doing computer tomography. And this gating allows the quantification of the function. And we know that in patients with post-stress left ventricular dysfunction, there is an increase of cardiac death, and that can be really useful in patients with a moderate or mild abnormal result, because in this patient we know that if there is a left ventricular dysfunction after the stress, we can, that's probably because these patients have balanced coronary artery disease, and that's increased the risk of cardiac death. So that's the standard use of nuclear medicine to explore myocardial perfusion imaging, but there is a lot of perspective in the field of nuclear imaging, and the perspective are the new CZT cameras allowing dynamic acquisition, as you can see in this image, and the dynamic acquisition allow the fast acquisition of the uptake of the tracer by the myocardium, and allow the quantification of the uptake. And this quantification allows the quantification of the coronary flow reserve by comparing the stress myocardial perfusion and the rest myocardial perfusion. And the coronary flow reserve, it's well correlated with the extension of the coronary artery disease. But the main advantage is that most of the time we are exploring the macroscopic coronary artery disease, but we know that there is microvascular disease, and the microvascular disease is really important to assess and to explore, and the quantification of the disease is important since microvascularization account for more than 60% of the total circulation of the myocardium, of the coronary artery disease in the myocardium. And that's why the quantification of the coronary artery, flow reserve is really important. And I just want to show you kind of application of this kind of tool. If you consider patients with diabetes and the coronary artery disease, these patients have a high risk of a cardiac event. And the patient without coronary artery disease and with diabetes mellitus and with low coronary flow reserve have exactly the same level of event than patient with coronary artery disease. And if you consider the same patient with diabetes but with normal coronary flow reserve, these patients have exactly the same risk than patients without diabetes. That means that the issue is not the diabetes. The issue is the impact of the diabetes on the coronary flow reserve. And the coronary flow reserve is the most powerful tool to explore the coronary risk of our patients. That's why I think that it's the most interesting perspective in the field of myocardial perfusion using nuclear cardiology. So in this presentation, I didn't talk about positron emission tomography, and we know that this is the perfect tool to quantify, sorry for the mistake, to quantify the myocardial blood flow. But in practice, it's really expensive and is not used in other countries. And for example, in France, we cannot use it to quantify the myocardial blood flow. So to finish and to summarize, I think that nuclear myocardial perfusion imaging is the oldest and the widely validated technique in the diagnosis and the risk stratification of patients with coronary syndromes. And I think that in my practice, I use it for all the high-risk patients. I'm using to the detection of the disease, obviously, but I'm using it also for all my high-risk patients because I think that this is the most powerful technique for the quantification of the myocardial extension and the myocardial ischemia depth and the risk stratification. And I think that there is a lot of perspective for this technique to quantify the coronary flow reserve and to better assess the risk of our patients. Thank you for your attention.
Thank you, Professor Olivier Lade. This is a great presentation. And I just have one question before we move on. Is there any difference between the scintigraphy agents? You can normally you see like in some center they use the gallium, some center they use the fructose, some center they use a different agent to do the scintigraphy. So is there any different and impact on the interpretation?
Yes, you're right. In practice, you can use the most used tracer are the thallium and the technetium. And in practice, the thallium is the better tracer because the thallium has a really better extraction, first pass extraction. So the sensitivity and the performance of the thallium is better than the technetium. But in practice, the thallium give a little bit more radiation, and it's a little bit harder to manage thallium because the half-life it's a little bit longer, and it's hard to deal with the thallium. So in practice, technetium is most used than the thallium, but the thallium is better than the technetium. I didn't talk about that. You're right.
Okay, so we went back to the discussion later on. So I think that we move to the next lecture from Professor Edvan Donan, talking about when we choose the stress echocardiography for chronic coronary syndrome and how to interpret it.
Hello everyone, and thank you for providing me the opportunity to discuss with you today the stress echocardiography for the chronic coronary syndromes and how to use and to interpret the stress echocardiography nowadays. I know that after me will be discussed the CMR, the nuclear techniques and the CT. So first of all, I want to make few statements. Of course, there is no competition between modalities. Strengths and weaknesses of each modalities exist. Availability and local expertise is the key point to choose between all the techniques that you might have. And never forget that the most important is to select appropriately the patients and the indications and to know about the pre-test risk of positivity of the test. It is important to know about the clinical condition of the patient, the risk factors, and why do you perform the stress echocardiography. If you look at the very recent guidelines about chronic coronary syndrome, you see that you shouldn't use anymore the exercise stress test without any imaging techniques. You can consider the stress echocardiography as well as the nuclear techniques as well as CMR according to the expertise and the availability of the techniques. But really, we are cardiologists and we have to think about the risk of the patient and to use the imaging techniques that fit the best with the risk of the patient. If the risk of the patient to have a coronary artery disease is very low, you probably use the CT to exclude any coronary artery disease. So you look at the anatomy. If there is a risk that the patient has a severe coronary artery disease, then you will use an imaging techniques to assess the consequences on the myocardial function of this coronary artery disease. I will not make a competition between nuclear techniques, echo, and CMR. There are several scenarios. You might have a patient with a stable angina or dyspnea, and you look for the severity of the coronary artery disease and the consequences of this coronary artery disease on the LV function. You might have a patient with a coronary artery disease who develop heart failure. You can have asymptomatic or symptomatic patients that have been revascularized, and then you might want to look at the consequences of the revascularization. You can try to find the reason for angina in a patient with a normal coronary artery angiography, looking for vasospastic or microvascular disease. You can look at asymptomatic subject for making sure that he has no coronary artery disease, and this is especially the case when you have a patient pre-anesthesia for high-risk surgery. And then you might look at the functional consequences of a potential coronary artery disease before the anesthesia. But before discussing any imaging techniques, you have to assess the pre-test probability of any coronary artery disease. And you can use these tables that is published in the guidelines. You see that if you have typical chest pain and if you are a man older than 70, 50% of the patient will have a positive stress test, which is completely different if you are a young man with atypical chest pain, where the risk is about 4%. So when you have a patient with a high clinical likelihood of coronary artery disease, if you think that the patient might need a revascularization, you use an imaging techniques to assess the consequences of the coronary artery disease on the myocardium. You can use nuclear techniques, you can use CMR, or you can use echo according to the guidelines. If you compare the techniques, you see that according to the coronary angiography, there is no techniques that seems to be much better to the other. Perhaps the localization of the ischemia is techniques or CMR, but the sensitivity of stress echo is much better. So you can use all the techniques according to the expertise and availability of the tools that you might have in your lab. Echo might be quite interesting as a first step. Why? Because you can use echo to first start by the rest echocardiography, looking for valvular heart disease, looking for the filling pressures, the right heart function, and the precise LV systolic function, regional and global LV systolic function. You start by this rest complete echocardiography, and then you will use dobutamine or exercise to test the same echocardiography when the patient is under a stress, pharmacological one, or exercise. You have tools now to display the images on a quad screen format, which makes easier the interpretation of the images. Most of the time, we prefer exercise stress echo because it's more physiologic, but sometimes the patient is not able to exercise or will not be able to exercise enough to get to the optimal frame rate, and then in that case, we use dobutamine stress echo. You have the protocols on the slide. Which is important is that when you use exercise stress echo, you really assess everything at every single step of the exam, which means that you will look for mitral regurgitation, you will look for for pulmonary pressures, you will look for regional and global LV function. You will look at the size of the ventricle and the function of each of the segments. It's a bit different when you do a dobutamine stress echo because most of the time you focus on the regional systolic function of the left ventricle. To quantify the potential ischemia, you can use wall motion score, as you can see on that slide. And when you don't feel comfortable because of the image quality, if the echogenicity of the patient is not good enough, then you can use contrast echo. You can use contrast echo to opacify the left ventricle, and you can also use contrast echo to quantify the perfusion of the left ventricle. You can do both, but most of the time, because it's very easy, we use contrast echo just to opacify the left ventricle and then to best assess the wall motion score qualitatively. It's very easy and very convenient. There is something that is important when you consider stress echo, because we have a large amount of data coming from the Mayo Clinic and other large labs showing that if you have a normal stress echo, the prognosis is very good. And the prognosis of a patient is decreasing according to the wall motion score during the stress echo. Also, it is important to see that if you have a wall motion score greater than 1.7, if you don't revascularize the patient, the risk of event is very high. So you see that you use the wall motion score to assess the risk and to push for a revascularization that might change the prognosis of the patient. It has been demonstrated, it's quite robust, and it's clinically meaningful. But when you use stress echo, which looks quite easy because you can do it in every single echo lab, but you have to get the expertise to look for the wall motion score, to precisely understand what's going on during stress echo, the stress and the increase of heart rate. And you have to be confident enough to push forward the heart rate to make sure that you have a maximal exercise stress test. Because if you don't get the maximal heart rate, the sensitivity and the specificity of your exercise stress echo will decrease. So you really have to use dobutamine or exercise with atropine if you use a pharmacological agent to increase the frame rate, the heart rate enough to make sure that you have the appropriate sensitivity and specificity of your exercise stress test. It has been largely demonstrated that exercise stress echo is powerful to diagnose coronary artery diseases in women, in patients with left ventricular hypertrophy, in patients with left bundle branch block, and in heart transplant patients. So we have a large amount of evidence to demonstrate that if you have the expertise, you can look at coronary artery disease and to diagnose coronary artery disease by stress echocardiography. you look for the regional function, you look for the enlargement, the potential enlargement of the left ventricle under the stress, pharmacological one or exercise. If you have an enlargement of the left ventricle during a dobutamine stress echo, it means that you probably have a three-vessel disease, and it's very severe. So look at the regional function, look at the thickening of the left ventricle in every single segment, but look also at the size of the left ventricle, because it's very interesting to diagnose three-vessel diseases. We have to look at the thickening of the myocardium at rest and during the stress. It is sometimes difficult to interpret. If you are a young cardiologist, if you don't have the expertise, you can use speckle tracking, longitudinal strain. It has been clearly demonstrated that longitudinal strain is very sensitive to ischemia. You see, in that example, you have a post-systolic shortening that is induced by a stenosis of the right coronary artery. So you can use longitudinal strain, speckle tracking, to quantify and to confirm what you think when you look by your eyes at the wall motion score and the myocardial thickening. You see that you have a decrease in longitudinal strain according to the severity of the coronary artery disease. Speckle tracking is very easy to perform, it's quick, it's robust, and it provides you something else to make sure that you interpret appropriately your exercise or dobutamine stress echocardiography. It has been very recently published, normal response to exercise when you consider speckle tracking technique. And you see that if you have a good image quality, you can use speckle tracking even during an exercise stress echo. The reproducibility is very good, and it increased your capability to make the appropriate diagnosis, and it improves your ability to localize more precisely the segments or the localization of the ischemia. You can do even better if you use the speckle tracking and the blood pressure to compute the myocardial work. It has been demonstrated also that you can use myocardial work at rest and during an exercise stress echo. And it's very interesting because you decrease the impact of the afterload on your assessment of the wall motion score because of the computation of the strain with the pressure, and then you increase the sensitivity of your exam. As you can see on that example, there was a doubt about the anteroseptal apical segments at rest. When you use speckle tracking and the quantification of myocardial work during an exercise stress echo, you see in green that you have a severe abnormality of the deformation related to pressure loops of the anteroseptal apical segments, which means that this segment is ischemic. It was not that evident at rest. It was not evident if you look at the images only, but it's quite clear if you look at the myocardial work during the exercise stress echo. So my take-home messages are that stress echo is perhaps not that fancy nowadays. We have other techniques that might be more fancy, but it could be great, especially in great hands. You have to get the expertise. You have to use these techniques in a lot of patients before being sure that you do the appropriate interpretation of the exams. The beauty is that you are a cardiologist, then you use the imaging techniques, but before you can discuss with the patient, you can appreciate the pretest likelihood, and you can assess the risk factors of the patients. Stress echo has been demonstrated as a good test, very predictive of clinical strong events in many clinical situations, left bundle branch block, women, heart transplant patients, for instance. And you can improve your ability to quantify and to localize the ischemia, considering not only your eyes and the assessment of the thickening of the myocardium, but looking also at longitudinal strain and myocardial work, if you have the tool, to best quantify and understand what is going on segment per segment. Thank you very much.
Thank you, Professor Edward Donan, for the great talk about the stress echo. I just got a short question before we move on. You mentioned about the longitudinal strain for the predict the event. So this is mentioned about the global, or this is mentioned about the regional strain set?
That's a good question, thank you. And thank you also for the invitation, of course. It's true that if you look at the global value, if you have the global value, you will be able to see that you have a decrease in the global value according to the severity of the ischemia. So it's more powerful if you have a 2 or 3 vessel disease. So this is for the answer about the GLS, so the global longitudinal strain. But you can also look at the regional function, and you are able to look for the systolic and the post-systolic shortening. If you have a prevalent post-systolic shortening during the stress, it means that you probably have an ischemia, and then it's quite useful to use also this strain data set regionally, looking for the post-systolic shortening and not only the peak value.
Okay, so it is more clear to the local audience now. So to move on, and we back to you later on for the discussion. The next presentation would be by Professor Hubert Cochet, when to choose the computer tomography for chronic coronary syndrome and how to interpret it.
Hubert Cochet, Professor of Radiology at the University of Bordeaux, and I will present on when to choose computer tomography for chronic coronary syndromes and how to interpret it. First, cardiac CT methods are not limited to coronary CTA. One can perform calcium score, coronary CTA, venous CT, late enhancement CT, dynamic CT, or even perfusion CT. So cardiac CT has become a highly versatile technique, and coronary CTA is just one part of it. But for the sake of this presentation, we will focus on the use of coronary CTA in patients with stable chest pain. So the rationale to use CTA in patients with stable chest pain is to discriminate between patients with no wall motion abnormality that will require no therapy, patients with non-obstructive CAD that will require a modification of risk factors, potentially a treatment by statin and aspirin, and patients with obstructive CAD that may require coronary angiography and PCI. Obviously, this purely anatomic assessment leaves some gray zone where functional tests may be needed, either because the stenosis is of unclear significance or because the imaging is non-diagnostic. These functional tests may be performed as a second-line approach, using various methods, including some with CT. So the most critical part of the interpretation is to categorize the stenosis significance and discriminate between patients with no stenosis, minimal stenosis, 1 to 24%, mild stenosis, 25 to 49, moderate stenosis, 50 to 69, severe stenosis, above 70, and occluded arteries. And obstructive CAD will be defined as stenosis greater than 70% in diameter on all arteries except for the left main, where the threshold will be set to 50%. This stenosis measurement is assisted by post-processing software, and most vendors now provide very user-friendly interfaces in order to precisely quantify this stenosis in diameter. And then once the stenosis is characterized on all three vessels, the report has to follow a standardized reporting classification system called the CAD-RADS. CAD-RADS 0 referring to no stenosis, CAD-RADS 1 to minimal stenosis, and CAD-RADS 2 to mild stenosis. In these patients, the chest pain is most likely not due to coronary artery disease, but the finding on CT may motivate the introduction of preventive therapy. CAD-RADS 3 refers to moderate stenosis, and this is the gray zone where functional assessment may be needed. CAD-RADS 4 refers to severe stenosis, so hemodynamically significant stenosis. 4A, when the severe stenosis is found on less than 3 vessels, and 4B when it's a 3-vessel disease or a left main stenosis. CAD-RADS 5 refers to total occlusion, and CAD-RADS N to a non-diagnostic study because of motion artifact or issues with the acquisition. Here are some examples of patients with stable chest pain. The first one, totally smooth arteries, will be categorized as CAD-RADS 0. Second one, a focal calcification with minimal stenosis, CAD-RADS 1. Third one, a mixed plaque on the proximal LAD, categorized as CAD-RADS 2. Another one on the CX, this stenosis was categorized as CAD-RADS 3. And here are examples of CAD-RADS 4. This one on the LAD, categorized as 4A because on only one vessel. Here is the finding of the invasive angio. And this one categorized as 4B because severe stenosis was found on all 3 vessels. Another way to categorize a patient as CAD-RADS 4B is the finding of a stenosis on the left main. Here is an example, a stenosis quantified as greater than 50% on the left main. And this is an example of a CAD-RADS 5 due to the finding of an occlusion on the RCA. So the use of coronary CTA in stable chest pain has been validated by landmark randomized control trials. The first one, the PROMISE study, studied more than 10,000 patients and compared a strategy using CTA versus one using functional tests. Results showed similar outcomes at 2 years, meaning that it's a safe alternative, but the results did not show any difference in terms of myocardial infarction or mortality. The second one, called the Scott-Hart trial, included over 4,000 patients. CTA was there compared to standard care, and the findings were that there was a lower mortality and a lower rate of myocardial infarction at 5 years in the group that underwent CTA. So let's focus a bit on this study because it is the one currently impacting the most the newest guidelines. So this was a randomized control trials where half of the patients underwent standard care, including CTA, and the other half standard care alone. All patients presented with stable chest pain. The primary endpoint was death from coronary artery disease or non-fatal myocardial infarction at 5 years. And the results showed that there was in the group undergoing CTA a lower rate of myocardial infarction and a lower rate of death from coronary artery disease. And this was not due to an over treatment by revascularization or coronary angio. When comparing the two groups, the rate of invasive angio and coronary revascularization was similar. In other words, the conclusion is that coronary CTA may save lives but not because of finding obstructive coronary artery disease, but thanks to the introduction of statin and aspirin and the modification of risk factors in those in whom CTA found non-obstructive CAD. And this is the strength of the method, to be able to detect coronary artery disease even when it's not hemodynamically significant. And it's the main difference versus the functional tests. So one very important step of the reporting is the description of this plaque composition. It can be performed easily by discriminating non-calcified, mixed and calcified plaque, or in a bit more refined way by detecting high-risk features. The napkin ring sign refers to hyperintensity at the periphery of the plaque. That tells us that there is some inflammation going on. Another high-risk feature is the low attenuation, when the pixels value within the plaque are below 30 Hounsfield unit. This indicates that there may be a fatty content of the plaque at higher risk of rupture. The calcifications are considered as stabilizing the plaque when they are massive, but when it is spotty, small calcifications less than 3 millimeter, it is a sign of subacute inflammation at risk of complication. And the positive remodeling, also the increased diameter at the level of the plaque, is also a feature at risk. It is important to acknowledge the limitations of CTA, particularly in patients with calcified arteries, but also in the patients with borderline stenosis. And in these patients, CTA may fail to define a patient management strategy alone, and functional tests may be required. These functional tests are all validated versus the invasive gold standard measurements of the fractional flow reserve. And the most widely used ones are stress echo and stress SPECT. Stress CMR is also very efficient. It's important to also mention that some of these functional tests may be performed at CT. We do not have a large experience on that, and these methods are less performed than echo and SPECT. But still, it's doable to explore perfusion on CT, either using a non-dynamic or a static or a dynamic perfusion CT method. There's also one approach that is currently being made available by one company that relies on the segmentation of the coronary arteries and then the computation of the fluid dynamics within these arteries. That gives access to a computation of a virtual fractional flow reserve. This has been validated in a handful of studies, and of course it's lacking randomized control validation to be integrated in the guidelines. So before going to the question on who should benefit CTA versus other techniques, let's see how does CTA compare to other tests. When it is assessed on anatomically significant CAD on invasive angio, coronary CTA is the best method, both in terms of sensitivity and specificity. But when compared to functionally significant CAD, to invasive FFR measurements, then CTA remains the most sensitive method, but critically lacks specificity. For that reason, CTA is rather to be used to rule out coronary artery disease than to rule in coronary artery disease, and may be reserved to patients with rather low pretest probability as compared to functional tests. In fact, that's how the most recent EAC guidelines are built. The first step is to compute a pretest probability of CAD based on age, gender, and symptoms. This pretest probability has been updated as compared to the previously published ones. And what's important in there is that it's not only focused on chest pain, but also includes dyspnea. The second step is to potentially modify this pretest probability based on the findings from the additional findings from risk factors assessment, ECG, TTE, and potentially with the adjunction of exercise ECG and calcium scoring. And then when the clinical likelihood exceeds 15%, non-invasive tests may be indicated for stable chest pain. Now the question is which test to select between stress tests and a coronary CTA. Coronary CTA will be preferentially considered in low clinical likelihood, so typically below 50%, in sites who have expertise, obviously, and in patients that have no history of CAD and no characteristics that suggest that imaging will be challenging. For instance, severely obese patients or arrhythmic patients may be rather selected to go stress testing. Stress testing should be considered in patients with higher clinical likelihood and also when viability assessment is required, obviously. So there's room in these ESC guidelines for a selection of the appropriate tests also based on local competencies. Some other societies are favoring CTA as a first-line method, using a much more radical and simpler approach, only based on chest pain characteristics and not on the computation of pre-test probability. This is what the NICE guidelines in the UK advocate. So the first step is to assess the chest pain characteristics, and then all patients will undergo CTA except patients with non-anginal symptoms and normal ECG. And the functional tests will only be reserved to patients with inconclusive CTA results. So to conclude, why does it matter? This is the story of a 46-year-old woman who was referred for stable chest pain in our institution. Unfortunately, she didn't undergo any non-invasive tests. She went directly to coronary angio, and the coronary angio was negative, but she experienced a iatrogenic dissection of the left artery, which was treated by a rescue PCI on a marginal CX branch. So this is the results of the CT 1 week after she was admitted, showing a flap, a dissection of the left artery, a patent CX stent, and this is the late iodine enhancement demonstrating that she has a large area of scars related to myocardial infarction. So this is why it matters to use non-invasive tests, CTA or functional tests, in patients with stable chest pain. So the take-home message, shouldn't all the guidelines be nice?
Thank you, Professor Huber, and I think it is also it is a great talk again, and we can actually, I think we already convinced using like CTA is maybe the first one. However, we have a short question before we move for the next presentation. So you mentioned that CTA is something like to rule out the coronary artery disease. So okay, we agree on that. But if the patient came back again, and how frequent you agree to do the CTA just to rule out? Because sometimes.
Yeah, several times. Yeah, all right. Yeah, that's complicated. You're right. You're right. I wouldn't repeat a CTA every week in a patient that claims to have chest pain, obviously. But you know, most of the medical decisions are also based on common sense. So I'm not sure whether the guidelines should mingle into that. But you're right.
Yeah. Okay, so we will come back later for discussion part. And so now we move to the last presentation before we jump into the discussion. The last presentation will be given by Professor Olivier Razet again about how to choose the CMR for chronic coronary syndrome and how to interpret it.
In this presentation, I'm going to talk about the choice of cardiovascular magnetic resonance imaging to explore chronic coronary syndromes. So this is my disclosures. And I could start by showing you this meta-analysis about more than 15,000 patient, showing that the best technique to explore coronary artery disease is probably the PET, but we already saw that the PET is not a widely used technique and is not available in clinical practice because of the price and because of the difficulty to obtain the perfusion tracer. So if we compare just SPECT and MRI, this meta-analysis show that the MRI is better than the SPECT. And there is a lot of studies showing this kind of result, and this is another one. And what is really funny in this study is that the area under the curve is not exactly the same that the previous one. And all the time, if you compare a new technique to the old one, and we already saw that the SPECT is the oldest technique and the widely validated technique. If you compare the new one, you will have better results than the oldest, because all the time the team who are comparing the technique are comparing with a team that are not so good in the other techniques. So that's why all the time when you bring a new technique, you can show that you are better than the other because you choose the comparator. And I think that's to say which is the best technique is not the goal, because in practice, and if we read the last guideline from the European Society, the choice will be based on the availability of the technique and on the local expertise, and this is probably the most important, the local expertise to give you the best result. But there is another important parameter. Obviously the choice of the patient, but the patient characteristics are really important. And I'm going to try to give you some aspect of the patient characteristic that can lead to the choice of the CMR to explore chronic coronary syndromes. So there is two ways to explore myocardial ischemia using CMR. The first one, it's the same than using a stress echocardiography. It's to study the stress wall motion. And you can see on the left, a normal wall motion at rest. And during the stress, using dobutamine, typically, you can see that there is abnormal inferior wall motion. But in practice, it's pretty hard to use this technique because you have to administrate dobutamine in patient inside the MRI, and we know that when we are doing echocardiography, that can be really challenging for the patient, and it can be really uncomfortable for the patient in the MRI to have dobutamine. So in practice, it's not really performed, but the technique has pretty good results with good sensitivity and specificity. The second way to explore the ischemia, it's to explore the perfusion, and you can see in this presentation that there is a perfusion defect of the inferior wall there. But because we cannot see really well in this kind of screen, I put some details there of the perfusion imaging. The goal is to administrate gadolinium within the blood, within the vessel, within the vein, and the gadolinium is going to arrive in the right ventricle and then to the left ventricle and then to the coronary artery. And you can see that there is an increase of the signal inside the myocardium, and you can see there is a defect of perfusion in the inferior wall. And this is typically the technique to explore the perfusion using MRI. And the perfusion has better results than the perfusion has better result than the wall motion, with a really good sensitivity and the pretty good specificity. And if you consider the prognosis, and you have on the left the dobutamine stress MRI, and you have on the right the perfusion stress MRI, you see that there is really good prognosis if you have normal stress MRI, and the prognosis is not good if you have abnormal stress MRI. But you have pretty the same results using both techniques. But in practice, we already saw that if you want to explore coronary artery disease, the most useful technique is probably to explore the perfusion, because the perfusion arrive at the beginning of the disease, and so the perfusion is more sensitive to detect and to explore patients with chronic coronary syndrome. So in practice, most of the teams are using perfusion imaging in the field of MRI to explore chronic coronary syndrome. So when to choose a CMR to explore patients with chronic coronary syndrome? I think that the advantage of the MRI over most of the other technique is the high spatial and high temporal resolution, allowing this kind of image with a really high resolution, and we can see that there is a kind of asynchronism of the left ventricle. And the second advantage of MRI over, for example, echocardiography, is the really high spontaneous contrast here without the need of gadolinium, and this allows perfect quantification of the cavity of the myocardium. And that's why I think that in practice we should use this technique for patients with a cardiomyopathy with a suspicion of coronary artery disease, because in practice we can explore the chronic coronary syndrome, and we can explore in the same time the cardiomyopathy. And here I put an example of hypertrophic cardiomyopathy. But in this kind of patient, if I have a suspicion of coronary artery disease, I can, if, for example, this patient have dyspnea, I can explore both the cardiomyopathy and detect coronary artery disease. So I think that MRI is really useful in this kind of patient. But maybe the most advantage of the more powerful advantage of the technique is to be able to explore small myocardial infarction, so to detect silent myocardial infarction and to quantify this kind of myocardial infarction using late gadolinium enhancement, as you can see in this picture. And why MRI is better than the other technique? It's because MRI is able to detect really small myocardial infarction, where SPECT will not be able to detect this kind of really small myocardial infarction. And we know that in a patient with a lot of atherosclerosis burden, we can have a small myocardial infarction without wall motion abnormality and without SPECT abnormality. And in this case, MRI will be able to detect this kind of infarction. And this kind of infarction will not be detectable using ECG, standard ECG. I mean that if you look at this presentation, you will see that in red, there is a patient with a non-Q wave myocardial infarction. And in this patient, myocardial infarction was not known previous to the stress test. And you can see that there is an increase of the prevalence of myocardial infarction with the extension of the coronary artery disease, and there is the same with the extension of the degree of stenosis. So the detection of unrecognized myocardial infarction can be really helpful to better detect coronary artery disease, and even disease without stenosis and with really active atherosclerosis without coronary significant stenosis. And this kind of unrecognized myocardial infarction will have an impact on the prognosis, because patients with no myocardial infarction will have a better prognosis than patients with myocardial infarction. And that seems obvious, but this is the reality of the practice. And this is because we know that all patients with late gadolinium enhancement and with previous silent myocardial infarction will have late gadolinium enhancement. And we know that late gadolinium enhancement worsening the prognosis. And that's really important because MRI allows the exploration of the coronary artery disease, I mean the functional impact of the coronary artery disease, but MRI allows also the quantification of small infarction using leg gadolinium enhancement. And this kind of infarction have a really high impact on prognosis. So in practice, we will be able to detect small subendocardial myocardial infarction, and sometimes we will be able to detect transmural myocardial infarction. And what it's important to remember is that allow the quantification of the variability, because the variability and the improvement of contractility, I mean the recovery after revascularization or after medical treatment, is proportionate to it's inversely proportionate to the extension of the leg gadolinium enhancement. And for example, if there is more than 50% of leg gadolinium enhancement, we know that there is no myocardial variability, and we know that patients will not recover, and the contractility and the wall motion will not be improved after a revascularization of medical treatment. But there is limitation of the CMR. The first limitation, and we saw that, is that when we can do exercise, it's always better to perform exercise. But in MRI, it's hard to perform exercise. And I show you here a picture of a patient who exercise just before the MRI. But we know that in practice, this is really hard to perform. And in my practice, I'm not performing that because it's pretty impossible to put a bicycle, for example, inside the MRI to do the exercise. So in practice, we can do only pharmaceutical stress, and we know that pharmaceutical stress is not the best stress. And the last limitation is probably the ferromagnetic artifact. And in patients with, for example, a pacemaker or automatic implantable defibrillator, we know that we can have this kind of artifact. And in this case, we are not able to see the heart. So if we cannot see the heart, we cannot explore the perfusion. So to summarize, I think that CMR is have pretty the same performance than the other ischemia test. And I think the performance is not the question. I think that CMR can be of interest in intermediate risk patients in whom the discovery of unrecognized myocardial infarction can impact in the management and in the prognosis. And I think, and in my practice, I'm using it like that. CMR is of particular interest in patients with cardiomyopathy, either hypertrophic or dilated cardiomyopathy, to rule out ischemic involvement. So thank you for your attention.
I thank you again, Professor Olivier, for the great talk about the CMR. I just have a very short question for this part. So basically, you mentioned that CMR is important for the patient to detect the small evidence of the myocardial infarction. So actually, is there any study to compare the CMR and with the CMR plus the optimal medical treatment?
No, as the previous study showed by Professor Cochet, no, to my knowledge, there is no study showing the potential medical impact of this discovery. But we know that this discovery decreased the prognosis, worsened the prognosis. But to my knowledge, there is no study showing that we can improve the prognosis by giving the specific therapeutic like statin and aspirin.
Yeah, so we have quite a few questions from the local audience, and the first question from the local audience that asking about which one of the imaging modality can predict best for the acute coronary syndrome. So we start with Professor Olivier Lager first.
So I think that the question of the acute coronary syndrome is totally different, because theoretically we should not perform non-invasive imaging, and theoretically we should go directly to the invasive coronary angiography. But in some cases, the patients arrive and they don't have, I mean, life-threatening condition, and they are pretty stable. And in some cases, in young patients, we are not suspecting acute coronary syndrome, but we are suspecting the real term should be acute myocardial syndrome. And I think that in this case, MRI is probably the best tool, because you can detect, you can make the difference, for example, between acute myocarditis and acute coronary syndrome. So MRI, I think it's a really good tool when there is kind of chest pain in the young patient, where we are suspecting acute myocardial syndrome and not acute coronary syndrome. And in this case, MRI can say, okay, this is not from a coronary artery disease. This is typically acute myocarditis. But theoretically, we should not use non-invasive imaging in this kind of patient.
Maybe the question I explained a little bit not very clear. The question from the audience is that the emerging modality for chronic coronary syndrome, not only for, you know, like to give the diagnostic, but also to predict the future. So which one can predict acute coronary syndrome? So yeah.
So that's a really good question, and if we could reply to this question, that could be really great. So in practice, it's impossible to predict acute coronary syndrome, and there is a lot of research on the plaque imaging to predict the instability and the inflammatory part of the plaque. And there is a lot of work with the PET-CT, because the PET-CT, there is kind of, if you use fluoride, you can predict the instability of the plaque. But nowadays, we cannot predict the instability of the plaque. But if I have to choose a technique to predict the instability of the plaque, but Hubert will be better than me to respond to this question, I think that the CT is the best tool to explore the atherosclerosis burden, the plaque composition, and to not predict, because we cannot predict, but maybe to better assess the atherosclerosis burden.
Yeah, thank you. So how about your opinion, Professor Hubert Couchet?
Yeah, the high-risk features of the plaque that I've shown in my presentation were validated in the context of acute coronary syndromes. So it's in patients with NSTEMI, you have time to perform a CT to rule out coronary artery disease. And in this study, it was designed so that after a first negative troponin test, before the second troponin test, there was a CT performed to potentially rule out. And then they found that these napkin ring sign, this low fatty content of the plaque or spotty calcifications were predictive of a final diagnosis of MI to a similar extent as the stenosis itself. But it's in the context of acute coronary syndrome. If your original question was in stable coronary artery disease, do we have means to predict which plaque will fracture? We don't. And I remember Professor Finet from Lyon, who had a great slide of a patient who had been explored with intravascular ultrasound 5 times in his life, and each time the plaque at risk changed. And in the end, he eventually ended with having a plaque rupture and a myocardial infarction on a plaque that was never categorized during the 5 tests as being at risk. So I think, yeah, there are things we can do and things we can't do.
Yeah, thank you. So how your opinion, Professor Edvan Donan? Yeah.
Actually, I don't have anything to add. I think that CT for sure is the best tool to best assess the coronary artery anatomy. So functional stress testing is interesting, but will never predict an acute coronary syndrome. It's a way to predict symptoms in the future, but not acute coronary syndrome. So if you want to assess the prognosis. It's true that using nuclear techniques and echo, we have a large amount of data showing that if you have a normal stress test, for instance, you have a best prognosis that if you have an abnormal stress test, but it makes sense, actually. It's clinically evident.
Okay, this is a great answer. The next question came from the local audience asking about the micro circulation. So the question is, which modality is the best tool to accept the micro circulation of the coronary artery? So
Not CT. I'm out of this one.
Yeah. So how about Professor Olivier Lazier?
So in practice, the best technique is the PET. The PET allow the quantification of the perfusion, and the PET allow the absolute quantification of the myocardial blood flow. But the issue is that the perfusion tracers are pretty hard to obtain, are really expensive. So in practice, they are not really widely used. But there is an alternative now, and I show that in my presentation. We can assess and we can quantify the myocardial blood flow using SPECT. And but to perform that, we need a specific camera, which are the new CZT semiconductor detector, and that allows the dynamic quantification of the flow. And by comparing the stress blood flow and the rest blood flow, we can quantify the coronary flow reserve, and the coronary flow reserve reflect the whole coronary artery tree. I mean the macrovascular and the microvascular coronary tree. So I think that for now, nuclear medicine techniques are probably the best.
So how about your opinion, Professor Edouard Donan? So you mentioned about the strat echo. So is there any new index like coronary work or the regional strain to predict the microcirculation impact?
No, I think, yes, we can assess the consequences of a microvascular disease, but the fact is that we don't have any treatment. So I will not have too much to add. I think Olivier told us that it's true that nuclear techniques are probably more powerful to see these defects. But according to the treatment, except the statins, I don't know what can we do. So it's still an unresolved issue, according to me.
Yeah, we have another question from the local audience about the moderate lesion. So, for example, like when patient came in to do the angiogram and you have a moderate lesion and you have some abnormality in the other tests, so how the other tests to help you to decide the way to go? So we started with the Professor Olivier first. So if you have a moderate lesion, so how the scintigraphy or CMR to help you to decide the treatment modality?
So you mean for the treatment of intermediate coronary stenosis? Yeah. So in my center, for example, I'm going to tell you, in my center, if you find an intermediate lesion, that means that you perform an invasive angiography. So in my center, in practice, if you find this kind of lesion, you are doing FFR. And so you assess the functional impact of the lesion using invasive stress test. That's why I will say that, and I don't have to choose between echo, myocardial perfusion using scintigraphy or CMR. But if I have this kind of lesion without the FFR, if I have to choose between the different tests, in practice always I prefer a test which is gonna use the exercise. So in my practice I'm using a stress echo using exercise, or stress myocardial perfusion imaging using a scintigraphy. But I don't mind about the technique. I prefer to focus on the stress, and for me the best stress is to perform exercise.
Yeah. Okay. So we back to the Professor Edouard Donan. For example, like if you have an intermediate lesion on the angiogram, and then you have the stress echo inconclusive or not very clear, strong positive. So what should you do at this moment?
Actually, this is a discussion with the interventionists. And usually when we discuss with the interventionist, we go for an exercise stress echo, except if the angiographic want to treat the lesion. If he believes that he has to treat the lesion, then he will probably go to a scintigraphy because the sensitivity will be greater. If you don't want to treat the lesion, he will go to the stress echo to increase the specificity. That's true, Olivier.
I know you're right. I know you.
It's how it works in our institution.
So in fact, I mean, we also want to listen to the opinion from Professor Hubert Couchet. So if you have a intermediate lesion and with the big burden of the, like a calcium, so that's why you have you cannot read very, you cannot. The image on the CT is not very clear due to the burden of the cancer. And now you have an intermediate lesion. So what should you do at this moment?
Oh, so you mean an intermediate lesion on CT and not in the cath lab? Okay. Then I will tend to, it's a question of availability. I'm a radiologist, I'm doing CT and MR, so the MR is next door. I will use the MR and I will do adenosine stress MR. But if you have an intermediate lesion, I guess it's not a correct answer. I would do that for personal reasons. But if the patient is symptomatic, you may want to have a physiological stress using exercise to reproduce the pain while you're imaging to relate the symptoms to a given stenosis. Because MR is so powerful that it can also detect abnormal perfusion that are not related to symptoms, So yeah, I would rather make either SPECT or echo, but with a real exercise test.
Yeah, we still got a comment from the one local doctor asking about the frequency of the CT angiogram. So, for example, like if you have an intermediate lesion or negative CT angiogram, and after 1 year, the patient came back again with the chest pain. So, should we repeat the CTA or you choose another modality?
I think when you read the guidelines, you have the pretest probability that is only, or the ESC guidelines, I mean, you have the pretest probability that is based on symptoms and age and gender, but you have also modifiers to assess the real clinical likelihood of CAD. And having a normal CT 1 year ago decreases this likelihood dramatically. So I guess we would be far below the 15% that qualify for any non-invasive test. And I would not do any, if you have normal coronary arteries on a CT from last year, I would not redo the CT. If it's an intermediate lesion that you found last year, then that's different. And I would go back to the prior question. I would do an exercise test with an imaging, either scintigraphy or echo. I don't know if it's...
Yeah, and I think this is the question from our local one. So I think we came into the last question. If you have a patient came in with a stable angina, which modality you choose first? So we back into the Professor Olivier Lager. Which modality of imaging you choose first for the stable angina patient?
So I think that if I know that this is typically a stable angina, and if there is that means that the patient has symptoms, and I know that the patient has coronary artery disease. Actually, I will go directly to the invasive angiography to be able to perform revascularization. So in practice, I'm not going, because I think that angina is a kind of stress test. I know that this is clinical ischemia. So if I consider that the symptoms are related to coronary artery disease, I know that the patient has coronary artery disease. And in this case, I'm going directly to the invasive angiography in order to offer revascularization in my practice.
Yeah, thank you. So how about you, Professor Edouard Donan? Which one you choose first?
So, of course, it's a clinical question, so it's difficult without having the ability to discuss with the patient. But if we are convinced that the patient has an ischemia and is severely affected by the chest pains, then I will go to the coronary angiography. If I'm in doubt, I will probably use the scintigraphy first to localize the ischemia and then to guide the coronary intervention. If I'm not convinced by the symptoms, I will do a stress echo and then I will move on according to the result of the stress echo. It's really a matter of discussion with the patient and the likelihood that we will find something.
Yeah, thank you. So how about you, Professor Hubert-Couchet?
Well, if the patient has a stable chest pain that is not known to have coronary artery disease, if he does, I would go for echo and scintigraphy or an exercise test, the most available one. But if he doesn't have a known coronary artery disease, I think I would focus on the pain, and this is what I like in the NICE guideline from the UK, is that it's really focusing on the characteristics of the pain. I will, if this chest pain is has a high likelihood of coronary artery disease, I would probably tend to go for a functional test. But if it's intermediate, I will do a mix between the ESC guidelines and the NICE guidelines. So if I don't believe he has coronary artery disease, I would do a CT, and if I do believe that he has a coronary artery disease, I would do an echo or a scintigraphy.
Yeah, I think we have a great discussion, and the time is move on very fast, and actually we still have a few more questions, and we hope that we continue the discussion through the website portal for that. We need to close the section now, and I think I would like to express my great sincere thanks to all of our delegate, Professor Olivier Lagier, Professor Erwan Donan, and Professor Hubert-Couchet. You spend a lot of time at the weekend to join with us and to share your expertise. Thank you very much again, and we hope that we can see you in the next congress or the workshop. Thank you very much again, and
thank you for the invitation.
Bye.
Thank you. Have a good weekend. Bye. Thank you.
Bye.